customers from across India and the world have been leaning on us for over 75 years. Bluestar, built on trust.
Welcome to the 8th edition of Bluestar Presents Healthcare Radius Smart Healthcare Summit powered by Polycab. Healthcare is undergoing major disruption. The COVID-19 pandemic placed enormous strain on hospitals and healthcare professionals, but it also inspired innovation and collaboration across the sector. Going forward, technology is set to transform medicine. This virtual summit will discuss where Indian healthcare is going in terms of infrastructure, innovation, and investment. Healthcare business leaders and policymakers will consider the challenges, opportunities that come with the rise of remote care, the evolution of hospitals, the growth of partnerships, and much more in a series of insightful panel discussions and keynote interviews. I would like to thank our partners, presenting partner Bluestar, powered by partner Polycab, associate partner Wipro, hygiene partner Diversey, hospital partner Sir HN, Reliance Foundation Hospital and Research Center. This event is brought to you by our magazine partner Healthcare Radius. Healthcare Radius was launched in 2012 by ITP Business India. Healthcare Radius is a monthly publication for Indian healthcare professionals. We highlight best business practices, analyze key trends, and outline business moves and risks of healthcare majors across the country. We are the industry's platform for debate and its guide to the latest and most promising trends in planning, strategy, technology, and management practices. Without further ado, I would like to invite Vibhor Srivastava, Country Head, ITP Media India, to kickstart this event.
Distinguished panel members, ladies and gentlemen, good morning. Thank you for making time out of your busy schedules to join us this morning. I would like to start by wishing you and your families my personal best for your health and safety in these difficult times. I would also like to express my profound gratitude to all of those doctors, nurses, and workers who are serving so selflessly on the front lines of this health crisis. This is a crisis like no other. Despite the extraordinary uncertainty, we can chart a path forward. And today, we'll be addressing this very aspect, future of healthcare. As the country head of ITP Media Group India, I take pride in welcoming all to the 8th edition of Smart Healthcare Summit hosted by Healthcare Radius magazine. Smart Healthcare Summit is one such platform where we bring together stakeholders from different sectors to discuss very relevant topics. The 8th edition of Smart Healthcare Summit is focusing on the future of healthcare and the role of smart hospitals. Global emergencies like the COVID-19 pandemic place intense pressure upon our healthcare community. However, smart hospital innovation is one of the critical support factors that will enable global healthcare industry players to overcome this crisis. With healthcare undergoing a period of digital transformation, the summit will look at the importance of modernizing healthcare delivery with a focus on healthcare providers and patient experience. A glance through the agenda planned for the day reveals that the amazing topics and eminent panel members who will discuss this very germane topic. I am grateful to the many experts who have come to share their knowledge. Some occasions provide unique opportunities for change. Such chances must be grasped while they are here. If not, there may be years before opportunity reappears, or it may never happen again. Digital transformation is one such chance. We must make the most of it. I hope the summit will help you understand the subject matter better, and we genuinely hope our next generation of hospitals will benefit patients and staff alike. I'm sure you will have fruitful and rewarding exchanges in the next few days. I wish you every success with this important conference, and I look forward to learning about the outcome. Ladies and gentlemen, ideas are worth nothing less unless executed. This highlights the importance of partners who support us in executing ideas. I would like to thank our partners Our presenting partner Bluestar, powered by partner Polycab, hygiene partner Diversey, and lighting partner Wipro Lighting, and Sir H. N. Reliance Foundation Hospital, who have collaborated to bring together this forum. It is my absolute pleasure to invite Mr. P.V. Rao, President and Chief Operating Officer, Electromechanical Projects and Air Conditioning Solutions Group, Bluestar Limited, to present the welcome address. P.V. Rao is a mechanical engineer with an MBA in Marketing and Postgraduate Diploma in Industrial Relations and Personal Management. He's also done the Senior Executive Program from London Business School. He's the life member of the Indian Society of Heating and Refrigerating and Air Conditioning Engineers, popularly known ISRE, and the past president for its Hyderabad chapter. He currently represents Bluestar Limited in CII as a member of the State Council of Maharashtra. In this successful career spanning around 35 years, he has held various roles in many divisions and functions in various geographies and has built a result-oriented leader, not only running operation, but also driving transformation and change management. Ladies and gentlemen, I invite Mr. Rao to present the welcome address. I encourage you to pay attention to the discourse and participate as required, and I trust that our speakers and panelists over the course of the day will help to enlighten all of us and stimulate us to action towards reimagining the healthcare ecosystem. Over to you, Mr. Rao.
Thank you very much, Mr. Bibor, for the kind introduction. Good morning, ladies and gentlemen. A very warm welcome to the Smart Healthcare Summit. It's indeed a great pleasure and privilege for Bluestar and for me personally to be associated with this event. Curating the summit on smart healthcare is indeed apt at this point in time when accessible and sustainable healthcare is the need of the hour. My best wishes to the organizers, ITP Media, for their efforts, and to all the participants in making this event a grand success. Taking this opportunity, I would like to give you an overview about my company, Bluestar Limited. Bluestar, with a rich pedigree of over 77 years, has a global footprint and serves many markets around the world, both in the field of HVAC&R with a comprehensive range of air conditioning and commercial refrigeration systems and solutions, and also in the design, execution and maintenance of large and integrated mechanical, electrical, plumbing systems and projects. Our deep domain knowledge in these arenas has not only enabled us to ensure seamless and superior installation, execution and after-sales service, but has also made it possible for us to support and endeavor innovation and sustainability of the highest levels. Over the last 7 decades, Bluestar has been associated very closely with the healthcare industry in providing commercial air conditioning systems, commercial refrigeration systems and solutions for healthcare facilities including hospitals, research institutes, labs, etc. We offer end-to-end solutions starting from design to after-sales service. Some eminent names that we have been associating with include Apollo, Hinduja, Fortis, Zydus, Sir H. N. Reliance Foundation Hospital, Dr. L.H. Kiranandani Hospital, Sri Gangaram Hospital, etc. The list is endless. With the healthcare landscape currently under enormous pressure, today's summit is an important step in terms of finding innovative solutions in designing hospitals of future. Of course, alongside, there are a few fundamental challenges to tackle. First and foremost, there is a critical need to allocate and attract significant investments in building adequate healthcare infrastructure and to be able to extend the reach by providing healthcare support to the farthest points in the country with equal efficiency and speed. Secondly, the challenge of meeting the deadlines for the facilities to open on time. While there are multiple building services that have to work in tandem for timely completion of a project, we at Bluestar undertake the whole range of mechanical, electrical, plumbing and firefighting services to ensure superior and on-time delivery of projects. The third challenge is with respect to the running costs. At Bluestar, we have come up with systems which are energy efficient and are highly reliable. We have also come up with systems which are built for Indian climatic conditions, which are indeed severe and for Indian power and voltage conditions, which tend to be erratic, especially in tier 3 to 5, tier 5 towns. I'm proud that through our products and solutions, we are significantly contributing towards building a robust healthcare ecosystem in India. We have introduced smart technology products, the VRF air conditioning systems, which significantly brings down the installation time and delivers a faster project completion. ACs with special air purification filters such as Living Guard, and ducted air conditioners with UVGI, ultraviolet genocidal irradiation. Our mortuary chambers installed in good numbers across the country are instrumental in upholding the dignity of the deceased. Recently, we rolled out new products such as vaccine transporters and Iceline Refrigerators, which are ideal for storing vaccines. Our commercial refrigeration product portfolio includes an array of modular cold rooms, medical freezers, ultra-low temperature freezers, pharma refrigerators, and blood bank refrigerators. We have also been representing brands for CT and MRI systems. And apart from all this, we offer gold standard after-sales service and also provide remote monitoring services. Our expertise and extensive knowledge is also reflected in the fact that we have published a guide that enumerates the specific design requirements needed for air conditioning hospitals and healthcare facilities. In closing, I would say that we are indeed delighted to be associated with this wonderful industry and would be more than happy to partner with you as you scale greater heights. I wish each one of you an exciting day and also a great year ahead. Thank you. Thank you, everyone.
Thank you, Mr. Rao, for kickstarting the 8th edition of Bluestar Presents Healthcare Radio's Smart Healthcare Summit powered by Polycab. We now move on to the next session, a keynote interview, Future of Healthcare, the role of smart hospitals. This session will be moderated by Professor Dr. Sanjeev Bhagat, Chairman, Nephron Clinics, Padma Shri Presidential Awardee, Dr. B.C. Roy Presidential Awardee. We will also have in the panel Mr. Mohandas Pai, Chairman, Arun Capital and Manipal Global Education. Professor Dr. Sanjeev Bhagat is a multifaceted individual of international repute who has garnered immeasurable prestige and honor for his highly distinguished and meritorious work as India's foremost pediatrician and pediatric nephrologist, and an astute health administrator. He delivers international standard world-class healthcare with uncompromising commitment. He was awarded Padma Shri for his valued contribution. Professor Dr. Sanjeev Bhagat is the chairman of Nephron Clinics and was the former vice chairman of Manipal Hospital, Dwarka, New Delhi, and the third largest healthcare network in India. Mr. T.V. Mohandas Pai. Over a career spanning 37 years, T.V. Mohandas Pai has served in the area of finance, accounting, information technology, human resources, education, corporate governance, social impact innovation, environmental conservation, policy formulation, heritage preservation, philanthropy, and the venture and startup ecosystem. He was awarded the Padma Shri Award by the President of India in 2015 and the Karnataka Rajyotsava Award in 2008. Mohan is currently the chairman of Arun Capital, chairman of Manipal Global Education. I welcome you both.
Good morning, everyone. I thank the organizers for having me and Mohan on this inauguration panel discussion as a keynote discussion. It's a novel concept of rather than having a one-way information decimation, rather than now having a discussion with perhaps, and in my very honest and respectable view, India's one amongst the finest minds, not only in finance, not only in administration, but a holistic global view in healthcare and well beyond healthcare. I welcome Mohan. Wonderful to have you as always.
Thank you, Doc.
the reason of having this summit on more on digital technology and this inauguration keynote debate, as we call it, or a discussion, is to highlight a few key points, and then we'll dig straight into the discussion with Mohan. I think everyone knows that India has just 2% of the global landmass and 21% of the disease burden and 20% of the global population. There is no occasion more than this pandemic which has actually laid open the cracks of deficiency in public health care and a huge deficiency in digital technology or even the routine technology, especially in tier 2, tier 3 cities and towns, where even till date, handwritten notes and handwritten bills and no electronic medical records are maintained. 75% of Indian healthcare we know is private, but unfortunately still till date, more than 80% of this 75% is in the unstructured segment of 20 to 50 bedded hospitals. What we are looking at is as follows. We want digital technology to form a backbone of our hospital and medical educational systems and medical tertiary, secondary and primary healthcare systems to give us what? To give us clinical excellence, operational excellence, staff nurses excellence, a better patient experience, above all standardized care with patient safety being the core and data assimilation. Mohan, a lot of people set up hospitals. A lot of people take over hospitals as acquisition. What would be a message of a person who approaches an investor or a bank or a fundraiser as to going digital? What would be his pitch? What would he tell the investor? Because this is the key. If you don't institute the digital technology in the early phase of building your institution, it's very often too late. Mohan, over to you.
Doc, thank you for inviting me. Doc, my personal view is COVID has taught us a very important lesson in all facets of our life. Reimagine the future. The future has changed. The existing model we have is the model of the industrial revolution, which is physical with people and everything else, and with the supply chain, which is not digital. Now reimagine everything so that you can come on to the digital way of doing things, and the digital revolution is here. That's the most important point. So if I have to talk to people who are setting up an hospital, I will tell them, first ask the question, why should anybody come to a hospital? Now we come to an hospital for OPD, to meet a doctor. We used to go to the neighborhood clinics, but they don't exist anymore, so we are forced to come to a hospital. We come to a hospital when we are in deep pain for investigation. We come to a hospital for admission. We come to a hospital for surgery. And we come to a hospital when we are in serious trouble for something else. Now, if you look at the entire gamut and deconstruct every single thing that forces you to come to a hospital and use technology, you can reimagine the hospital of the future. For example, OPD. Why should people come to an OPD? Now, they could come to an OPD, and the OPD can be in a neighboring, in a neighborhood at a small place. People don't have to come to a big hospital and crowd the place because travel costs, everything is there. Doctors don't have to travel. And then when people come to an OPD, the most important thing is data. You make a physical check, and today there are devices which people can carry with them in the phone, or apps which measure your blood, you measure your heartbeat, which measure many things that are required to make a diagnosis. So we got to look at how to make them technologically savvy and educate them. Second, we have to make sure that we can do video conferencing and talk to everybody. Doc, you know that research proved that only 35% of a specialist time is occupied. The rest of the time they are not occupied. We got a lot of specialists. I don't know, even for you, it will be a very high percentage. And this physical interaction occupies too much of time. So why can't we have video, which is now allowed in this country, to talk to doctors and use the remote diagnostic tools in an app or in an IoT device or whatever it is to do something. For example, we have a company called Dozy, Doc. And what Dozy does it puts a mat with a lot of IoT devices under the bed. It captures your data real time, puts it into an app on the phone, and then by doing predictive analysis, they're able to predict 30 days ahead whether the heartbeat pattern is such that you could get an attack. Why? Because they got an enormous amount of data. 80 to 90% of everything that happens to us is a pattern. And that's why you can do a diagnostic. Because when you see the symptoms, you know what it is. So there's a pattern, and you learn the pattern. And the next thing is, when people come to a hospital, why should they remain in the hospital for a long period of time? You know that, the ICU is very critical, very expensive. How do you make sure people don't remain in the ICU? Can every bed becomes an ICU using technology? And then can we have non-invasive surgery? Non-invasive surgery for many things in neighborhood clinic with robots or other things, with technology available. Can we do a full body scan using low cost equipment? So exactly you know what is there in the body, what is happening. And can you make sure that you use more technology to do a predictive analysis so that you know what is going to happen and you can catch things very early. If you're able to catch things much earlier, you know, doc, that you can prevent a lot of stuff. And the last point is we must make sure by using all these digital technologies, we have a 360 view degree of the patient. Because about 70% of medicines are useful, 30% because the DNA has possibly mutated and everybody's DNA is not the same. And we have all this data with us. So my view, doc, is reimagine the hospital of the future. Create a operating system where the data is gathered and everything is available to you. Make the life of the doctor much more productive. Reduce the need to go to hospital. Reduce the need to invade your body and cut you up all the time. And make sure that wellness becomes a large part of whatever program you have for future. And people can afford to pay. And another thing is, you know, doc, that today 13% of India is more than the age of 60. In Japan is 35%. We must prepare for the time when aging is a real issue. You know, the UN says that the population which is supposed to be 11 billion by 2100 will only be 9.6 billion. So we have big issues ahead of us and pandemics and things like that. So reimagine.
Wonderfully put, to be future ready. So just to put in some statistics which Mohan has so beautifully weaved into a magnificent story, which we will build on very quickly going forward. With this digital technology, we can have better clinical results in terms of clinical outcomes, increasing it by 42%. We can have a better diagnostic to reduce the error by 30%, a better discharge process by 40%, a better bed utilization by 50%, including the ICU and the OT occupancy, decrease the A loss by at least 1.2 to 1.3 days per patient admission, and more importantly, decrease hospital-acquired infection. So I think the gains are so overwhelmingly numerous that it makes only common sense. I always say that digital technology is never an expenditure, it's an investment, because you can drive an ROI which is equal to any other investment in healthcare. Mohan, we know that we are short of doctors, we are short of beds, we are especially short of specialists. You have very importantly pointed out a lot of the Indian population in the Indian subcontinent is in inaccessible areas. I know your institutions and many other good institutions in India and indeed worldwide are progressing very rapidly on telemedicine. What would be your thoughts in having a separate department, like we have cardiology, we have gastroenterology, neurology, orthopedics, oncology, have a separate department of digital healthcare and telemedicine as a separate vertical so that it can be tracked more immaculately? Mohan, over to you.
Doc, to me, this is a great point. I think, brilliant. To me, there are two things. One, the IMA, the Indian Medical Association, should have a training program how to create a digitized portal or use digital technologies in the ordinary work of a doctor and train them up. And then they must make a search of all the apps and technologies available, create a repository so people know what is available, and make them in contact with the doctors who manage clinics and hospitals. And the second thing, which is extremely important, is we must now create a healthcare system based on digital technology so that every person has access to good healthcare at home, in the primary clinic, in the district hospital, and in this here. And in the medical colleges, you must have a separate department for digital technologies, because the medical college, the way of education has not changed for more than 200 years. You know that. Why can't we have a department of digital health technology so all the doctors who are trained know what is there, know what to do that? I want to ask you a question. Now, you spoke about the shortage of doctors and nurses. What about the productivity of the Indian doctor, of a doctor? The model is the Industrial Revolution model. Now, can we increase the productivity of a doctor by 50%? Can we increase the productivity of a nurse by 50%? And once you're able to do that, by reducing the unproductive work done by the doctor, Now you spoke about, discharge. It's a nightmare in all hospitals.
Yeah.
Doctors come for the visit. They have to write down. It goes somewhere else. They have to make a bill. They have to do everything. That problem has to be solved. If all these problems are solved, doctors' productivity will increase. I want to ask you, what is your view about increasing doctors' productivity so that doctors can help more people and lower the cost?
Yeah. So a few quick points in this. This is one of the core areas which is actually a thorn not only in doctors and the administrator's life, but in the patient's life. So a doctor typically comes in at 7 o'clock or 8 o'clock or by 9 o'clock, sees the patient, chalks out the discharge medication, talks to the family, explains for follow-up, and then it goes through various circles in the hospital, which includes the resident doctors, junior resident doctors, data entry operators, the typists, then into the billing system in the ward. It then finally goes down into the billing for the on the ground floor or the first floor, which is the main hospital billing. Then the patient has to go down. Then there are errors, and then it goes through the TPA. The TPA takes good 6 to 8 hours for the bills to be cleared. There are queries. Then the queries are sent back. So by the time the patient goes back, it's close to tea time or dinner time, and the patient forgets the good work of the doctors, the life-saving surgeries, but he has a very sour taste in the mouth because he's been made to wait, which is, needless to say, completely avoidable. Doctors would probably be able to free themselves for about 2 to 3 hours minimum every day. I think going forward, the hospitals should have a publicized promotion campaign time that teleconsultation would be between 1 and 2 or between 1 and 3, which is the weakest part of our OPDs from physicians' point of view. A lot of screening and a lot of initial work can be done. A lot of the paperwork is redundant now because once you have it initially filed in, everything is there. All you need to do is systematically compile it, which the computer does for you. The discharge process will be a lot quicker. In real time, the TPAs would be able to capture the diagnosis. All the errors would be, process would be error-free. More importantly, we will avoid not only hospital-acquired infection, we will avoid human errors. There is a beautiful handbook written by WHO in 1999, which the initial first chapter is written as to err is human. And the third leading cause of death worldwide in late 1990s, early 2000s was medical errors, human errors. Now, if this digital technology can decrease the human errors from 11% to less than 1%, that itself is proof of pudding that this technology is not only worthwhile, but is life-saving. I couldn't agree with you more. I think doctors can use the time much better. Patients would be a better comfort zone to go home quicker and will remember a hospital experience not as a terrible experience, but something which was good, it was useful, it was time-bound without any delays. Now, coming to the health education part, because you're deeply linked also with the health education, not only in India, but globally. Being through myself through government medical colleges in Bombay and then subsequently trained in various parts of the world, the Indian healthcare educational system needs to go through what I say is a sugarcane grind. It needs to churn itself out completely. New dress, new face, new outlook, new perspectives altogether. None of the medical students pay attention to what we call as preventive and social medicine. I think that should not be put into a dustbin subject. I think it needs to be beautified so that people take more interest in it. Your thoughts on that? The second is MBBS doctors are perhaps worldwide, not only in India, extremely poor in critically analyzing not only research papers but data. And we don't have any course in our educational system, which is our backbone going forward, of what do you do with regards to computer analytics. It's not difficult, but even a 3 months rotation, compulsory rotation, would be critical because this will shape the future of the doctors going forward to post-graduation and beyond. Over to you, Mohan.
Doc, you hit the nail on the head. We have to produce a different kind of doctor. Now, let us understand one thing. In this country, the most brilliant minds have been going and becoming doctors. They are the top of the pyramid. They are brilliant. That's why they shine all over the world. They're the best of every generation. Even today, your generation, they were the best. There's no doubt. Even today, maybe, the top 5-7% want to become doctors, right? And it's a very, very hard grind for them to become doctors. Now, the important thing is, are we producing doctors for the 21st century? The answer is no, because the circumstances in which the doctor works has changed. So we must reorient the system of education. First and most important, like we said, there must be preventive medicine and wellness inculcated into the medical thing. Now, if you look at traditional methods of medicine before the Western method, allopathy came into being, they're all based upon the bodily, improving the bodily function, the bodily response to disease, right? And building up immunity. So we must focus on the preventive to make sure a doctor becomes a friend, philosopher, guide for everybody who takes care of the total wellness, the health of his patients or the people who come to him for advice, and is seen very differently, not a person who cures an illness. A person who works with you as a coach, as a mentor to make sure that you lead a healthy life. And that's important. I think that's a very important part of it. Second, we must reorient for them to make them thinkers and problem solvers. See, I think we're giving them too much of information. See, the time was in the Industrial Revolution where a few people read the big books. Then you had all of you go there and they had to talk to you and explain to you because you are not read the books. And they were all in big fat books, which are expensive. Not all that information is available electronically. Everything is available electronically. If you are the doctor have a doubt, you can go put a query and 100 great doctors will give it to you. You can search, you have the facility. So you must look at the content and reduce the content and look at those content which is important for make them think. For example, diagnosis is very important even today. Even if it's electronic, you have to diagnose because that is where your application of mind is there. And that is where the diversity of the disease or the condition can be seen by you and you can learn. Even though 70-80% may be a pattern, there's still something to be done. Now there, can you make sure that you learn medicine from the end output? Suppose a patient comes to you. Take an example in the first year itself. And you have to make a diagnosis. What are the things that you'll see? Why you will see it? What is the reason for seeing? Then what are the symptoms of various diseases? Symptoms of various things. And then go back to theory. Can you reverse it from theory to practice to little bit more practice to learn theory? Because people understand the theory much better when they see its implication in real life. Now, third, very importantly, much more peer learning than a one-way broadcast. See, in medical education, there's a one-way broadcast. There has to be peer learning. We did an experiment in our Antigua Medical College where we get Americans and we train them to be doctors. We created groups of 10 and gave them the topics and they had to study and come and discuss and learn. And we had a tutor going around and helping them. The achievements was much more because it was interactive and it was, much more involved. Now, you must get the students involved because the students are curious. That curiosity is what makes a great doctor. Even today, you read 3 or 4 hours a day. You're very curious why things are happening. You write so much, you teach so much. Why is that? Because you're curious. And the curiosity is there with you. How do you retain the curiosity? And the last point, the examination system should be changed.
I agree.
The examination system should be more based upon your ability to carry out your functions, not your ability to write an answer to a problem given in an examination. Absolutely. That is the easy part. Now, how good are you in actual life? That means, doctors should come and evaluate, doctors should come and do a work. We got to change everything. Because like I told you, Doc, and I'm sure you agree, this is the old model. We are in a different world. The world has changed, but the method of education has not changed. I think we got to reorient. And lastly, reduce the cost. I mean, the cost of medical education in India, 50, 60 lakhs, 1 crore is astonishing. And why is that? It's there because there is too much of input being given, unnecessary details being given, unnecessary infrastructure being given. How do you use existing infrastructure? How do you reduce the cost to make it much more affordable so that if I pay 1 crore as fees, Doc, I want to earn the money back in 5-7 years. It compels you to do something very different. Now, it's true, government gives education for 45-50% in the country at a low cost. That's very true. But there's another 55% of private sector, but there is no subsidy. You have to pay. And the true cost of medical education, nearly 1 crore per student per year today. You know that, right? And whether you and I pay as taxpayers, as somebody pays, somebody is paying. Why don't we reduce that by using digital technology? We have to reimagine the education process to create the doctor for the future.
Absolutely wonderful. Few very, very quick points. I have so many things to cover with you because this topic itself is so beautifully magnificent. We have to move away from the 3 A's, which is affordable, accredited, and accessible healthcare, which is a given. We have to have those. We have to move now towards more precision more personal, primary, preventive, predictive, and proactive healthcare. What is your take in the hospitals taking the lead, the private hospitals at least taking the lead, in having sensors as devices as a protocol? One, for tracking the patient. Two, for all monitoring. You can reduce the manpower by 32%. Resident doctors and the nursing staff, which go in and out of the rooms, increase the risk of infection, errors in reading, human errors, then tabulation, then entries. It can be done through simple sensors and devices, right from temperature, pulse, respiration, saturation, blood pressures, movement disorders, for Alzheimer's, for dementia, for Parkinsonism, even to predict impending AIs, means MIs, heart attacks or strokes. What is your take in which hospitals can actually make it as a given protocol? These devices are extremely cost effective now. Indian devices at least are extremely cost effective, and the patients can go home with the device. All the data is gathered, and then when they come to the hospital, they have the 1 month data of all blood pressure in a serial chart, rather than doctors having a Holter monitor, repeat ECGs, and ongoing investigation. Mohan, over to you.
Doc, you just given the vision of the hospital of the future and healthcare of the future. I'm totally with you. But to expect private hospital and doctors to change the way of working is not possible. Let me say it very clearly. The biggest impediment to reforms in education is the faculty. You can't change the faculty's attitude in 1 month, 2 months, 3 months. It takes 5 to 10 years. Yeah. They have to change their attitude. They have to adopt. They have to unlearn, etc. What I would suggest is private hospitals should align with startups who are giving all this kind of devices and monitoring, maintaining, and giving you the data. Partner with them and ask them to come and look at what they're offering and ask them to give it. For example, ICU, DOSI, like I said, your ICUs can have this IoT bed beneath every bed. And then you don't have to be in ICU. You can be in your house. You can be in your room instead of the ICU, because ICU is extremely expensive. Half the people don't have to be in ICU because you're just monitoring. And the monitoring can be done remotely. And one nurse can take care of maybe 5 to 7 patients. And you made a brilliant point. By getting the data for 1 month with devices which are easily available, either on your mobile phone through an app, like you get from Apple, or putting some devices, wearing it like, wearing it rings all in your body, or keeping it attached to your body, you can get the data sent remotely. And if you're able to do that, you can predict with a great degree of accuracy what will happen 30 days, and you can prevent this. You can prevent the deterioration of the body. All these things can be done. What is important in my view, Doc, reimagine the hospital of the future. Write it down in the form of a protocol in the book. Maybe you should take the lead in this country because you're so brilliant. And publish that. And talk to the Indian Medical Association. I'm sure they'll ignore you. They will rubbish you because they don't want to change everything. And then talk to a few hospitals who can do that, because hospitals are very worried about the bottom line. A lot of the hospital work is unnecessary, is a wastage of resources, and the costs are very high. People can't afford it, right? You know what happens. And then reimagine it. And then there are many entrepreneurs who want to set up hospitals of the future, create a protocol for them. And if we're able to do it in a substantial way, we can see a change in maybe 2030. Wonderful. Because we need partners. You see, a hospital by its own lacks the technology capability, the monitoring ability, the maintenance ability to do that. So they should align with startups who are doing all this. And these startups can take care of all that and feed into the doctor, and also help the doctor understand. So in 1 or 2 years, they can transform themselves into a digitally led hospital, which gives better care and much better output than earlier.
Excellent. In fact, some of the institutions overseas already have a separate vertical called as behavioral AI. So a person's behavior predicts his future illnesses or good health. I'm touching now an area of on digital technology, area of a hospital which is always considered as a backbencher, but for me it's one of the most important departments in a hospital. How does technology reshape human resources? How can human resources tap into the energies, work synergistically with technology to decrease manpower, to increase productivity, correct allocation of the required resources at the correct places, seamlessly integrate resources? I mean, there are hospital chains who have duplicated the resources in a radius of 5 kilometers, 10 kilometers in different hospitals, which becomes cost-wise and structurally counterproductive. Over to you, Mohan.
Doc, that is a very brilliant thing. Today, we're all victims of processes.
Beautiful.
Processes are important to have certainty, repeatability, etc.
I want you to, Mohan, repeat that what you said.
Today, we are all victims of the tyranny of the process.
Wonderful.
Victims of processes. Many of the processes are antiquated, done at a far time, and things were very different. They are different. So I think we are victims because processes are required. Because processes ensure repeatability, certainty, and accuracy. They are important. We cannot do away with that. But are the processes important in managing a hospital and doing everything? For example, the human capital cost of a hospital is extremely high compared to what was 10 years ago. We had to pay people more, people cost more, living has become expensive, all that is a necessity. Now, are they productive enough compared to 10 years ago? The answer is no. Productivity has just not kept pace with the expenses. We're still following the old model. So if you look at all the hospital protocols and processes, we can eliminate a lot of it and increase productivity by maybe 25-30% and reduce unnecessary work. The next is reimagine the process and automate the process to the maximum extent using IoT devices, using technology, etc. And look at areas which take a lot of human people where closer contact is required and see what can be done to change, right? If we're able to do all that, we can increase productivity by another 15-20%. And then we also have to make sure about where exactly we need to put infrastructure, how much is the infrastructure used in various areas. For example, very costly equipment like robotic surgery can be localized and we can have a center only for robotic surgery. And all hospitals can be a partner. You don't have to set up the equipment. High quality MRI machines which cost 25-30 crores can be kept in one place and the usage can be done. If you look at expensive equipment in hospital, the usage is very low, but the costs are very high. And then ordinary causes, do you really require a person to come to a hospital for that? Or can it be digitized on an app and you can take that very easily, right? So you got to centralize the costly equipment so people can be ferried. Because we always had a problem, and the old problem, should the doctor come to the patient go to the doctor. Now doctor came to the patient earlier. Now the patient has to go to the doctor.
Absolutely.
Now both are not efficient. Can the patient see the doctor remotely? That is much more efficient. But for that you require data, you require everything else. And the last point which you have to do is, after we do all this, we must write on a document about the new process, the new way, and train people and see what has to be done. And then you will find very clearly you don't require 1,000-bed hospitals.
Absolutely.
You require in a big city, maybe a 500-bed super specialty hospital. Then you need smaller rings, centers all across the place, closer to people. So the doctor is closer to the doctor's residence, closer to people within any ward. So much of the work can be done there and much more work can be done at home. Why should people come to hospital at all? And then you will find that costs will come down. People will become more healthy and productivity will go up. It's a question of low productivity because of high cost.
High cost. Last two points of discussion and quickly, Mon. There are so many that, my God. Your take on human body being different at different age groups. Our own genes evolve, they mutate. There is a newer concept now which COVID has brought up called as Immuno Aging. That means as you age, your immunity goes down. So there's a different concept now in medical literature known as Immuno Aging. And everything depends and revolves around genomics. It is not uncommon, even in my own practice, to see huge amount of patients who are taking multi-drug antituberculous medicines, multi-drug anti-epileptic medicines, and none of them work. The reason is those drugs are genetically not susceptible to that patient. So their patient is going to continue to have symptoms going on. Wasteful medication, side effects of medication, and excess stress for ongoing condition deteriorating into complications for thousands and millions of patients. Hospitals must have a separate department of genomics, at least the larger hospitals. And this can be a share model with other hospitals without any conflict of interest so that we don't duplicate it. Genomics doesn't come cheap at the present moment. But I always give an example of Hepatitis B vaccine. In 1992, when it was launched in India, a vaccine cost, one shot cost 1,600 rupees. Today it costs 44 rupees. So once you go forward with the scale of volume, the cost is going to come down. Hospitals having a department of genomics integrated with AI, because this is going to predict how your body is going to respond to which disease, to which medication. Mohan, over to you.
Doc, that is another very futuristic thought. Why can't we have a genomic map of every individual? Today, we can do by using a DNA samples, you can create a genomic or a DNA sample of everybody. All of us are constructs of various parts of DNA. And like you said, all of us are very different. Maybe 70% have same characteristics, 30% are different. If you happen to be the 30%, you're in deep trouble. So much of medicine, so much of diagnosis goes waste because your body responds very differently. And like you said, at different points of time in your life, your body responds very differently. Now, we got to map all that. And the starting point should be done by creating a DNA profile of every individual. For that, a centralized facility, multiple centralized facility, and that can be stored. And then we know from data, a large number of cases, what will work with what DNA profile. And we can read the DNA. And the DNA can be read. The costs have come down very little. I think it's just about $100. And if we do it for crores of people, it may come down $10. And we can do it as a service to everybody. And I think everybody should get the DNA profile. You need companies which will create DNA profiles of individuals and read it out and push it to a database. And the data has to be stored by every hospital or in a central database where individual can store. So when I come to you with my genetic makeup and you have a look at it and you have a technology or an application which will study that and give you the input so you make a better diagnosis. That should be the starting point. Now, diagnosis is important, interpretation is important, but there is its own limitations. I think we should go to the next level because we are data. I'm a collection of data. Now, the data can be many things, yes, my behavior, my thinking, etc. But physically, I'm a lot of DNA in my body, and the DNA maps are available. You start with that, then you can have gene therapy, which is tuned, and you can reduce so much of wastage, like you said, Doc. That is a new, pot of gold.
Absolutely. It reminds me of a saying before I go on to the last point of discussion with you is, absence of evidence doesn't mean evidence of absence.
Yes.
So I think you need to scratch to see the surface below. 20 years back, 15 years back, when I was the first time CEO of a hospital in Delhi, the president of the hospital told me, these are fixed costs, don't worry about it, in the annual review meeting. And I got very insulted and humiliated that why is a cost being taken as a fixed cost? That means you've already taken for granted that you can do nothing about it. I'm touching 3 points in this, in my last point of discussion. And I actually appointed a night guard to switch off the lights in the corridors. And I was again humored that you're wasting money with extra duty of a guard. But that was cost saving for me. Now going forward, that was 15, 18 years back. Why can't technology be used for smarter use of energy? Lights, which can also be medical lights, energy for electronic devices and medical equipment as cost saving. And now COVID has brought on a huge factor, which we call as ventilation and ACs, be it hyperfiltration filters, be it HEPA filters, be it ultra filters. How can these 3 verticals be harnessed with technology? 1, to give you better clinical results, lower grade of infection. 2, how can we save money by integrating this into what we call as an enterprise bus in which all the verticals plug in. This is something which is not a fixed cost.
The first or second point new products and revenue.
Over you to more.
Doc, I think that's a brilliant point again, because this kind of a fixed cost bogey, in the long run, everything is a variable cost. There is no fixed cost. Let's understand that. The fixed cost is there because you think it is a fixed cost, like you just gave an example. Now, we must re-examine all kind of a fixed cost and see how to make it more variable.
Correct.
Because if you are able to make it much more variable based on use, you increase efficiency, you reduce the cost substantially. Today, in terms of energy efficiency, any new device you buy today is 30 to 40% more energy efficient than 10 years ago.
Absolutely.
In Infosys, we started a drive to reduce energy, to increase energy efficiency. We're able to cut down our energy consumption by 50% in 6 years. And what did we do? First, we replaced all equipment more than 7 years, especially the AC system.
Correct.
Second, we make sure that we improved our practices so that energy consumption is limited to the period of use, not dead load, where dead load has to come down. And the third, we made sure that we had new technologies which reduce the need for energy. And the fourth, we went into alternate energy. We went into alternate energy to make sure energy cost comes down. Just to give an example. Now, if you look at equipment also, much of the equipment earlier was all analog. Now it's become digital.
Yeah.
And digital is much cheaper. So if you look at the state-of-the-art equipment today, they're all digital. Of course, some of them, like in robotic surgery, Da Vinci and others, still have a monopoly. That monopoly has to be broken.
Yeah.
But that, Doc, what we need is a grand challenge for the young people. We should have a grand challenge to say,
Absolutely.
Here is 10 pieces of medical equipment, which is very expensive. And these are the specifications. Why don't you come with a new device, reimagine a new device, which can do the same work at much lower cost? Why can't you do that? Let us challenge the established order. I was speaking to a person from GE, who used to run GE Medical in Bangalore, a brilliant man. And he was telling me, they created a MRI device in India, which was 1/10 of the cost in the US.
Absolutely.
And they were brought on, their boss told them Jack Welch told them that you got to do it, man. People can't afford to buy it. So how are they able to do it? They reimagined the entire thing. And with new technologies today, with something like LiDAR, where you can have X-rays going in and checking a thing, full body scan. So many things are there in AI. And the use of AI will make sure that you do things right the first time itself because you have a lot of data. And then you can do 3D printing. See, Doc, today by 3D printing, you can create body parts, heart parts. You can create so many things which are very cheap, right? And they can be done. And you can get a digital profile of an individual and then do what has to be done. So, Doc, it is a very exciting field. The only limitation we have is an ability to think. So I would suggest you in closing that please write down all your thoughts, write down everything, reimagine the hospital and healthcare of the future, what has to be done. And you should become a person who talks about it and inspires people. And then also, Doc, talk to a lot of startups. See, why do I talk about startups? These are young people who don't have a legacy problem. So they don't know. They look at problems new. They come with the latest technology because they're very adapted technology. And they give you a solution which is so very cost effective and which is so very simple to use based on the reimagined hospital. But you should work with them.
In the end, thank you, Mohan. It's been absolutely exhilarating. I always enjoy a session with you because it's like peering into another person's mind. There's an old saying, give me some data and I'll give you some information. If you give me all the data, I'll give you the world. I think the world now has to work on data. The hospitals have to work smarter, not only digital, but digitally smart. And I hope people would have enjoyed this session and take this forward. Thank you, Mohan. It's been absolutely wonderful. God bless you. Keep well, keep safe. Thank you, the organizers, for having both of us.
Thank you, Doc. Thank you. Thank you.
Thank you, Professor Dr. Bagai and Mr. Pai for the insightful discussion. Moving on to an interesting presentation by Senthil Tangam, Senior General Manager, Commercial Air Conditioning Products and Solutions, Bluestar Limited. He will also be accompanied by Ayas Kanta Jena, Senior Manager, Commercial Refrigeration Business Group, Bluestar Limited. Before we have them on screen, we have a brand AV by Bluestar.
Customers from across India and the world have been leaning on us for over 75 years. Bluestar, built on trust.
So good morning, everyone. On behalf of Bluestar, I extend a very warm welcome to everyone for the Smart Healthcare Summit. Bluestar is the largest HVAC company with over 8 decades of experience. We have come out with many breakthrough products which have set global benchmarks. Now, let me take you through some of the key innovations in design, technology, and automation of Bluestar, which is in line with the theme of the event in the last decade. To begin with, let me take you through some of the very key innovations of Bluestar on that design part. We all know India is a tropical country where the temperatures are certainly much higher than most of the other countries. Now, what happens is most of the products what we buy, which are of international repute, will be designed only for 35 degrees centigrade. Here in India, the temperature easily crosses close to 40, and coupled with the urban heat effect, the temperatures can reach even up to 43 degrees centigrade. So what happens in such situation is there will be a phenomenal drop in the capacity of the systems and abnormal rise in the power consumption. Bluestar was the first company to introduce the VRF systems, which is capable of delivering 100% capacity even at 43 degrees centigrade. So the benefit for the healthcare customer is you get full capacity without any duration, even at 43 degrees centigrade, and phenomenal drop in the power consumption. Not only that, we know India has a challenge with the power. The quality of power is one of the most challenging part in the country today. We all know that especially in the tier 2 and tier 3 towns, the power fluctuations can be phenomenally high. Most of the air conditioning systems operate only between 380 to 415 volts. So what happens is for most of the time, the machines and the systems may not be operational even when the voltage is at 360 volts. So knowing the conditions, Bluestar came out with VRF systems which is capable of operating from 320 to 460 volts. So what happens is even when the fluctuation is phenomenal, Bluestar systems can function without tripping. So that is the key benefit for the customer even when the power fluctuations is abnormal. Again, for healthcare, there are many special areas like ICUs and operation theaters where the fresh air requirement will be very, very high. So you cannot go with the conventional indoor units of VRF like wall mounts or cassettes. You will be forced to design a specific air handling unit which is capable of handling huge fresh air. So Bluestar again was the first company to introduce the AHU kit, which can integrate a large AHU up to 32 ton with the VRF systems. So today, when a customer in healthcare wants to completely go for a VRF system for a hospital application, he can easily go with Bluestar's 5th generation VRF systems. Now, there are many hospitals and healthcare facilities which will opt for, again, chillers. We have the same challenge of ambient conditions, and the quality of water, again, coupled with quality of power is again a big challenge. So knowing this challenge, we have actually now come out with a very innovative mix and match design. In simple language, if I have to explain, we don't have any standard models of chillers now with Bluestar. The customers can choose the kind of chillers what they want, which is tailor-made for them. That means the compressors, the coolers, the condensers, everything can be selected based on the ambient conditions of the site, based on the efficiency requirements of the customer, based on the power challenges in that place, based on the water challenges in that place. So you can customize and make a chiller which is tailor-made specific for that application. So what happens is you get a chiller which is very highly efficient, which is not only going to surpass the international standards like AHRI, but it can even meet the Indian chiller standards, which is likely to come next year in India, and it can even meet the advanced Indian chiller standards. And what more, this can be proved in a lab which is of international repute. The largest AHRI facility in the country is available with Bluestar, and the performance of all these chillers can be tested in India's largest lab available with Bluestar. at our Vada plant. So we have seen what all innovations we have brought in. So let me move to the next part, which is automation. We have seen phenomenal developments in the field of HVAC automation, and Bluestar was instrumental in innovating and introducing many new technologies of automation in the country. So let me take you through some select automotive innovations what Bluestar has introduced in the last decade. To begin with, for a large VRF kind of installations in hospitals, you have a central controller or a Wi-Fi based controller. Now, using these controllers, you can operate the entire facility from a single laptop or with your smartphones. You can actually switch on, switch off, you can adjust the temperatures of any part of the premises from the Wi-Fi based controller. Now, moving ahead, the next advancement is the mobile app control. That means you don't have to even be in the premises itself. You can be anywhere in the country. You can still see what is happening in the premises. You can switch on, you can switch off, you can regulate the temperatures. Even if there are some errors or some issues, it can be reported in the mobile app, which can be used for transmitting the message to the customers. So such is the advancement in the controllers what we have for VRFs. Now, for VRFs and chillers, we also give the Bms integration. In simple terms, you can integrate the air conditioning systems with other services of the hospitals like lights or lifts or access control or fire control. Completely it can be integrated. So the customer can completely control the whole building from one controller. So that is the benefit the customers will get. Now the next is the most innovative introduction from Bluestar, which is the remote monitoring system. Today, the biggest challenge is there are hospitals and healthcare facilities coming in tier 2 and tier 3 towns. The biggest challenge is you don't get the quality manpower for doing the after sales service. So to overcome that, we have come out with this remote monitoring system where we collect the data from each and every systems located anywhere in the country and integrate it with our remote monitoring center based at Thane. Now we have a team of experts and panels who will be monitoring the system performance throughout, and they can communicate with the local service team. So in case of any issue, this is completely transmitted through GPRS, and even the nature of the problem can be monitored from these systems, and those informations can be given to the team which is doing the service in the local sites. So what is the benefit for the customer? We all know that hospital and healthcare is a very critical application. So the response needs to be very quick. So it is very much possible with this remote monitoring system. Not only that, we also know the exact nature of the problem. So the team going there will be well prepared to handle the kind of issues what is there inside. Hence the turnaround time will be very, very fast, resulting in very, very quick kind of uptime of the system. And finally, the quality of service, even in tier 2 and tier 3 towns, will be fantastic with this kind of backup from the experts based in our Thane center. Now, let me move on to the third facet of this presentation, which is the technological innovations introduced by Bluestar. Let me start with a basic fundamental part of the commercial air conditioning segment, which is the ducted systems. For a very, very long time, the industry was operating with the traditional reciprocating technology, and Bluestar was the first company to introduce the scroll compressor technology in the year 1995, which gave a whopping 10% power savings compared to the traditional reciprocating systems. And Bluestar did not stop there, and we continued our technological innovation. And in 2003, we came out with the next higher version called tandem scroll compressor technology, which actually helped the customers to save further 15% power. The next innovation of Bluestar came in the year 2008 in the form of high performance packaged air conditioners, keeping in mind the kind of rising ambient temperatures across the country, which has resulted in 20% power savings. Then finally, in the year 2016 and 2020, we came out with different generations of the inverter ducted systems, which are almost a replica of the advanced VRF technology in a simplest format, which gave a further 25% power savings. So you can see the kind of technological migrations which has helped in phenomenal power savings for the customers. Not only in the ducted systems, even in the chillers, we had a lot of migrations in the technology. We had in the year 1995 the conventional chillers, then we moved to the mix and match chillers in the screws. Further, the next development is the VFD, variable frequency drive chillers, which we introduced in the year 2015. And also the next advanced version is the oil-free chillers. Now you can see the kind of benefits for the customers when the technological innovations happen. Way back in 1990, 1995, when we used the conventional chillers, you can see the kind of integrated part load values. IPLV for air cooled was somewhere around 4, and for water cooled it was around 5.7. That actually moved, and you got a phenomenal improvement in the kind of efficiencies when it was moved to the mix and match kind of series. You can see a big jump in the efficiencies. And finally, when we shifted our gears to the VFD chillers, you can see a further phenomenal kind of savings in the integrated part load by another 25-30%. You can see the water cooled version jumping almost close to around 100% kind of savings, and in the case of air cooled, you can see a 50% kind of savings from IPLV of 4 to 5.5 plus, and then 5.7 moving to 10.4. And the final version of the latest advanced technology is the oil-free version, where the IPLV is now at 11.3. The IPLV at 11.3 translates to some 0.29 kilowatt per ton. That is all is the power consumption of a water-cooled chiller, which was actually somewhere close to around 1 kilowatt sometime back in 1995. So that is how the benefits of technology has helped the customer to bring down the running cost. So here we are having a basket of products for smart hospitals, giving you phenomenal benefits. Some key benefits are the products offered by Bluestar are specifically designed for Indian conditions. Hence, it can withstand the kind of challenges of ambient temperature or power or even the water quality. So it is tailor-made for Indian conditions. And you can decide and design a model which is specific for that particular site. It is not some standard range which is available, which we have to pick and choose. So that is another benefit what the customers get, and it meets all the international efficiency norms and even the Indian efficiency norms, and hence the customer is going to get the lowest power in the industry, the lowest power consumption, resulting in lowest running cost, which is going to help the customer. Then we have seen the host of advanced remote operations, automations available, which is going to not only monitor, control the system, but also do the after-sales service. You can integrate with the third-party BMS, which is going to make the life easier. It also complies with the green building norms, because some hospitals may go and apply for some green building norms. So it is going to comply even with that. And the systems are made to be very sleek and compact, backed up with fantastic 24/7 after-sale service, going to make Bluestar as the best choice for hospitals. So I once again thank all of you for sparing your valuable time. And I would now request my colleague Jana to take over and give a brief on the commercial refrigerant products. Thank you once again for sparing your valuable.
Thank you, Senthil sir. Good morning, all of you. I am Iceline Jana from Bluestar, representing Commercial Refrigeration Business Group. Talking about the manufacturing process, we have the 5 state-of-art manufacturing facilities located at Dadra. Himachal, we have 2 facilities, Wada, Ahmedabad. In order to meet the future demand, we are in a process of setting up another factory at Wada. Coming to research and development, we have high level of product development and testing capabilities with several patents. Our lab are DSIR approved. We focus on energy efficient and sustainability. We have enhanced capability in developing digital and smart products. Our electronics labs for product development are NABL accredited. Some market insight, We feel privileged in having our market leadership in storage water cooler, deep freezer, and modular cold rooms from past many years. Coming to medical refrigeration, Bluestar is a one-stop shop solution provider for all medical refrigeration needs, starting from blood bank storage, vaccine storage, and vaccine transportations. We have a wide service network across India with 24 into 7 assistance and with the added advantage of service on wheels. Our entire product range meets with high quality ISO standards and are C certified with latest technology. Coming to pharmacy refrigerators, the features are precision temperature control 2 to 8 degrees C, 360-degree ventilated air circulation for temperature uniformity, two-layered glass door with clear visibility with a door heater switch, and audio-visual safety alarms. We have the capacity to 60 liter to 1200 liters. These products are C certified and ISO certified also. Coming to Iceline Refrigerators, these products widely being used for vaccine storage and distributions. The features are temperature control to 8 degrees C, audio visual safety alarms, hold over time 20 hours. If there is no power, it can hold the temperature with accuracy for 20 hours. Puff insulation 110 mm. We have two capacities in this, 150 liter and 275 liters. These products are C certified, PQS and ISO certified. Coming to vaccine transporters, vaccine transporter is used for transporting vaccine from one place to another by maintaining the temperature accuracy. The features are temperature control 2 to 8 degrees C, audio and visual safety alarms. It has a DC compressor. That means it works with a 12 volt to 24 volt in any vehicle to transport the vaccine from one place to another. It has a low noise. Capacity is available at 20 liter and 50 liter. These products are CE and ISO certified. Talking about ultra low temperature freezers, we have wide range of temperature control over here, starting from minus 10 degree to minus 25 degree, minus 10 to minus 40 degree, and minus 40 to minus 86 degree. These products have audio and visual safety alarms. Also, the features are data recording through USB. We have the facility, the data recording for 55 days to 365 days. We have efficient compressors. We have wide range of capacities in these product segments, starting from 90 liter to 1008 liters. These products are CE, UL and ISO certified. Coming to modular cold rooms, the features which we have are the eco-friendly green cyclopentane panels, cam lock with metal plunger locking, SS304 evaporator body with inner grooved copper tubes, energy efficient pre-charge condensing units. These products are thereby enhancing standard of healthcare, catering to wide range of temperature requirement at various touch points. Coming to mortuary chambers, the features which we have is the multi-door systems, telescopic GI carriage with SS trays, modular design with rooftop refrigeration system, and cyclopentane as blowing agent. The models we have with 2 body, 4 body and 6 body, also these products are C certified. Coming to service and after sales support, we have gold standard customer service network, more than 2100 plus centers across India. Some of the key customers are ILBS, Bharat Biotech, Apollo Pharmacy, Bms New Delhi, Indian Railways, BMC Mumbai, IRCTC, OSMC, Ministry of Health and Welfare, and many more. Thank you for your time. Thank you.
Thank you, Mr. Tangam and Mr. Jena for an interesting session. Before we move on to our next session, we have an exciting announcement for all the delegates who have taken out time to be a part of the 8th edition of Bluestar Presents Healthcare Radius Smart Healthcare Summit powered by Polycab. You will see quiz questions on your respective screens. Do participate and stand a chance to win smart home automation products by Polycab Home. With this, I would like to introduce panelists for our inaugural panel discussion on designing hospitals of future. Dr. Bishnu Panigrai, Group Head, Medical Strategy and Operations, Fortis Healthcare. Dr. Panigrai contributed significantly to the strategic growth of Fortis Healthcare through the channel of medical strategy, quality, training, and education. His visionary outlook in establishing Fortis's clinical leadership in the areas of clinical outcomes, patient safety, infection control, and research is well respected across the industry. He put Fortis on the international forefront of clinical outcomes by becoming a member of the ICHOM Steering Committee for the Coronary Artery Disease. Dr. Panigrai has a distinctive experience of 39 years, out of which 12 years was an educator and 27 years was in the corporate world, where he worked with Indraprastha Apollo, Fortis and Max Healthcare. Dr. Panigrai is presently Group Head, Medical Strategy and Operations at Fortis Healthcare Limited. Pardeep Sood has over 2 decades of extensive experience working in healthcare infrastructure projects for various organizations in India, besides working 10 years in hardcore industries. During his healthcare tenure, he has worked with healthcare companies like Fortis, Max Healthcare, JP Healthcare and Radiant Life Care as part of the infrastructure team that set up chain of hospitals for them. He has worked with Fortis for 11 years and instrumental in setting up chain of hospitals starting from Mohali. Mr. Sood is presently working as President Infrastructure and Hospital Projects with Indo-UK Institute of Health to set up 11 medicities across India using futuristic smart technology in designing and building hospitals. Dr. Prabhu Vinayagam is a highly accomplished and resourceful C-level executive with rich experience backed with a Bachelor of Medical and Surgery, MBBS, MAMC, and MBA in Marketing and Operations from SP Jain, Singapore. Change agent and self-motivated P&L leader with proven success in transitioning strategy into tactical action plan for maximized revenue growth and market penetration. Business advisory role working in tandem with CXO level decision makers in credit organizations with tremendous results. He was the managing director of the Joint Commission International Asia Pacific and has been instrumental in providing accreditation for almost 80 hospitals in Asia Pacific region. He is currently the Group CEO of Family Mandalar Group of Hospitals and advisor to the Yashoda Group of Hospitals, Hyderabad. Shashi Amin, currently working as Executive President and Chief Business Officer, Cables Polycab India Limited, which he joined in 2011. He has diversified experience of more than 32 years in the field of sales and marketing for cables and wires business with various reputed companies. Recognized as one of the key industry leaders and has been closely associated with IEEMA, where he also served as chairman of Cables Division during the period 2018 to 20. Mr. Amin has been instrumental in development of cables and wires industry in India. Bhagat Singh is a Bachelor in Engineering in Mechanical from PSG College of Technology, Coimbatore. He has over 25 years of experience in the HVAC field and joined Bluestar in 1998. He also had a 7-year stint in Dubai handling MEP projects between 2004 to 2010, including the world's tallest tower, Burj Khalifa, Dubai. Bhagat Singh has played a vital role in development of many breakthrough differentiated products like configured series screw chillers, oil-free chillers, inverter scroll chillers, VFD screw chillers, etc. Bhagat Singh is also a member of ISH, RAE and RAMA Committee for Star Labeling Program, Bureau of Energy Efficiency, Ministry of Power, Government of India. This panel discussion will be moderated by Kaustubh Chatterjee, who is experienced healthcare strategist with a demonstrated history of working in the management consulting industry, public speaker, and an innovation evangelist. 3 times President's Club member, award winner. Over to you, Mr. Chatterjee.
Good afternoon, everyone. Thank you so much for joining. We are going to talk about a very important topic today, which is how to design the hospital of future. And when we talk about future, the aspect of incorporating smart principles into hospital infrastructure is an imperative concept. We have a very distinguished panel with us who will contribute with their individual expertise and background in this particular concept, such as designing smart hospitals of future. In this particular track, we have 7 different aspects to cover. And one of the key areas that we will focus at the beginning is how to prepare, plan, and procure for a hospital system that can incorporate smart hospital principles. And I would like to start with Mr. Pradeep Sood, Vice President Infrastructure at Indo-UK Institute of Health, to share his experience in how to prepare and plan for a smart hospital based on his vast experience building similar capabilities within India and outside.
So, thank you, Costa. I will take up now the problem we have faced in previous conventional technologies is we always faced problem with the timelines. There is no consistency of inequality. There is too much dust moving around in the hospital, even during construction, and it takes a lot of time to commission it. And there is a problem of flexibility in spaces is not there in the existing hospitals. So these are the 5 parameters: faster timelines, no more timeline overruns with high degree of certainty, better and consistent in quality, less dustier site, and ease of space utilization with minimum disruption to meet ever-changing healthcare environment. I have been in hospitals for last 20 years, and this environment is changing drastically, and which is basically is leading to create facilities which is flexible in nature. The hospital which we made 20 years back used to have 1 or 2 transplant room. Now it is, you will find every hospital will have many flooded with transplant procedures, and all the facilities are there. So these are the aspirations every management has. They should come to the market fast with faster techniques which we can use for delivering the project. So there should be high degree of certainty on the timeline. So we should not face problem of the overrun of the timeline. So the problems in quality we should not face, which will basically impact the commissioning of hospital. The quality should be better and consistent. So it should be cleaner, and the space which whatever we are designing should be flexible to take care of changes in utilization of the existing spaces. So now for that, what all we need to do, conventionally we used to construct the building with concrete. Now basically this is leading, all these questions leading to a modern way of building hospitals. So I will concentrate more on the building, and IT and other things will be taken up by other panel members. So there's a conventional way of doing construct the building with concrete, and it takes a lot of time. Nowadays there are technologies available. We can construct the building with prefab structures and steel. So these works are done with a very high degree of quality, and with simultaneously it can be done at off-site locations, and we can get the project on time. So existing the old construction methodologies of brick or mortar walls are being replaced nowadays with modular concrete walls, wall panels, or with gypsum panels. So For faster things, we need to increase the utilization of tiles instead of gypsum, because both of the type of ceiling, but tile ceiling can turn around the hospital in a day's time. So increase the utilization of vinyl floor instead of marble and tiles, so that it can be laid. Huge areas can be laid in few days only. So this technology is basically, modern technology is working on a system called converting the building into replicable modules, which can be produced in factory in many numbers. Basically, each module is replicable so that they can be constructed in bulk,
Sure.
which indirectly increases the efficiency, cost, and timeline of the project. So
Sure.
even MEP construction, MEP is also done in factories, and they all come in the form of modules, and they are assembled at site. So
Okay.
all these things reduce dependency on the labor-oriented works at site.
Yeah. So understood, Mr. Sood. So according to you, early movers advantage, agility, and modular approach to building capabilities are the three cornerstones of smart hospital.
Yeah, absolutely.
Now, I would like to quickly approach Dr. Prabhu Vinayagan and get his perspective around whether he can relate to the narrative that Mr. Pradeep already mentioned to all of us, and what he can add on top of it based on his tremendous experience, both in the demand side as well as in the supply side. He came from the background of operating in the vendor side, but he's also now managing a large hospital and also acting as a consultant side by side. So Dr. Prabhu, just wanted to get your perspective around where do you fit in and how do you envision to modernize the current hospital infrastructure landscape of India?
Thank you, Kaustubh. Appreciate, and first of all, and thank you for all the panelists, and appreciate to be here on this interesting summit. I completely agree with what Mr. Pradeep Sood said, that there are various technologies which has come in today's context to help improve the building structure. I'm not going to focus on the building structure because I'm not a builder, right?
Sure.
And as usual, traditionally what has happened is hospitals are built keeping in mind that we have to build a hospital. But unfortunately, what needs to be taken into account is there are 4 phases of building a hospital. One is called the planning phase, the second is the design phase, the third is the construction phase, and fourth is the commissioning phase. Now, most of the hospitals straight away start the construction phase and keeping in mind the commissioning phase as fast as possible. But what I found that the planning phase and the design phase are the 2 important aspects that generally gets a little behind on what the owners or the people who are investing in the hospital infrastructure don't spend time upon. In my opinion, the planning phase and the design phase should take care of 70% of the total project time. Because if you plan well and if you design well, the rest of the parts of construction and commissioning gets taken care of much more easily. Now let me focus on the planning phase itself. Yep. Unfortunately, in current context, most of the planning phase gets involved with people who are either an architect or a building engineer or the owners of the hospitals or the investors of the hospitals. But in order to have question to be answered is, why do we need a smart hospital? The smart hospital to take care of efficiencies. The smart hospital should improve the quality of the patients, the treatments. The smart hospital should have an efficient flow of patients within the hospital. And if you look at any hospital in today's context, go to any large hospital chains that you go into the OPD or into the emergency room, you will only find clutter and chaos. And the reason for that is because the pre-planning exercise which needs to be done, which should involve clinicians, which should involve engineers, which should involve architects, which should involve quality people to come and first ensure what should be the pre-construction risk analysis that you want to do. First, ensure the process mapping and the patient mapping and the flow mapping of the entire hospital. Build a 3D modeling of that structure and find out where the gaps are in that 3D modeling. Because we have the tools and the technology available to do a construction-based 3D modeling of the entire infrastructure. And if you're able to do that, you will find out the gaps that happens, the flow of the patient, the gap that happens when treatment modalities has to be done. If you go into a particular hospital, you'll find the billing and the admission procedures and the payment areas, they're all cluttered. And patients have to go at least 4 or 5 times up and down to take care of the lab investigations to do that. And I'm just focusing on the OPD one only. I've not yet come into the other parts of how the OT is managed, how the ICU is managed, and how the flow. And second most important, and particularly in the current context, and it's important to point it out, is when you make an emergency, typically hospitals make an emergency room based on the triaging process of the patients, and then subsequently build, an isolation room, especially to take care of the communicable disease. In current context, it spans well because of the COVID-19 issues. Now, this isolation room is, when you enter into the emergency, the isolation room is positioned at the end of the emergency. Now, when you know that the isolation room is specifically for a communicable disease, you can't have the patient walking through the emergency, infecting everybody else, and then go into an isolation room. You are exposing the entire hospital environment to the communicable disease. And that's one of the reasons why the spread of, infection happens very fast. So it is important that the planning at the design phase, you should spend as much time as possible, map all the streams, ensure that the streams are, there are no glitches in the streams by doing the 3D modeling of the streaming process, and then start the construction and architectural phase, because then it becomes much more simpler and easier to ensure that you have a better and a smarter hospital coming up for all future aspects.
Thank you. Thank you so much for that perspective. I gather from your insight that the planning and design phases of building a smart hospital are very important, and stakeholders need to prioritize those steps and probably need to spend up to 70% of their total time to launch a smart hospital in those two areas. I would like to come back to Dr. Vishnu Panigrahi towards the end of the first round, to really get his perspective, because he's one of the key opinion leaders taking decisions on a daily basis on these issues. So I definitely want to learn from him about the reality of that, what's going on in India, and what we need to do both at a corporate level and as a policy level to make that shift and accelerate that shift towards the modern day thinking of smart hospital. But for now, I would like to quickly move to Mr. Shashi Amin and get his feedback around where Polycab comes in, because if you consider large hospital, they play a very important role in helping hospitals secure the systems and the overall facility. Mr. Shashi, you heard Dr. Prabhu. What's your take on how you should be part of this ecosystem, and do you think that today, especially in the context of India, you are ultimately involved in this process, but it's pretty late, and that should change, and moving forward, you should be involved pretty early from the first day of the planning and designing phase of the hospital?
Yeah, thanks, Mr. Kaustav, and thanks. I would like to thank the panel members for giving me an opportunity. See, when it comes to electrical fraternity and Polycab for that matter, there are two things. One is your smart hospital. Second is whether the hospitals are safe enough. Like we've been hearing a lot of news on fire, and during this COVID period when it was very peak, there was 3 cases in Maharashtra, 1 in Iraq. Few years back, I read somewhere about a hospital in London. Today, besides smart, whether our hospitals are safe for the patients who are coming into for a treatment, and when they go out, are they happy about the whole process, what is involved in hospital. When it comes to smart technologies, we need to see what are we doing in saving of power, which is very vital today. Some years back, India was power deficit, and today because of a lot of solar projects, the power is not a problem. But again, being a responsible citizen, we need to look at saving of power at every aspect. So when it comes to smart technologies, there are technologies in the market. Like in Polycab, we have introduced a product called Home HOHM, where everything can be controlled, including the lights, the curtains, the fans, the water heaters, which we have got into a home automation. But similar thing can be replicated for hospitals also. So what happens is you have your correlated color temperature is within the lights. So you can control centrally in the morning, maybe by between 6 and 9 in the morning, what sort of a light you need in the room where the patient is recovering. And maybe in the afternoon, it has to be a very bright light, evening again a dim light. The patient normally in an air-conditioned room is not accessible to the outside atmosphere or the temperature. So we create a mode within the room itself where a patient feels good about it when he's on the way of recovery. So there is a central dimming light which can be provided. It is an energy saving, as I said earlier, easy to install, and where in a click of a button, either it can be controlled centrally, or maybe a patient can control sitting in his bed the various moods of the room. This is as not only Polycab, maybe this is one of the electrical aspects what we can look at when it comes to the smart technology. When it comes to safe technologies, there are a lot of things which is happening in the electrical fraternity. Today, there are hospitals which have been built about 20-25 years back, and over a period of time, the technologies have changed. And at the same time, you get in robotic surgery equipments. Are we doing an electrical audit year on year? Most of the guys would be doing it. But if not, I think you need to do it. Whether whatever you have installed about 20-25 years back, is it good now for the kind of technology which has come in? Like when it comes to cable, we are talking of a fire survival cable. There are cables available in the event of a fire. The electricity can be on for at least 3 hours. So you need to take care of all these aspects as regards electrical is concerned, because all of a sudden you hear about the fire in the hospital and the basic reason given is short circuit. So electrical audit on a periodic basis, according to me, is a must. And when a new hospital is being designed, please involve us, people from the electrical fraternity, so that we can come and update you on the latest technology which has come up in the electrical industry.
Sure. Thank you. I would like to quickly then approach Mr. Bhagat Singh from Bluestar. Could you please share your perspective on the same aspect of building smart hospital and getting involved early in the planning and designing space, and also how important for your stakeholders also to approach periodic audit of central air conditioning systems of large hospital systems? And the reason I'm asking this is, just the other day I was having a discussion with one of my industry friends. He's an MD holding a very senior position in a major hospital in North India. And he was saying that if you approach any large hospital and try to understand where the bottlenecks are, they are mostly found in the operational aspect of the day-to-day activities of hospital. And one key area to focus on, especially at the outset of COVID-19, is how central air conditioning systems are aiding to hospital-acquired infections, which are really preventable. So I'm just trying to understand from you, Mr. Bhagat, how do you anticipate to change that narrative in India and offer credible solutions so that moving forward, your customers can safely install your systems and prevent hospital-acquired infections through central air conditioning systems?
It's a very relevant question. First of all, thank you, Mr. Kaustak, and I'm honored to be part of this distinguished panel. Coming to the question of hospital-acquired infection through air conditioning, I think that has been said right. That was the topic talked about earlier when the COVID infection started, but then clarity emerged very clearly that as long as the hospitals follow the prescriptions given by the air conditioning regulatory body like ISRE and ASHRE, which talks about providing proper ventilation and proper filtration, definitely this acquiring the infection through air conditioning is very much preventable. In fact, it can go one step further to say that installing the necessary filters like MERV filters and having the necessary ventilation and bringing in the fresh air inside the hospital, in fact, the air conditioning system aids in preventing the spread of infection. So that's clarity that has emerged recently, and that is well established now. So that fear or whatever concern is not there anymore. And now coming back to the question of building a hospital which is futuristic, because that's the topic of this discussion. And I was able to hear that interview which Mr. Pai and Dr. Sanjeev had, and in that in many instances I heard them refer to the air conditioning system. So it is very important. It plays a very major role in a hospital. You can imagine a hospital wherein the operation theaters, operation is going on, and the air conditioning system providing the comfort and the necessary conditions like the ICUs, CCUs. There are many areas in the hospital where air conditioning is very key. And for hospitals to consider the future technology, I think now we can see it as in the form of three buckets, like the design, automation, and technology. Coming to the design part, we know India is a tropical country, right? So the ambient temperatures keep going up probably 1 or 2 degrees every year. And even the power quality, for example, is not the same as in a developed country. And we find many air conditioning systems available in India, which are being installed by the customers. And these air conditioning systems may be imported from another country, like for example, China or some other country, where they don't have this kind of a high ambient weather, very average water quality or power quality. So what happens is, if we go ahead and install these air conditioning systems in the hospital, it may not deliver the capacity. So we have had customers complaining that we are not getting the necessary conditions. That's because when the country is having, when the site or the hospital is running at an ambient condition of say 45 degree, we are installing an equipment which is designed for 35 degree ambient, because that's where those are the conditions prevailing in those countries from where it is imported. So the customers have to keep in mind this, and these are the things which have to be planned in advance. There's no point in, as I was referring to a case, that installing a system and then, finding the consequences later on. So what we need to do is we need to be mindful of these facts, and as an Indian manufacturer, as an Indian company with over 75 years of experience, what we have done is we have our R&D is also here in India. So all our equipments are designed to suit Indian conditions. That means mostly the VRFs, the variable refrigerant flow systems, and the chillers, which are predominantly used in medium and large hospitals, they're all designed for this high ambient Indian weather conditions. So that means if you, for example, if a customer installs a VRF of Bluestar, it is delivered to provide the necessary capacity at 43 degree centigrade as against the 35 degree centigrade design conditions which are used for many manufacturers' equipments. So that's a big difference.
Yeah.
So that's a big
Thank you so much
and
for that perspective.
Yeah. So same is the case even with chillers. Yeah. Sorry, you were saying something.
No, please continue.
Yeah. So even in the case of chillers, we have, even the government of India has realized this, and they have come up with the Indian chiller standards, which basically enables manufacturers to manufacture the chillers at the elevated ambient conditions in India. So again, we have proactively followed this, and we have a wide range of chillers which are suiting this Indian chiller standard. Basically, what we have done is we have the important components like the coolers and condensers and compressors specifically designed for each and every product. We call as a mix and match design, so that it exactly suits the requirement of that particular hospital, and also it provides the efficiency and performance as guided by the government of India. So this is as far as the design. I just touched upon a few points. There are a few other things. Due to paucity of time, I just touched upon a few points. Now coming to automation, there were days when the air conditioning systems will be inside some room, some people will be roaming around, some technicians, operators roaming here and there, and there is a possibility of catching infection, especially in the post-COVID situation. So what the technology is migrated to the extent of operating these systems remotely. So there is no need for any operator to be in the plant room or anywhere. So, for example, if you take, because I'm taking our equipments as reference because I'm coming from Bluestar. So we have our VRFs which can be operated through mobile. So you can imagine operating your air conditioning systems anywhere outside from your mobile. Okay,
yeah, that's the point that I want to touch upon in the next round, where we'll express our ideas around how to incorporate digital health technologies into the smart hospital ecosystem. But now let me quickly approach Dr. Vishnu Panigrahi. Sir, you heard all of them. These are stakeholders playing an important role in your ecosystem, and you're driving the conversations, making investments, and really pushing the industry towards the next step of being digitized, being smart. Quickly wanted to touch upon on the fact that, do you think that based on the narrative shared by everyone, India is at that path of quickly accelerating to the smart hospital paradigm? Do you think that we still need to go a long way before this concept can be incorporated in real world?
Thank you for the invitation, and from behalf of Fortis Healthcare, I would like to thank you all. I would like to be maybe the odd man out here. I think so. It cannot be business as usual, because whatever we're hearing is that little bit of minor tweaking is happening. There has to be a paradigm shift, and we have to think the patient should be the central part of it. The healthcare providers have to go to the patient, but this is where technology will come in. Can I continue?
Yeah, please. Yeah. We are hearing some noise from outside, but please continue.
Yeah. So if you look at it, the hospitals that were made by the private sector or the public sector. Was made as a large entity where everyone is to come in. The acute cases, the chronic cases, but the way things are going out, I think so we should plan for looking at hospitals as acute care, and the community hospital should be taking care of the NCDs that is coming in. If you look at the non-communicable diseases, blood pressure, diabetes, these things are coming in. So if a community setup can be there, which can with a good emergency and accident services there, a lot of the patients they can take care there, and wherever required they go to the specialist hospital. So that is something that can happen. And if you look at a major hospital now, we should be looking at how do we make the patient comfortable when they enter. A lot of hospitals, the entry is not comfortable and spacious, number one. Number two, when you go to the OPDs, the outpatient rooms, now the teleconsults are coming up very frequently. Now suppose I'm talking with you as a teleconsult, it is a one way, then suppose I want to access the reports, I don't have to then again interrupt you. So that facial interaction is not there. So when you plan the OPDs, for example, we should have another screen where without disturbing the flow between the doctor and the patient or the attendant, I can access the reports. If you look at the rooms have to be patient friendly. So as a Bluestar colleague rightly mentioned, these are the things that and the Polycab is that we have to see that the patient is able to sort of control his temperature, control his lighting. And about the lighting part, I'd like to say it has a scientific reason, the medical reason. There's something called the circadian rhythm. Because if when you switch off the lights or it becomes dark, the circadian rhythm helps you to recover quicker. A patient who has come into hospital, we need to give the patient the comfort, the rest, and to heal. That is the purpose of the patient coming into the hospital. Right. Because we just can't look at bells and whistles to make a hospital. How to make it comfortable? If you look at the bed that the patient is in across at the foot end, if there's a screen there where he can look at what if you want to see the TV, or that can there, he can have access to reports there. So all these things, if these are things put in, and a very fundamental thing, if you look at across the world, when for the bed, if you look at the washroom, it is not a straight line. So we should be looking at the way the washrooms are also prepared, that when the patient gets out, goes in a straight line with bars there. We call it grab bars, which at night will be lighted. So these are small things. When a doctor or nurse enters a patient room or in the ICUs, their wash basins are now have they started testing it in Netherlands now. If I go to the washroom, into the room of a doctor, of a patient, and I've not washed my hands, it will start blinking. A red light will come. Hey, doctor, Vishnu, come on, wash your hands. Right. So these are what I think is to get out of the thing and be patient friendly. And the other part is the very important part, which I would like to put up on. 70-75% of a touch point of a patient in a hospital is the nursing. And you go across to any healthcare sector now, nurses are sort of loaded with a lot of non-nursing work, a lot of paperwork.
Correct.
So if technology is there for them to sort of see that there's less of paperwork there for them, and they are able to access reports quickly and then look at it, they are able to access the resources where they are, so they can get it quickly. The RFA tagging that is there. Even if you look at the small things like you have some attendants to take care of the patient to the ICU, to the radiology, to the OT. So if they know, because if there are two persons there, one may have gone somewhere. So with this tagging that has happened, you can exactly know who's free now. So instead of calling the person who's busy, you call the person who's free. So what I'm saying is that holistically you have to start looking at that. So what I'm saying is that we should look at a specialist hospital. It should be more spacious, friendly, and the most important part which has happened in this pandemic is something that has opened our eyes. We must be able to accommodate a surge capacity, because pandemic is one part. There's something called, we never know. There could be a bioterrorism sometime down the line. So you should have areas where you can have more of a negative pressure treatment patient areas, negative pressure treatment areas, prevent infection spreading up. So it could be in your your parking areas, in your lobbies. So for that you need to have the electrical fitting, the IT fittings, your gas lines accordingly put in. So these are the things that, in fact, Israel did that. The basement was used for within a couple of hours. They immediately made it into a hospital. So the sick patients, so infected patients can come there. As my colleague was rightly mentioning, instead of going through the ICU and then infecting others in the ER, infecting the others, this side of triaging can happen.
So very important points, and I would like to quickly jump in and share some of my experience working with leading hospitals in India and outside. So Frost & Sullivan has been advising major multi-speciality integrated delivery networks all over the world. And one concept that has really come up strong in the IDN space is to establish a digital command center in a hospital. And I'm referring to a scenario where, like a traffic control police, a centralized vigilance team within a hospital can have a look at what is happening within that network. And when I say network, I essentially mean a collection of hospitals connected seamlessly with each other within a common network. And in that capacity, what hospitals are doing to transition to that smart hospital principle is to incorporate digital command center approach, wherein they're connecting not only software devices, but also hardware devices and sending critical feed to that central command center platform through which critical decisions are made across the clinical domain, financial domain, and operational domain. We probably need a separate session to talk about that. With the advent of smart hospital and incorporation of smart technologies within a hospital system, there is a need to ensure that the hospital is safe from external cyber attacks. So also hospitals are aggressively spending on cybersecurity solutions to ensure that all their data points, including financial data points, which is the number one threat agent for external hackers, as well as clinical information are stored in a very safe and secure data lake. So thank you for touching a lot of concepts from your quick feedback. I have 3 takeaways. The first one is how to expand the scope of care from hospital to outside hospital, and what role technologies will play to dissolve the hospital boundaries and improve the accessibility of quality care across the nation. The second takeaway is how to ensure that all your systems and departments are working in tandem and in accordance with the corporate principle as well as the clinical principle that you have established as a senior corporate leader of a major hospital. And the third aspect is what role the designer, the architect, and the planner of a hospital system play to ensure that every patient touch point is mapped and prioritized to ensure that patient safety is the number one focus area, and all other services, clinical, financial, and operational within a healthcare system should be approached by keeping in mind patients' convenience and affordability. Now, quickly, I want to jump to, again, Mr. Pradeep Sood and ask his perspective around another interesting area that Dr. Bishnu touched upon towards the end of his comments, which is how to ensure that you're not only building a capability which is future-centric and forward-thinking, but also future-proof. The COVID-19 pandemic has showed us that hospitals were not ready to embrace the overwhelming surge of patient footprint in their systems. And now that elective surgeries are still pending and we are expecting thousands, if not lakhs of elective surgeries to be back on track, how do you ensure that hospitals need to spend on planning, designing, and incorporation of devices that will make their system both forward-centric as well as future-proof?
I have already covered that we need to have the facilities in place that flexible use of spaces. We may encounter a situation that we may have to convert all our patient rooms into ICUs because we don't have ICU rooms. So all those things, flexible use of spaces has to be well thought of while designing only. And all these minor changes, it can be turned around and made available to the hospital so that they can do the required, fulfill the required need of the patients in time. Like use of basement for one type of patient, so that the infection from the main hospital cannot go to the other areas. So these are the things which we have to keep in mind. And another angle which Mr. Bhagat covered for HVAC, smartness. In HVAC, in typical hospital, HVAC consumes approximately 60% of energy. So hence, the maximum potential is there to save more. So earlier perception of using these technology was like BMS was monitoring only. Now we have to shift our paradigm from monitoring to analytics of parameters. So the data collection is there. Now we need to monitor these data to convert into efficiencies. So data is there. Now we have to analyze and bring efficiency to the system, which is not there, which we are trying to do at IUIH. We are trying to have a different type of BMS, which will give us efficiencies of every equipment in time, because data is there, we can collect it. Yep. So now the second question is, normally there are some hospitals which may afford right kind of people to do these type of analytics, or if they are not that capable, then these things can be remotely monitored by a third party at a much lower cost. They can spend 1 hour, 2 hours a day to analyze these data and bring efficiency to the system and guide the promoters to bring efficiency. Yep. Now, another point which was touched was HAI with respect to HVAC. This pandemic has, we have learned many things from this pandemic. Now, there are systems available in the market with very easily we can, by putting those gadgets in the system, HVAC system, we can make the air as well as the surfaces of the entire hospital safe from any type of these viruses. Yep. So these, with coming time, these technologies will be more proven and more efficacy of these products will be known to everybody. And I did some analysis by spending approximately 30 lakh rupees. We can convert 80% of the hospital areas into this area, safe. So air as well as all the surfaces in the hospital will be safe.
Okay, understood. Now, I would like to quickly approach Mr. Shashi Amin. Shashi, you mentioned that wires play a very important role to secure the hospital system. I have a follow-up question to your previous narrative, which is what kind of threats does fire pose to establishments like hospitals and large integrated delivery networks, and what are the options they have right now to mitigate that issue?
Yeah, Kaustubh. As I mentioned earlier, we were talking of safe hospitals. Ideally speaking, whether I think I'm asking for too much, whether a hospital is a fire-resistant hospital. But if not, how we can mitigate, or because when you're talking of fire-resistant hospital, the cost could be about 3 or 4 times the normal cost of the construction of the entire system. So at least some of the places, like you have fire alarm, you have got sprinkler system, you've got emergency lighting. So there are various products which have come up in the market. When it comes to wires and cables, there are green wires. Basically, those wires are heat resistant, flame retardant, low smoke, low halogen, and lead-free wires. We are trying to promote this kind of wires in malls, hospitals, theaters, high-rise buildings, and some of the builders within the country have opted for green wires. That is one thing which I would strongly recommend for the internal wiring. Second product which I would recommend is the fire survival cables. Internationally, any building beyond 14 floors, it's mandatory to use fire resistant or fire survival cables. So what does this cable do? It can resist the fire for 3 hours. Nothing will happen to the power. The smoke generation is absolutely negligible. There is no HCl emission. There is no carbon monoxide. And within 3 hours, it has been proven it's sufficient for the people to move out from the crowded place. And all these aspects I would be covering in my presentation after the panel discussion, where I will be talking in detail about these product categories, which I have prepared for the audience.
Sure, thank you. Now,
Thanks,
I will quickly approach Dr. Prabhu. Dr. Prabhu, you're also part of the joint certification initiative. You were heading that company for a long time based out of Singapore, and the Joint Commission International Standards, do they incorporate this progressive capabilities like auditing fire resistance capabilities of a hospital or ensuring that the central ACs are not causing HNIs?
Yeah, thank you once again. Yeah, absolutely. I mean, any accreditation agency, the primary purpose of an accreditation agency is to ensure patient safety and quality. And in order to ensure patient safety and quality, all of these factors are incorporated into the auditing process. We don't call it as auditing because it's not actually an audit, it's a survey process. So in a survey process, what is important is to understand what are the various issues that happens in a healthcare setup. When we are talking about air conditioning, when I do the audit myself into hospitals, when I walk around, I just lift up the false ceiling of the air conditioning vent, and you look inside and you will find ample amount of dust and debris accumulated. So, and that is a harboring of all the microbes, because the maximum number of bacteria or virus that you will find in an environment is inside the hospital, and those are getting harbored there. So if those are not regularly cleaned, then that's a source of infection for any other immunocompromised patient who's going to come in. Coming back to the fire part of it is that you may have all the technologies of getting the best cables in and getting the best aspects in, but also again is the fundamental factor where how you design your hospital infrastructure. If you're going into the utility system and you have a liquid oxygen plant set up and you have a diesel storage right next to it, you're asking for trouble, right? If there is an issue and if there is a fire, you cannot save the entire hospital because your liquid oxygen plant is right next to the diesel storage plant. So again, it comes back to the design, how you design keeping patient safety and quality in place. Fire resistant walls, fire separators, fire compartments, these are all part of the infrastructure and building capabilities of the hospital. And if the fire safety officer is not part of the earlier design phase, you will tend to miss out all these aspects, and therefore invariably you will hear about all the fire accidents that we see in hospitals, right?
Mr. Bhagat, any thoughts on that?
Yeah. So Prabhu was touching upon the dust that is getting collected through the air conditioning vents. That's a very pertinent point. It is, as he said, it is not good enough to install the right system. It has to be maintained properly, right? Because these air conditioning systems are installed and it is expected to have a life of anywhere between 10 to 20 years depending upon the type of equipment. And we are talking about the conditioned air. We have to keep it in mind that the temperature and the condition of the air which is inside the duct is about 15, 16 degrees centigrade. I mean, it's a dehumidified air. It is bound to attract dust, and by having dust on the surface, it is quite natural that some of the bacteria also can get developed there. So it's very important that the air conditioning systems are maintained properly. There has to be a periodic cleaning. There are a lot of, again, technological advancements available. It's all up to the customers to make use of. For example, in Bluestar, we have the non-man cleaning of ducts. Everything is done through remote, through some robotic technology. We can clean the ducts, okay? So the technology is available. It's up to us to make use of. And as the pioneer in the industry, we do tell our customers, we do as much of awareness program as possible to avoid this. And that's about the maintenance part. And Mr. Pradeep was touching upon the power. That's a very important point. Of course, I thought I will handle that in the subsequent question. Air conditioning in any service constitutes close to 50% of the total energy bill. Hospital is not excluded from that list. So any energy saved in the air conditioning system is a direct saving to the end user. I was just touching upon the three buckets. I think I could complete two of them, and then the technology was the last one I could not complete in our last question. So I will make use this opportunity to touch upon that. The technologies have improved leaps and bounds, and we in Bluestar, we have brought in a lot of technologies successfully in India. I don't want to get into the details of that. What I'm trying to say is the technological advancements are here to stay. I'll just take one or two examples. For example, we know that hospitals are not going to run always at the same loads, right? In the morning or daytime, it will have a higher heat load through the footfalls or other operations and other things, and in the night it is going to have a very thin load. So it's very important that the air conditioning systems consume proportionate power. In the earlier days, the technology was limited, that it used to always consider certain minimum power. It cannot go less than that. Now the inverter, or the VFD technology that has come, and in chillers we have the oil-free technology. Oil is normally used for lubrication, as we all know, but it brings along with that some inefficiency. So the technology has gone to the extent that the oil is completely removed. You can imagine a mechanical system running without oil. So that technology is also there. So in Bluestar, we have all this technology, VFD, we have the entire range of VFD chillers, we have oil-free chillers. Suppose if a customer buys, for example, and we have had instance, and we are very happy to share in this forum, a very average hospital somewhere in, Tanjavur, I don't know how many of you know Tanjore. It's a a tier 2 kind of a city in Tamil Nadu, where the hospital customer has gone for this highest technology of oil-free chillers. It's about 360 odd tons. It's not a very big hospital, but he has realized the importance of it. And places like Siliguri, some extreme part of Northeast, they've gone for this high-end technology. So it's not that customers are not aware. So what it brings along with that is, there's a clear power saving of around 20-25% compared to the conventional systems. So going by whatever Mr. Pradeep was saying, 50-60% is the power consumed by electricity of HVAC system. And if there's a saving of 20-25%, the hospital bill comes down to minimum 10-12% in a year. That's a big saving. So it can be passed on to the customer. It can be whatever the hospital can decide how to run the hospital. So it's very important to be aware and also to install the right system. Of course, yeah, it probably has some initial cost more, obviously, because of its technology, but it pays off. We have found that customers have told us that, it pays off within a matter of 2 years, and considering a lifetime of 15-20 years, subsequent years, whatever is the savings, not only for the hospital, even for the larger interest of the country. We are talking about the carbon footprint and then the green gas effect and all that. So the technology is available, and Indian companies like Bluestar, we have all the technologies. In fact, we are probably having an edge over others because we have our equipment designed for Indian conditions. So it's all the customers, once they make use of it, so definitely they'll find the benefits in their systems.
Understood. Thank you so much for that insight. Quickly, again, coming back to Dr. Vishnu. Dr. Vishnu, do you think that there is a need to invest in automated systems that will not only monitor the performance of the infrastructure that comprise of a smart hospital, but also alert key stakeholders at the right time when there is a need to upgrade to a modern systems?
Yeah, Shuvik, the clinical decision support systems that are coming in now, that will help the doctor, the nurses, because the data that comes in from the monitors, from the electronic health records. So the algorithm picks it up and gives a prompt or sort of warning to the doctor, nurses to act upon. So these things have started coming in. So I think this is something that we in India must look at, the clinical decision support systems, which uses technology, which uses data from the electronic health records, from our monitors in the ICUs. And because these data are there, it's just collating them, and AI tools are there now, which helps the doctors and nurses to quickly act on it.
Yep. Yeah, the role of cognitive technologies to automate the process is really a no-brainer now. It's established already in international market and coming up in India. I am very optimistic about the future of AI in healthcare, especially in the inpatient context.
I'll give a example. Just as a nice
Sure,
to
sure. Yes, sir. Yeah.
About 3 years back, there were someone from Israel connected with us and asked us to give us because we do endoscopies. We have across a network of hospitals, so of the 30 plus hospitals. So he asked us to give us the endoscopy findings and what was the final diagnosis. And so they took all this data there and they're dicing it and cutting it, and they said that from this we will have the AI. Like if this is the image, this is likely to grow into a cancer. If this is the image, this is likely to be a clot. So in other words, data, if it's properly taken, collated, and the AI comes into it, AI is just a collection of getting the data points and then working on it. So this is something that we have to do because he paid us for that. And so obviously he's done it. He'll be selling it to someone else. But what I'm saying to tell is that the Indian healthcare with our population, this is something that we need to look at for the benefit of our patients, and also it'll bring down the cost of care in the long term.
Sure. So we have 5 more minutes to go, and I would like to open the forum for Q&As now. Request the organizers to please field questions and share with us. We have a panel that is eager to address any question that may appear. But in the meantime, I would like to quickly come back to Dr. Prabhu. Dr. Prabhu, you have spent a lot of time advising hospitals in India to move to a more mature, more modern infrastructure. And also, I think you're currently building a very highly advanced, digitally centered hospital in Hyderabad. Could you talk about that briefly in a couple of minutes?
Yeah, so there are 2 aspects to it. One is infrastructure, and second is the clinical domain. And I like the positive attitude that you brought in, saying that you have a futuristic in mind that the healthcare infrastructure will grow into the technology space much faster. And I was always of the opinion that if technology has to come into healthcare, it will not be by the medical professional. It has to be by the engineers and the IT professionals. Now, only they will change healthcare. We should be medical practitioners should be focused on patient care. Right now, if you remember that the thermometer came into existence somewhere in the 170 to 250 AD of when it was invented. Medical profession actually started using it in about 1850 AD. It took so many years for the healthcare profession to adopt technology, and that is where is the challenge I'm finding. Adopting technology is not easy, and it does not come easily for the healthcare professionals to quickly accept it and take it over and take it to the next stage. When it comes to healthcare, smart healthcare or having technology, the challenge that currently which is being faced by most hospitals is every department by itself has a separate software. So there is a hospital information software, there is a EMR, there is a separate OPD software, then there is a PACS which goes for radiology. Unfortunately, all of them are not connected. Unless you have an integrated system which connects all of these software together, it becomes very difficult for the healthcare or the medical practitioners to get the advantage of this particular software within a hospital. And that makes them not to get into the system at all. You will find that most of the time I'll find that, only 5% of the entire hospital people are using the hospital software, and the rest of the software is going waste. And then the hospital management will always feel it's not worthwhile to invest into a software which is hardly getting used by anybody within the practice. But there are challenges. There are challenges of interaction between softwares. There are challenges between various departments using different software. So all of the things needs to come together in order to ensure that a final free-flowing artificial intelligence can be developed, and augmented reality can be developed. Trainings can be developed, and all of them can be developed. So I still stick by the stand that healthcare needs to be changed, and it needs to be changed by engineers and IT professionals.
Thank you. Thank you so much for that detailed overview. We are approaching the final couple of minutes of the session. I would like to request the panel members to share any parting notes with all of us. Anyone can jump in and share.
I'd like to jump in here. I think so while planning, one thing which has come out is that while there should be some window should be there for every patient to see out. and they should be seeing some greenery outside, because now the data is showing when you see a garden, see greenery outside, the recovery is better.
Yep.
And length of stay comes down. So this is something that we never take cognizance of, because we just look at building up a hospital, taking care of the patient, and that's all.
Yeah.
But this is a very small thing, but it matters.
Yeah, you brought back a lot of memories for me. I'm a typical village boy. I was born in a small town in Bardhaman, which is 80 kilometers from Kolkata. And growing up, that's all I did, to roam around in greeneries while going to school. I went to Bangalore to pursue higher studies, but up until I was 18 years old, I was just roaming around everywhere. And you brought back a lot of memories. Greenery indeed is very critical to our lives. Healthy or otherwise, we all need to be exposed to more greenery. The other fact is, for the last couple of days in Kolkata, I'm in Kolkata right now, it's raining heavily. So the green aspect is very prominent here because of the rain in the summer season. When the monsoon hits, everything turns green. So it's really a privilege for me to come back to my roots and experience the same experience I had like 15 years ago. Yeah, please.
Just one point, just to add on to Dr. Panigray's point, is that while it is important to have a greenery, and that's no doubt, it's been coming out, data suggesting that patients recover faster, but a lot of hospitals go about putting the entire wall as a glass so that the patient is able to see outside. Now, if that glass is not safe enough, any patient can break it, and there are suicide attempts which happens because of that kind of glass.
Very
so
important.
Infrastructure building is also equally important while trying to provide the best ambience to the patient.
Yeah. And when you don't have greenery, like in the Western world, they will just put up this huge TV. Entire wall will be covered in TV, and they will play some greenery visuals for you. So with that being said,
just one point I thought I will just share here for the
please
hospital, because this is about hospital. As much as we talked about the greenery, I have seen hospitals not having sufficient ventilation. That's a very important aspect in a hospital, if not in other applications. Okay, for example, an office can have probably limited ventilation, but a hospital cannot afford to do that. Especially in tier 2, tier 3 towns, we find hospitals, the operation theaters is supposed to have certain air changes for the proper maintenance of the hospital. That's not happening. Whatever reason, they put some normal air conditioner which cannot afford to have that ventilation. It just does not have the provision to have that air changes to happen. So probably I through this forum, I request, the hospital fraternity to consider, because ventilation is a very huge part of hospital. We cannot compromise on that. Of course, it will add to the air conditioning value, but it makes a lot of value to the customer. So it's very important to have sufficient ventilation. There are norms which prescribes an operation theater, how much air changes it should have, CCU, how much air changes it should have. I think my humble request is, we need to follow that, so that, especially in this COVID times, because it's very clear that the more the amount of fresh air that comes in, the better it is. So I think, we need to keep that in mind while designing the future hospitals.
Yeah, absolutely. Couldn't agree with you more. And with that, I would like to formally conclude today's session. I would like to thank each of you for sharing your valuable feedback and time with us. This was a very good learning experience for me. I have worked primarily in the research and advisory side, working very closely with corporate managers, but the nuances of building a smart hospital is something that I always craved for to learn. And today's session opened my eyes to a great extent. And, I'm going back with a lot of feedback and perspective to dwell on, and potentially I will come back to each of you to carry on this discussion at a later stage, and I would like to stay in touch with all of you. With that being said, I would like to formally thank all of you again for being part of this event and for sharing your valuable time and feedback. Hey, just when we thought we are going to end, we are getting a lot of questions. I would like to ask the event organizer.
We have been receiving great response from our delegates. So I would like to ask you questions. So the first one is for Mr. Singh. How are these fire survival cables different from normal cables?
I think I beg your pardon. I think that may be the
I think
question
this
for Mr.
is,
Shashi. Yeah.
That's
I
for
think
Mr. Amin.
Okay.
it's for me. I do not want to take much time here. In my presentation, just after this discussion, I'm covering this topic. I think the answers are there in my presentation. I will explain in detail the difference between the normal cases and the fire survival cases. Yeah, thank you.
Okay. So the next question that we have, despite what is the kind of effort that leading organizations should be making to draw attention to this issue? I guess this one is again for Mr. Amin. So would you like to address this now?
What is the question? Can you just repeat?
What is the kind of effort that leading organization should be making to draw attention to this issue?
It's very unfortunate that not much of an effort has gone into the process of making the entire infrastructure fire retardant or fire resistant. In fact, about 6 months back, I was in a similar panel with the Secretary Ministry of Housing and Urban Affairs. I was just telling him most of the European countries have got legislations on this fire protocols, high-rise buildings, malls, hospitals, theaters, a railway station. If we have some kind of a legislation here in India, probably when you plan such infrastructure, the fire-resistant protocols can be taken care of. Till now, not much of an effort. There are a lot of things needs to be done by the manufacturers in the country to take this up to the government.
With this, I would like to thank all the panelists and our moderator, Mr. Chatterjee, for taking out time for this. Don't miss out to check out our partners' virtual booths to know how your business can benefit from their products and services. We now move on to our next session by Shashi Amin, Executive President and Chief Business Officer, Cables Polycab India Limited. Over to you, Mr. Amin.
Good afternoon, everyone. This is Shashi Amin here. I'll be talking about the fire safety and even the smartness regarding to the hospitality industry. Before I go around with the product, we just had a panel discussion where we were talking about smart hospitals. I also mentioned about of late hospitals need to be safe enough for the patients to recover and come out healthy. Before I do that, a snapshot on Polycab. We are India's largest cables and wire manufacturing company. We are the market leaders, exporting to around 40 odd countries. Of late in last few years, we have diversified our portfolio into fast-moving electrical goods. A huge distribution network, around 3,500 dealers and distributors, more than 1.25 lakhs retail outlets, 25 manufacturing facilities based out of Daman, Halol. Besides that, we have an FMEG manufacturing in Roorkee, where we produce our fans, Vadodara for LED lights, Nasik for switches and switchgear. In Polycab, we have done backward integration, like for example, we have our own copper rod plant, we have our aluminum rod plant, we also have steel plant for armoring and the compounding. Besides this, we also have our own drum manufacturing factory. So we are not dependent on the third-party vendor. We believe in manufacturing all the raw materials and products needed for manufacturing of cables and wires. We are a highly trusted and a well-known brand in India, and of late you will see a lot of Polycab around. If you look at the journey, started way back in 1964. The first cable plant in Halol came up in 1983. IFC invested in Polycab in the year 2009. In 2013, we came up with a switches factory. Then in 2014, we launched our fans. And in 2016, we had a joint venture with Trafigura for a copper plant, which now currently is a 100% owned company of Polycab. And 2019, we came out with our public issue, which has been successful. And thanks to each and every individual who have made this public issue successful. Enabling smart hospitals. This is the one product which I mentioned in my panel discussion also. Recently, we've launched Home. Home is a human-centric lighting. Basically, it is an art of creating lighting that mimics the natural daylight which drives our bodily functions. It enhances human performance, health, and well-being. If you look at home in healthcare, it supports patients' recovery and enhanced drug efficacy. Dr. Panigai during the panel discussion mentioned about circadian rhythm synchronized to natural light helps a lot in recovery of the patient. This circadian entrainment also improves our immune system, lowers our stress, and even reduces our risk for diseases like diabetes, obesity, cancer, and mood disorders. So we are talking of intelligent lighting systems within the hospitals, which can be controlled through an app by the patient or the relative of a patient. If not, it can be controlled by the group, by the administration of the hospitals. So these are some of the electrical gadgets which can be controlled through the home application. You have your ceiling fans, you have your lights, you have your bulbs, switches, everything can be controlled with this gadget, which we have recently launched, and I'm sure this could be of interest into the high-end hospitals in the industry. What does Home offer? It's a mobile application. It is a voice assistant controlled by Alexa or Google Home, a scene creation, a mood creation within the room, and even time scheduling. This does not require any wiring because this is all digitally controlled. Moving away from the smart automation, I would like to talk about the fire threat. Today, all of a sudden, we talk about whether our hospitals are safe enough. We've been hearing about a lot of fire accidents within the hospitals. Like in last 3-4 months, there were 3-4 fire incidents in Maharashtra. There has been one fire incident in Iraq. Few years back, there has been an incident of fire in hospital in UK. Like if you look at the numbers, your National Crime Record Bureau 2019 talks about around 11,000 cases, and fatality is again around 11,000. Each fire, there is on an average one person dies because of fire. The majority of the fire which was published in the year 2019, major fire took place in Madhya Pradesh, followed by Maharashtra, Gujarat, Chhattisgarh, and Tamil Nadu. If you see, it's mainly in the western part of the country. But at the same time, like when you're talking of a building which is around 20-25 years old, do we have a similar electrical safety standards? Like whatever building or the hospital which has been built in 90s, are they safe today? There are a lot of gadgets which have been added. We're talking of robotic when it comes to surgery. Is our electrical capability taking care of this addition of the equipment? So electrical audit is a must according to us when you add on equipments and gadgets into your hospitals. These are some of the causes of electrical fires: faulty equipment and appliances, light fixtures, extension cords, improper training of staff, wiring and poor maintenance, negligence, electrical panels and circuit breakers. These are some of the few examples which normally I speak of. Upar Cinema is very close to my heart. This happened about 24 years back. Small school kids, children had gone out to see a movie, I think it was Border, and suddenly there was a smoke which entered the auditorium, even though the fire was just outside the viewing area. The smoke entered the auditorium, there was no power, lights went off, and 59 people, majorly children, died trapped inside, mostly due to suffocation. The other one recently in Bombay, Kamla Fire Mills, again this is not because of electricity, but because of the kitchen, live open kitchen, there was a fire and people died again because of the suffocation. The majority of the people die because of suffocation and not because of fire in the event of a fire. Recently in this year, an hospital in Maharashtra, COVID ward hospital in Maharashtra, 13 people died. Bhandara Hospital, 10 small babies aged between few days and 3 months died because of suffocation. The reason I'm harping on suffocation is most of the people do not know the cause of the death. The reasons are short circuits, maybe, but people die because of suffocation. Again, there is a mall in Bombay which was converted into a COVID hospital. March last week, the fire was engulfed for more than 40 hours and a lot of people died during this fire too. So what are the primary causes of death? It is the smoke, not the burn. Smoke inhalation is the primary cause of death for victims of fire. The inhalation or exposure to hot gaseous products like your carbon monoxide, sarcogenic gases, those are the main reasons for the fatality in the event of a fire. 70 to 80% of the fire deaths are because of smoke. Poisoning and pulmonary irritation and swelling caused by carbon monoxide and cyanide. Toxicity of smoke also kills the person. What are our options? Disaster management training for all. Availability of fire extinguishers. Yes, I'm sure I think most of the hospitals would have this. Availability of smoke detectors, fire alarms and sprinklers at every site. We have to ensure whether those equipments what we're talking of now in the event of fire would be on. Better evacuation measures, better wiring and cabling practices. So for us, better wiring and cabling practices implies, and we need to take care of this particular aspect. I had mentioned earlier also in my panel discussion of fire survival cables. What are these fire survival cables and how are they different as compared to normal cables? The normal cables has PVC as an outer sheet. PVC in the event of a fire emits around 95% smoke. Since PVC has got chlorine, it emits HCl gas and it also emits carbon monoxide. So because of this, you have dark smoke which comes out. So moving away from those cables, FS cables have been introduced where the visibility is around say 90%, 95%. In case of PVC, the smoke is around 95% and the visibility is 5%. In case of FRLS cables, the smoke generation is around 40 to 45%. What does this cable do? This cable, besides smoke and the toxicity index, can survive fire for 3 hours. It can survive 950 degrees centigrade for 3 hours. So that within those 3 hours, nothing will happen to the power. The circuit integrity will be on, and 3 hours is sufficient for an evacuation in the event of fire. Second aspect is oxygen index. Normally, oxygen required is around 29 to 32%. This cable can have an oxygen index of around 34 to 36%. In these cables, we do not use PVC as an outer sheet. We use a separate elastomeric compound which takes care of all the properties. And at the same time, we have this glass mica on the conductors or the core which prevents the fire from going up to the conductor. So this is a typical test as per BS standards which the fire survival cable has to go through. Like it has to resist the fire at 950 degrees centigrade for 3 hours. If you see the photograph, the cable is burning, but there's hardly any smoke. There is also a test called W, which is resistant to fire and water at 650 degrees centigrade for 30 minutes. Then there is Z test. It's called as CWZ test, resistance to fire at 950 degrees centigrade and a mechanical shock for 15 minutes. So these are the cables which can survive the fire from 950 degrees centigrade, and when you have water which is being poured on the cables, it can survive the fire at 650 degrees centigrade, and when there is a mechanical impact, maybe the debris falling on the cable, nothing should happen to the cable. These are the typical characteristics of fire survival cables. And ideally speaking, in a place like an hospital or a mall, this cable should be used extensively. No doubt it is an expensive cable. The cost could be around 1.5 to 2 times the normal cable. But when you are building up an hospital, if the cost of the project is say 100 crore, this additional cost of creating a fire resistant premises is hardly anything. It's basically peanuts. So these are the applications where I would strongly recommend to use this sort of cables, fire survival cables. fire alarm system, lift operation, critical wiring circuits, emergency lighting system, sprinkler pumps, CCTV systems and telephone lines, public address system, and the BMS. These are some of the critical equipments in any hospitals, malls, or buildings which predominantly this sort of a cables need to be used. This is some of the photographs. One thing I would like to say is in Polycab, we are the only company where our product has been tested and approved by LPCB. LPCB is Loss Prevention Certification Board based out of Bombay. So the cables, fire survival cables which are being produced by us are being certified by them, and on an annual basis they visit our factory and ensure that a quality product is produced within the factory premises. Besides moving away from fire survival cables, these are green wires which we strongly recommend in hospitals and malls. The difference between this and the normal wire which are being sold in the market is flame retardant, but this wire is heat resistant, flame retardant, low smoke, low halogen, and low fume. So you have all the 5 properties or characteristics in this particular wire. And if you look at the cost, this could be slightly more than the normal wires. So I strongly recommend to use green wires instead of PVC FR wires or FRLS wires. So this wire takes care of the properties of FRLS. Besides that, this is heat resistant. The current carrying capacity of green wire is 15 to 20% more than the normal wires and the FRLS wires. This is ROHS compliant. This is all I mentioned to you. And a lot of green buildings are using those green wires of late. Difference to what I mentioned, oxygen index, if you see, the normal PVC is 21, FR is 29, here is 32. Temperature required to catch fire in normal is 150 degrees centigrade. Here is FR is 250, green wire is 280 degrees. Visibility FR is only 5 to 10%. Here it's more than 45%. Halogen content here in normal 7%. In green wire is less than 15%. Carbon monoxide is more in FR, and in green wire it's very low. This is an ROHS compliant lead-free wires. As in Polycab, other than HOHM what I spoke about, fire survival cables what I spoke about, and the green wire, we are also into pumps, we are also into switches, switchgear, we are also into water heaters, LED lights, street lights, flood lighting. So this is the entire basket of product which Polycab is offering to our customers. I would say it's a one-stop solution when it comes to electrical products. Whenever you are designing an hospital, building an hospital, please think about us. We have experts within the organization who will come and explain to you the characteristics of the products and the features of the product, and accordingly you may take a call on looking at the specification and looking at the technological advancement over a period of time. Thank you so much. Thanks a lot for your patience.
Hello, Mr. Bhagat. Welcome back. We had 2 more questions which came from the audience, which we could not ask at that point of time. So we would be glad if you could answer this question. So the first one is, what are the new trends in design, technology, automation in air conditioning system for building smart digital hospitals which are future ready?
I think I did answer a part of it in my first question by Mr. Kaustik. Basically, there are a lot of trends that have come, especially in the post-COVID situation. I will just touch upon few things. First and foremost is we need to understand that India is not similar to other developed countries. So if we are thinking of importing equipments from those countries, we have to ensure that they are designed for Indian conditions, and practically it will not be, because those equipments are not meant for Indian conditions. So I just mentioned about the Indian conditions, typical Indian conditions, which are high ambient, that means high temperatures, very average water quality and power quality. So we need to ensure that while we design the hospitals, we are designing the HVAC system for the prevailing conditions of that project site. So I just mentioned a few things. For example, in Bluestar, in the case of chillers, for example, if a customer decides to go with chillers, we have the mix and match design. That means we design the each and every component. Some of the major components are in the heat exchangers like coolers, condensers, compressors. We just put together all these things and then design the chiller for that particular project. So the benefit is it is just fitting in the exact requirement of the project. It gives the best performance at that condition. That is whatever I mentioned about the ambient, and the average water and power quality. So it does deliver the best performance at those conditions. And if you talk about the automation part, I was mentioning about the mobile app, wherein we can operate the systems, like for example, VRF through the press of a button from a mobile. It just eliminates the need for a person or a group of people to stand together and then create chances of spreading infection. But it also adds to the convenience and comfort. You can operate through your mobile. We have the Wi-Fi operated remotes, and in that session, Mr. Pradeep was talking about the supervision of the system. We have a remote monitoring facility. Due to paucity of time, I could not touch upon those in my earlier session. Through this remote monitoring system, which we have introduced in India, our equipments can be monitored 24/7. That means there is no need for a customer intervention. Our experienced technicians and managers will be monitoring the health of the operation of the particular site, whatever may be the equipment, a VRF or a chiller, 24/7. So what happens is, in case something goes wrong, immediately an alert is sent to the the respective technician who's handling the site, and then whatever modification that is required is done immediately. And by analyzing the trend, the performance also can be improved. So there is a lot of advancement that have happened thanks to the improvement in the electronics. We can put together all those things. So all these things can be made use of in the future digital hospital. And on the technological side, I mentioned that migration has happened towards the inverter technology. From the fixed speed technology, we have moved on to variable speed technology. We have the variable speed compressors. We have the variable speed. All our VRFs are with variable speed compressors. We have chillers with variable speed compressors. So all that will aid to the performance, not only the performance, but also to improve the operational efficiency of the air conditioning system. And the air conditioning system, by virtue of the the entire setup, that being consuming some 50 to 60% of the power. So whatever is the savings by installing this new technology driven equipments, air conditioning systems like VRFs or VFD based chillers, there's a clear saving in the customer's electricity bill. So it aids in at least minimum 10 to 12% of electricity bill in running the hospitals. So these are some of the things which are available. And we being an Indian company, we have all the technologies available, sophistication, automation, design, everything I just mentioned. So all these things can be put together while designing the hospital so that they can be future ready and digital.
Okay. So that leads to the second question, which is about the operational efficiency. So how to improve the operational efficiency in the hospitals through key infrastructural conditions, like air conditioning plants? Sure.
First and foremost is air conditioning plants consume half of their energy bill in a hospital. So that shows the importance of having the right system in the hospital. So whatever is the energy that is consumed more, it is going to affect the hospital. Whatever that is going to be saved, the energy that is saved, that is going to be the saving for the hospital. It is as simple as that. So I was just mentioning about the latest technologies. We need to migrate to variable speed drives. That has already happened. We have manufacturers, like us, who have the entire range of equipments which are designed with the variable speed systems like we have in case of chillers, we have VMT based chillers, we have oil-free chillers. In case of VRF, we have the variable speed compressors. So what this does is, as I was mentioning in the session, the hospital is not going to have a constant heat load, right? It is going to vary throughout the day. In the daytime, it's going to have a higher footfall, maybe more activities happening, so it will have a higher heat load. And probably in the night hours, it's not, many of the services are not going to be there, and it's going to have a lesser heat load. So the air conditioning system has to run in sync with this. It should not happen that it always runs and delivers at a particular runs at a particular speed and then keep consuming that electricity, because it's going to be a waste of energy. So once we have this VMT-based systems, what it does is it just adjusts the speed of the compressors to suit the prevailing heat load. For example, in the night times, probably it may not run at the full capacity, maybe running at some, say, 60-70% or whatever that particular site calls for. So what it does is, it straight away brings down the energy bill, the energy that is consumed by the chiller, or what, for that matter, a VRF. Okay, because why I'm talking about these two equipments, because they are the systems that are mostly used in many hospitals. So it makes sense to talk about this equipment. We have other equipments also which with advanced technology. So what this VMT driven systems does is it just adjusts its speed, and then accordingly the electricity consumption also is modulated in such a way that it is in exactly proportion to the requirement. So these are the ways by which the operational efficiency of the hospital can be improved, because if a bulk if there's an equipment which is going to consume, say, 50% of the energy, it makes sense to focus on that rather than some other equipment which may not constitute the bigger ratio in the electricity bill. So by following the latest technology like the VMT-based chillers, oil-free chillers, VRF systems, which are much more efficient and also designed for Indian conditions, these are the ways by which the operational efficiency in the hospital can be improved leaps and bounds. There is a clear scope for minimum 10 to 15% improvement if the right systems are chosen and installed.
Okay. Thank you, Mr. Bhagat. Thank you for your very insightful views on this. Welcome back for a very, very fiery fireside chat, which will be headed by Dr. Garima Singh. So we have two panelists on this. One is Dr. Pandit, who is the Director of Critical Care Fortis Hospital, Mumbai, and he's also the member of Maharashtra COVID-19 Task Force and the member of Honorary Supreme Court appointed National COVID-19 Task Force. So in short, he is helping the COVID-19 Task Force for us. So with over 2 decades of experience, Dr. Rahul Pandit is currently the Director of Critical Care Fortis Hospital in Mumbai. He is bestowed with the prestigious Fellowship of Joint Faculty of Intensive Care Medicine, Australia. Dr. Rahul Pandit plays a lead role in setting up the ICU policies, protocols, and patient care algorithms. He is an esteemed member of Maharashtra government's COVID Task Force on COVID-19. And this task force played a key role in establishing a patient management protocol for serious and critically ill patients. Next up, we have Dr. Mahajan, who is the president of NatHealth, also the founder and chief radiologist of Mahajan Imaging. Dr. Mahajan is the president of Indian Radiology and Imaging Association and also a consultant to the International Atomic Energy Association, Vienna, Australia. He's currently the chief radiologist at Mahajan Imaging Private Limited, the company which he founded, which has 7 radiology and nuclear medicine centers in and around New Delhi. In 1992, Dr. Mahajan set up one of India's first privately run MRI. Subsequently, in the year 1998, he was appointed as the honorary radiologist to the President of India, and he continues to hold the post till date. He was awarded one of the highest civilian national honors of Padma Shri in 2002 for his contribution in the field of radiology and imaging. He is also the current president of NatHealth. Steering this show is Dr. Garima Singh, who is the founder and CEO of Axia Health Services. Garima is the seasoned healthcare professional with over 20 years of experience in the corporate healthcare of India. She has also worked overseas. Her work experience covers the entire gamut of healthcare delivery, namely project management, hospital commissioning, equipment, and manpower planning. She is also into recruitment, team alignment, P&L ownership, which has around 600 crore annual turnover, establishing clinical service lines, strategy and growth investor relations. Since 2019, after working within the corporate healthcare for over 2 decades, she runs her firm, Axia Health Services. In a short span of 9 months, AHS already has an impressive client list and body of work. Axia Health Services also provides the health sector with industry-relevant solutions for providing, empowering, skilled, relevant healthcare professionals who possesses the ability to significantly impact and enhance the patient care and experience. So the fireside chat will be on reimagining healthcare and bringing the lessons forward. Over to you, Dr. Garima.
Good afternoon. A very warm welcome to the participants and the audiences. And we have a very august panel over here, which is Dr. Harsh Mahajan as well as Dr. Rahul Pandit. The pandemic has seen certain areas within healthcare field which were literally, close to ground zero. One of which was the diagnostics field, and the other was the critical care zone, wherein everybody who needed oxygen and more were kind of made available for these resources. So, like Sujata mentioned, what we're talking about as of now is reimagining healthcare and bringing the lessons forward. So to structure the conversation a little bit, I believe that we've learned lessons, and those lessons touch different stakeholders in healthcare. Some being the hospital, the patient themselves, the diagnostic chains outside the hospital realm, the critical care. So these and the use of technology, how quickly we as a community could adapt to the use of technology to access healthcare in a faster way and ensure that the outcomes were better. So with this brief introduction, may I request Dr. Mahajan to speak a little bit first on the lessons that he personally experienced while going through the second and the first wave of the pandemic.
Thank you very much, Garima, and good afternoon, everyone. We've learned a lot over the last 16 months that the pandemic has been around, especially so in the diagnostic field, both in imaging as well as in lab medicine, and we kind of straddle that entire space at Mahajan Imaging. And what, when the pandemic hit in January and then, it became serious in March, the country was capable of only 100 or so RT-PCR tests could be done. And we knew by that time that this is the gold standard test. That's when both the public sector as well as the private sector came together. And one of the lessons that we've learned is that when public and private work in unison, when they come together and sort out the issues amongst them and together address a problem, then, this country is capable of huge things. From that 100-odd tests we were capable of, today, generally we are doing 18 to 20 lakh tests a day, out of which about 15 lakh are RT-PCR tests. So, also here, the accrediting agencies played a major role, because ICMR to begin with, to set the standards, and then for the private sector it was mandated that you would need to be NABL accredited, and this was all done online for the first time. There was no physical presence of the inspectors, and somehow we felt that it was more stringent than with the people present there, because with a camera you had to show everything, and the agencies were willing to work in the evenings, at night, to do this. And that's why we have over 3,000 labs which are accredited now, from 1 or 2 that were at the beginning of the pandemic. Even in imaging, we learned how to run the radiology departments in such a manner that, number one, we don't end up infecting patients, mixing, the COVID and non-COVID, because in the beginning there was a mix, and then of course COVID took over, especially so in the second wave. also how to protect the healthcare workers. And then over time, we learned which are the techniques. The X-ray had its own useful interventions and limitations, and the CT scan was important in its own way. And here again, the new practices that we learned about how to have, prevent infection and cross-infection, I think really stood us in good stead. And, as you've seen, especially in the second wave, radiology and imaging came into its own. I at times feel that it was overutilized, misused also, but then the capability and the resilience in the system, we learned as we went along, and from what we were capable of and what we actually achieved, probably if you'd asked me in June, July of last year whether we would be capable of this, I would have said no. One last point is also that we realized that it is better to be Atmanirbhar, because the world had a shortage of everything, right from testing kits to PPEs to medications. And that's where, even the medtech industry came into its own. And today we are self-sufficient in RT-PCR kits, in rapid antigen kits, all manufactured within the country. And in fact, we have a surplus. The same thing we saw with PPEs in the beginning, getting an N95 mask, even a surgical mask was an uphill task. And when the textile industry came into its own and met the challenge, today we are exporting PPE kits to the world. So there is that, capability which is there inherent within our country in different industries, which we realized and which came to the fore. And was a great learning during the pandemic.
Thank you so much, Dr. Harsh. And I think very rightly put, when the purpose is common, which in this case was, handling pandemic and saving lives, I guess everyone, every stakeholder, whether it was from the government side to the community, to the hospitals, to the diagnostic chains, everybody pitched in, and we were able to see the resilience and the ability to scale up. At a human level, we could scale up, and at the equipment level and ability to deliver the desired results, if I may say, I think we were able to demonstrate that very quickly as a country. With that, Doctor, may I request Dr. Pandit for a few words with regards to specific learnings that he found when it came to his patients, the communities that he was dealing with, and being on the COVID-19 core panel. What were the basic learnings that he was exposed to, which he would be happy to share with us?
Good afternoon, Dr. Garima, and good afternoon, everyone. Thank you for having me on this panel. Look, I think we need to talk about scalability. A lot of points Dr. Mahajan already touched upon, and I'm just going to sort of build up on that. When the pandemic started last year and the first cases started trickling, throughout the country, we had around 9,000 odd beds registered as intensive care beds. Today, we have close to 1 lakh beds which are registered as intensive care beds. And that's the amount of scalability we've gone through. We've gone through from, say, under 10,000 to 1 lakh within a span of, say, 12 months. Because in the last 6 months or so, the beds have been more or less stable. We have added a few beds now in anticipation of a third wave, at least in some states like Maharashtra, where we've been proactively adding up beds. But overall, as a country, I think we are better prepared than what we were a year and a half ago. The second thing which basically changed the whole quantum of critical care is that though we went from beds from 10,000 to 1 lakh, we were not able to produce that many intensive care doctors because it's just too difficult to actually produce that many trained doctors. So there was a lot of innovation in that. We had a quick training program for these doctors across the country who were not formally trained in intensive care, but had the required skills which could be actually used to our benefit. And why am I saying that? 90% of the skills which are required in intensive care management are actually cognitive skills. I could sit in one place and manage 10 ventilators, having one person on the ground actually helping me to sort of put the patient on a ventilator, what settings to do, what tabs to push, when to decrease those pressures on the ventilator or the blood pressure medications, or say, for example, whether this patient is going to need dialysis or not. All of these things are cognitive skills, whereas the hands-on skills, which are very important and actually compensate completely for this 90% of the cognitive skills, are how to put somebody on a ventilator, how to put in an arterial line, a central line. These are very, very precise techniques. But fortunately, we had a whole lot of doctors who possessed that, anesthetists, physicians, pediatricians, surgeons, who could actually chip in and help out the intensive care doctors with these procedures. So the technology came to our rescue. We were able to have doctors sitting in on their computers and managing patients within the hospital or even in the hospitals which were miles across from their own place of work, and were able to manage these patients very, very nicely until the point that everybody's knowledge base came up to a point where they were then able to independently handle these patients, which was over a period of say 6 to 12 months. The necessary skills were then picked up. And I think that's the biggest thing which changed in intensive care was use of technology to support patient care. The other thing which I found, which was a big learning, of course, many points which Dr. Mahajan has said, I'm not going to repeat them in terms of scalability. But one of the things which actually changed completely for us was communication. Communication to the patient was the biggest change. We've never seen communication to the patient being driven by telemedicine or audio and video communication. We've always relied on patients coming to the hospital, we're talking to them face to face, whether it was actually giving them a good news or unfortunately sometimes breaking a bad news. Now everything was actually done on audio-visual mode. And surprisingly, people adopted to it very quickly and accepted it. And in fact, many of them demanded it because the pandemic had put in a sense of fear, sense of concern. If one member of the family was sick in the hospital, everybody obviously wanted to protect the other members, and quite rightly so. I would do that for my family. Why not everybody else would do it the same way? And they were actually demanding that the consults be done, the communication be done over an audiovisual mode. And then comes the next step. The next step was consenting processes. Consenting process also took up an audiovisual mode. We were actually then discussing the procedures over the phone, sending them the consent forms. They were signing it, scanning it, or just photocopying, just taking a photograph on the video on the phone and sending it back to us. So I think this learning has made a big difference in the way we are actually going to function. So I'm just going to take up these 2 or 3 points which are important. We've got many more to talk about, but these are some of the big learnings in the process.
So I think the key message that I take back from the conversation that we've had with Dr. Pandit is that technology per se impacted our ability to reach to wider communities, larger number of patients than what we normally could. So a doctor could probably look after 15 to 20 patients in this case because of the use of technology and the communication ease and the acceptance of communication on a technology platform and not in person alone. It allowed and freed up the time for the doctors to reach out to a wider number of people. I hope I've summed it up right about over there. Great. Right. So going back, there is a little one little thought which I wanted to put across, which probably community faced quite a bit, was the paucity of, let's say, oxygen and certain life-saving drugs when it came to the pandemic. And there was hoarding, which was kind of, evident in multiple forums, and many people bore the brunt of it. So I wanted to take individual views of the doctors as well as what are the lessons that we have learned so that we don't end up repeating this one particular issue, which has a wide impact on Indian community and the healthcare in India. Dr. Mahajan, you first, please.
Yeah, thank you. Well, this was the dark side of, our people that we saw during the pandemic, especially during the second wave. We saw hoarding to an extent which is, just not acceptable. We saw profiteering of the kind which is abhorrent, really, that for transferring a patient from place A to place B, which is 10 kilometers away, ambulances were charging 30,000, 40,000 rupees. oxygen cylinders were sold, at least I can talk about the Delhi NCR region, for as high as 1 lakh rupees, which is otherwise just 5,000. Same with the pulse oximeters, whatever, then remdesivir, which, now it's said may not be as useful as it was thought at that point of time. Again, hoarding and then black marketing, which was going on. And this actually showed the dark side. Now, the oxygen shortage itself, the fact that so there was such a huge surge of patients, 4 lakh is what we reached. And with that, all hospital beds were filled with patients who required oxygen. So the oxygen level requirements in a hospital went up 4, 6, even 8 times. And that's where the shortage came. Because generally, one could meet with liquid oxygen the requirements of the hospital. And this is where across the country, we found that there were shortages. Also, the manufacturing happens in areas which may be at far distances from the metros where most of the hospitals were located. And we found that we were short of trucks, refrigerated trucks, which could, transport these. And I think the lesson has been well learned. Already oxygen generators are being installed across the country, both in the public as well as the private sector. More plants are being set up. More oxygen tankers are being acquired. But I think it's somewhere the government also needs to focus on this black marketing and how to prevent it, because it was rampant and it was open and nothing was done. We haven't found too many people who are behind bars accused of black marketing. And just to amplify the point that Dr. Pandit made regarding use of technology, I think telemedicine has come to stay. It's accepted by the physicians who have to give advice, as well as by the patients who have to receive it. And also the government was very quick. In March, April of last year, they brought in the act and the rules for telemedicine. Before that time, it was actually illegal to consult over phone or on Zoom or whatever. And so now it's legal, and I think this is going to be the way forward. However, from Nat Health, we did carry out a survey, and most people actually were benefited by telemedicine and adopted it. However, there is a caveat. They want to go back and have a face-to-face interaction with their doctor as and when the infection lowers and it permits. So we'll have to see. Though telemedicine has come to stay, however, the face-to-face meetings will still remain. Maybe 1 out of 5 may be a face-to-face and 80% may be telemedicine.
Thank you very much, Dr. Mahajan. Dr. Pandit, a question on similar lines only. With regards to the disruption pertaining to oxygen supply, what was it that you saw, and what solution do you propose so that there is no repeat, and the use of technology in ensuring that there is transparency when it comes to supply essential supplies for hospitals, especially in pandemic times?
I think it's very important that we actually take our learnings to the next level, and those learnings need to translate into actions. One of the things which we need to now do is to make sure that we always have augmenting capacity of our oxygen plants. We never thought in this whole lifetime that we would actually run short of oxygen, of all the commodities oxygen. So PSA plants are very good. They actually provide you a very good backup. Sometimes you can actually even manage a hospital on a PSA plant, but they have their own limitations and stuff. The other thing which we need to do is use the technology to our benefit. Again, same thing. We need to RFID all the oxygen cylinders so that there is no hoarding ever which is going to happen. Every cylinder where it is located, you should actually be able to do that, and that's not very expensive. For a fraction of a cost, you can do that for the lifespan of that cylinder. The third thing which we need to do is we need to identify that we would never be in such a situation again by having a stock of oxygen, which would be equivalent for a week's stock at our disposal at all the time. And that would be something on the lines that the government always has a petroleum stock, which is a wartime stock or an emergency stock, which is there. We need to have that kind of a stock which is available in the country all the time, so that if we do run into a problem, it takes a week or so for companies to augment it. The steel companies, the oxygen companies, the gaseous oxygen filling plants, all of them take 7-8 days to sort of change from a normal production mode to an increased production mode. And till that time, we need to have this stock which is available for us. The last thing which we need to do is, and we are already doing that, is there are a number of modelers who actually model out the requirement for various things. The IIT Kanpur model is there. Then you've got a number of other models which are there, which then can predict the pandemic, the way it is shifting, and whether the demand is going to increase or not. And we need to have some form of a trust on them. Now, there are people who would get it wrong. There are people who would get it right. But I think if there is a trend which is seeing that it's increasing, we need to start the action of producing these essential items, oxygen, maybe some of the other drugs like methylprednisolone or dexamethasone in a pandemic situation. And remember, this is not the first pandemic that we are seeing. I mean, as a doctor, we had number of, if I may just take 1 minute more, we had number of warnings in the last 20 years. 2002, 2003, the SARS pandemic was there, which sort of did not go as a pandemic, but had a concentration in the Middle East, Asia. Sorry, in the Southeast Asia, beg your pardon. Then we had the 2009 swine flu, which went across the world, but fortunately had intervals in between the two countries, and that sort of did not give it it did not sound like a pandemic at that time. Then we had the Middle Eastern respiratory virus, we had the avian influenza, we had Nipah, we had this virus, the Ebola virus, which came up into the African country, and then we had the COVID-19. So it's been sort of hitting us all the time. Unfortunately, this COVID-19 was the one which actually spread across the world, but there were a number of instances before. So I think we need to be aware that this is not something one-off. We need to be prepared for these type of respiratory viruses or other viruses which may attack us all the time, and we need to have a bit of a guard done for that.
Thank you so much, Doctor. Now a general question. What we have seen, and it's an open question, whoever would like to take it first, is the time for the GP, has it come back? Have we seen a reversal from a specialist-driven care to a GP-driven care who's connected to the patient and can handle almost 85 to 90% of the issues when they start and can work on the prevention aspect with the families and the patients directly?
See, if I may take that, I think the GP was always necessary. I mean, when we were young, there used to be the GP in the colony, you know, and he would know about your entire family illness. He was more like part of the family. And with the advancement, we've kind of lost out on the GP. And it is not that the patient wants to go to directly to a specialist, but that layer has become very, very thin. And so the GP is necessary, very well brought out by the NHS system in England, where first you have to go to a GP and he knows about you, and when necessary, he refers you to the specialist. Similarly, I think the GP now is going to be someone who will be available on call through telemedicine, whether it's a telephone or it's WhatsApp or it's some other software that is specifically meant for this. And along with this, we will need the EHR, the electronic health records. And so when you call and it's not possible that, he would know everything about you, but technology enables that through electronic health records. And when you call, he will have your data in front of him, and based on what problem you have, about 80% it is said will be solved at that level itself. In 20%, he may need to escalate to a hospital or a specialist. And initially, the specialist also may be on call. And where he determines that some test needs to be done or some, he has to see him or her physically, then one may go to the clinic or to the hospital physically. Also remember, we have all these wearable devices which are getting better and better, which will also be able to give us a lot of inputs about the problem the patient is having. Of course, there's no replacement for face-to-face, but I think in today's world, it would be through telemedicine that this GP will again come alive.
Thank you very much, Dr. Mahajan. Dr. Pandit, if we could have your views on the resurgence of the GP back into the realm of healthcare field.
I think the general practitioners would be definitely required, and they actually have a very strong place in the community. However, we need to understand that the general practitioners, what we call now, will have to probably graduate to what I would sense as a family medicine person. Okay, so they need to have some more training. I think right now what we are doing is we are treating everybody who finishes his medical school as a general practitioner. That's not true. So even the people who work as GPs in UK or Australia or Canada, which are the 3 free public healthcare systems, they actually receive a formal training in family medicine. And that's very important. They will be then able to pick up the problems in a structured way. They would be able to solve them in a proper way. And they would probably pick up the referrals very quickly. Right now, one of the pain points is that the referrals happens probably a shade later than what it could have happened, or in some cases a bit early than what is necessary. Both are true. And I think we need to just balance that out by giving these physicians a proper training to be a family physician, rather than just calling them as GP and throwing them into the deep end and saying, now you manage patients. We don't really think that these patients need to come to us because we are specialists. You please find out a way. They need to be actually trained to do that. And I think, again, technology, I think, has been sort of probably going to be the game changer here. General practitioner will be able to manage more patients than what he does. And if with the training we are able to impart to the existing GPs as well, and make them a bit trained like a family physician GP, I think we will have a lot more structure in our healthcare system, which has been lacking. It is mostly an unorganized sector at the GP level, but we need to make it a bit organized, have these referrals more formalized so that we can have a good feedback mechanism, and the electronic health record then will start making a lot of sense suddenly.
Thank you so much. So I would definitely agree with the view which has been put forward, that currently only MBBS, which is the graduates, the medical graduates, are considered to be GPs. They are not fully equipped to handle the complete gamut of care which is expected out of a family physician. So that training is imperative. Learning from this and leading to the next question is, how important is then preventive care, and how has our focus changed as physicians, as communities towards preventive care? Are we now more tuned in for it, and are we geared up for focus on the preventive care such that the hospitalizations get reduced? Because in pandemic, what we saw was the resources were in severe crunch. What we needed were beds and oxygen beds, which were pretty much occupied many a times by people who may not have needed it to that level. So how do we ensure that the resources at the highest end, which is at the hospital level, are kept for the people who deserve it the most? Focus on preventive care being the question here. Again, an open question.
I think preventive care is very much the key. Of course, in a pandemic situation, it's very different. But when we talk of preventive care, we are talking of, preventing non-communicable diseases. And if they are going to come based on our genetics or the environment or the workplace, then we pick it as early as possible so that it can be treated early. To your point, in the pandemic, I think home health care also played a major role. And this is also a field which is coming into its own, from preventive health checks to the elderly care, to home health. All these have to be strengthened. Primary care has to be strengthened at the basic level so that we catch a disease early. And towards that end, actually, the government is planning the health and wellness centers, 1.5 lakh across the country. But we'll have to see, into what real structure they evolve. And then from there, a hub and spoke model is how it can work, supported by technology and telemedicine to provide access. Because as Dr. Pandit has said, we are so short of healthcare personnel, not only doctors, nurses, but even technologists, other ancillary healthcare workers. There's a huge shortage. So that's where we have to make use of technology. And just as with a huge shortage of landline telephones, we actually leapfrogged this telephone, mobile telephone. Maybe something like that needs to be done if we are to be able to provide access. And preventive medicine and wellness is going to play a huge role. And also, hygiene, water, sanitation, all of these go hand in hand if we are to prevent diseases.
So, Dr. Pandit, what was the impact that you saw between patients with comorbidities and otherwise? Because I'm linking it again to the preventive, responsibility. Every individual in the community is responsible for ensuring that the preventive care is focused on, right? So, what was the link that you found in your practice there?
Okay, Dr. Pandit, if I may come in before you answer, Dr. Garima, we may have to close in another 2 minutes because the next session panels are going late.
No worries.
I'll take 30 seconds to answer. Essentially, we know that comorbidities were the ones which were unfortunately bad. Patients with comorbidities are the ones who were unfortunately badly hit. And I completely agree that the prevention is better than cure. This is a proverb which we've always heard from our childhood, but we've actually never acted upon it. And I think that's what we need to do. We need to put in processes to identify communicable as well as non-communicable diseases, lifestyle diseases, and we need to bring in some form of a sanity in this overall process. And if we can do that, now is the time. Now is the time people are most aware of their health. People are most aware of this word called as comorbidity. I did not even know that such a word actually existed in my language, Marathi as well. So it's called as Sahavyadi. So I've learned a lot many things. I think we need to now harp on this and we need to point and focus on this.
Yeah. So thank you very much for your time, Dr. Mahajan and Dr. Pandit. It was very, very enriching, and I'm sure the audience would have enjoyed it. To just sum up the discussion that we've had, so technology as an underlying common thread to reach to a wider audience, greater access, reduced hospitalizations, use of technology to prevent hoarding and ensure an uninterrupted supply. Preventive care from a diagnostic perspective becomes the key for us to kind of move forward and take these lessons forward after the second wave that we have seen. So I do hope this session was informative for everyone, and wishing everyone a very good day. We sign off.
Thank you, Dr. Garima, and thank you, Dr. Mahajan and Dr. Pandit. Thank you for your valuable insights.
Hi everyone, I'm here again. Good afternoon. I hope you're enjoying the session as much as I'm enjoying. An absolutely phenomenal discussion. The last session left us thinking a lot of insights to know how one can look, the healthcare going forward. But ladies and gentlemen, before we start the other session, we have got this amazing partners with us, which is Bluestar, Polycab, Diversity. Then we have HN Reliance Foundation and Wipro Lighting. So these great brands, brands that we have seen and, been with them. Please visit their booths. They've got amazing solutions for you. It's very simple. If you're logged in, go to the lobby, go to the exhibition area, click there, and you will be into the exhibition hall where you can actually maneuver yourself and be in the booth that you want. If you are not able to go through that, which you will be able to do so, you can very easily click on any of the brandings or the panels of any client, Bluestar or Polycab. You will be ushered into Diversity, whichever booth that you want to go. So ladies and gentlemen, please keep shooting. And I'm told by my team there's a good audience and there are more number of people joining in. So it's very good to see on a Friday, 700 people entering in the audience, 1,300 plus registration. Thank you for all your love and support. We'll be back soon. Thank you, and do visit the booths, and I think the next session is going to be up very soon. Thank you.
Welcome back for the second panel. It's a very interesting panel of CIOs. We will be discussing about hospitals of tomorrow, how technology will transform the patient care. This panel will be spearheaded by Mr. Kalyan Mangalapalli, who is the director of NASCOM. He is responsible for running the Vizag Incubation Center. I'm going to keep the introductions very short because we are running very late on the session. Next, we have David. David is from Acer DM Healthcare, and he has worked for over 40 years and is currently serving as the Chief of Service Excellence at the corporate level of Acer DM Healthcare. Next, we have Mr. Rajiv Sikka, who is the CIO of Medanda Medicity. He is in the current role, he is responsible for the group IT functions covering digital transformation initiatives and IT operations. Dr. Nilesh Shah, he is the President and Chief of Science and Innovation Metropolis Healthcare. He is a highly respected Metropolis is a highly respected and multinational chain of diagnostic center. Today, he is managing a team of over 5,000 employees across the emerging markets of Asia, South Africa, and Middle East. Dr. Naresh Yalapragada is the Group Chief Information Officer, or KIM, and he is responsible in delivering IT projects to healthcare institutions under different categories. And he has been into the product development, consulting, IT implementation in India and US. Willow Williams is the CIO and Head Information Technology from Sir H.N. Reliance Foundation Hospital. She is an accomplished and performance-driven senior executive with over 29 plus years of significant techno-functional experience. With much ado, I'll hand over the platform to Kalyan to take this over. Kalyan, over to you.
Yeah, thanks a lot, Sujata, and thanks to, first of all, very good afternoon to all the panelists here and to the audience. Friday afternoon, that to post 2 o'clock is always a tough one, and I really appreciate all of you joining in. My name is Kalyan, and I'm your moderator for this panel. As Sujata mentioned, I'm a director at NASCOM, and we work on building the deep tech ecosystem which can assist the pharma healthcare companies to grow their digitization prospects. Today, as she mentioned, we have a diverse panel of healthcare practitioners. We're going to deliberate on how technology can transform patient care, and we'll be talking about the broad aspects of patient care and the opportunities and challenges therein of deploying some of these emerging technologies. Our goal is that whatever role yours is in the industry, that you'll come up with something new, a fresh idea or a new strategy that you can thereby implement. So let me kick off the conversation. I have a couple of points to start with, and then I'll ask the panelists to comment on that. Over the past decade, the mobile technology has definitely transformed the way we live in, and that's something that has also come to healthcare now. From artificial intelligence and robotics to virtual reality and connected devices, healthcare is at a huge transformation point. And this wouldn't have been possible without the convergence of various technologies, deeper storage, smaller processing chipsets, and longer battery life. So I would like to start the discussion first with asking Dave about what his views are on the service excellence part, specifically on patient care itself. Right? How would you define patient care, and what has been your experience from the outcome perspective? How do you think some of these initiatives have helped you? Dave?
Sure, great. Thanks for the question. And being mindful of the time, I'll move this along. But again, I'm a lay person. I'm not a physician. But from a service perspective, obviously, I think that technology, and especially things like telemedicine, home monitoring, things of that nature, have absolutely raised the bar for all of us. And I like to remind myself and others on a pretty regular is that we live in an insta culture today, right? Today's patient, today's consumer is used to, on their personal life, non-medical, push a button, get Netflix, push a button, have Grab, bring a Starbucks to our office, to our home, or whatever. And so today, the sense of urgency from the consumers around the world is immediacy, right? Patients want to be in and out of a telemedicine visit. They want to be in and out of a physical visit. They want it to start on time. They want it to end on time, and everything else. But I think I've been a fan and been involved with telemedicine since the late 90s, so quite a while. And certainly a lot of providers around the world who had the foresight to have telemedicine platforms were poised to pounce, I will say, when COVID-19 hit back last February, March, April of 2020. And so, I think increasingly we may never go back to the same we were, the same levels of adoption at the peak, maybe not for a few more years because a lot of people are going back to their old ways. But increasingly, I think the pandemic has absolutely accelerated the whole movement to digital technologies from a consumer perspective. And again, there's clinicians in the call, so I'll let them respond accordingly.
Sure. Can I ask Rajiv to respond to Dave's point? And also, Rajiv, since we're talking about telemedicine, that's a great point that Dave brought in. Could you also elaborate a little on what trends do you foresee, that are happening in this space, and how it has evolved even at your organization as you have rolled out some of these initiatives at scale? Rajiv?
Sure. So I think David said it very, very right. We have seen a couple of trends in the telemedicine in the last 18 odd months. Between March of 2020 to September of 2020, we moved 12 times in the telemedicine consult which were happening in Medanta. And not just the pie increase, but also very, very interesting facts which came out is that when we were launching, telemedicine, we were always under the impression that it is a young people phenomena, as David rightly said, that Insta culture. But then we realized that more than 50% of the patients who were using telemedicine in Medanta were all 50 and above. So that myth get busted. Another myth was that, it is only a city phenomena, while Medanta have more than 35% of the patient coming from the non-Delhi NCR. That's our catchment area. And then after telemedicine, we realized that roughly 40% of the patient was coming from UP, Jharkhand, MP, and Bihar region. So again, if you look into tradition in India, these regions or states are not supposed to be treated as forward-looking states. So this myth also got busted. So third myth was that, new patients will never come to telemedicine. Only the old ones, which are already captive of a particular hospital or captive of a particular doctor, they will only come. We realized that more than 40% of the patients who are getting registered for telemedicine are all new. Fourth thing which was there is that, we thought that, tech adoption is difficult for doctors who are very senior in age, and generally doctor means senior in age. And we were, that young doctors will adopt, older will not adopt. Again, this got busted. We have all doctors in Medanta now doing telemedicine consults. So these were like very interesting facts, and that's why telemedicine, as David said, that is going to stay. But few things which we are working now on is that we are introducing AI into this. What it means is that when doctor is doing telemedicine consult, he has in a physical world, he has more interaction with the patient. But now what we are doing is that while doctor is speaking to the patient, he's, talking about the medicines or he's talking about the diagnosis to be carried out. We are converting by, based on the symptom and a doctor way of working, we are picking up the complete diagnostics and complete recommended medication default for this particular patient. And doctor has a choice to drop or add few more. So his 80% of the time which he's devoting in writing that, prescription or documentation is going to get reduced automatically and reduce medication error. So some of these trends, will definitely be, will be very welcome by the clinical community. And I have a strong opinion that, as David rightly said, that this is bound to stay, knowing, what wonders we have done in last 18 months, where accessibility to the healthcare was a major challenge, and we have not been able to crack it in last 75 years, which was one of the dreams of our forefathers of the independence, that, education and healthcare, both of them are in shit. So this particular 18 months is kind of a window for all of us to see. And I am of the strong opinion that we'll do wonders with this tech.
Rajiv, that's a great point you make, and I would love to have Villu respond to this. Villu, what I would like you to probably dwell on is the integration with the EHR systems that are out there that the hospitals are deploying, right? A lot of what Rajiv said has to really be enabled by some of these enterprise level EHR systems. So could you please take us through some of your experience on that and maybe some of the challenges that you're facing there?
Sure, Kalyan. So I fully agree, first of all, with what both Rajiv said as well as what David said. We used the same principle, that is, the pandemic created an opportunity to bring telemedicine to the fore, and people who were not using it definitely started coming on board. However, we also must remember that telemedicine by itself is not a mobile app. We need to do a multiple features that need behind the scenes. So we brought in now we are using SAP as a complete HIS platform in addition to the ERP in Reliance. And we brought in a complete integration to every aspect of the teleconsultation first, which is taking an appointment. It had to go through the first step. Seeing the doctor's availability, getting a bill, getting a payment made through a payment gateway, which is not only a payment gateway to the mobile app, but also a payment gateway that would put in every update back into our SAP system. Whatever prescriptions were given, that had to get connected back to that patient's medical record, EMR, which is the OPD EMR, back into our system. The last part, of course, is that if doctors wanted to give follow-up visits, they wanted to advise something, some tests, they could give those advices easily. And yes, there are still more things that we are developing. So when we call this a telemedicine platform, it is really incomplete when we take it beyond a consultation by either integrating certain home care devices or by integrating wearables that can give us continuous data, clinical data of the patient when the patient is not visiting us, and so on. So all these integrations are mandatory to make it a complete telemedicine platform.
Yeah, that's great, Vilu. I would like to bring in Dr. Naresh here. Dr. Naresh, if you could address the few challenges that lies in there. I mean, I'm aware that you have spent a lot of time working with the regulatory bodies on the interoperability standards and the likes of such, which actually enable such wonderful integration and for the front end to really have such a user experience to it. So could you please elaborate a little bit on the kind of data standardization and the interoperability initiatives that are being done, and also please link it to the National Digital Health Mission that is currently underway, and please talk about a little bit about the challenges and what is it that specifically that healthcare providers need to look out for. Dr. Naresh?
Sure. Thanks, Kalyan. Thanks to Healthcare Radius for the opportunity as well. Before I dwell upon the role of standards and how standards and healthcare IT solutions really help the implementation in Indian healthcare context, I would like to take a step back and to understand what are the real challenges which healthcare is facing at this point in time in India, and then try to understand where standards could help us achieve those objectives we have for ourselves. So we're looking at a country where primarily it is driven by private healthcare. The public healthcare is state-driven. Central government has little role to play, which is obviously the one of the learnings which we had in the pandemic. So because in this context, me as a patient, I have my own records in paper with me. So if I visit 3 hospitals this week, I will have 3 different records to me, right? So whenever I visit a new hospital, whenever I go back, until unless I have those physical records with me, the next person who's going to see me doesn't have a clue of what my problems are, what are my medications, what treatments I've undergone in the past, etc. This is the context in which we are right now. And more from a private healthcare perspective, there have been very few success stories as far as an EMR implementation is concerned. But what we need is if we say, for example, if we compare this industry to a banking industry or to an aviation industry, today you can draw your money from any bank's ATM. Right? You don't have to say, for example, you have an ATM from a HDFC bank. You're not required to go to an HDFC ATM to draw money. You can draw money from any ATM, right? If you want to book a flight ticket today, you don't have to go to an Air India's website or Indigo's website to book a ticket. You can book it from anywhere you want. That's the phase at which the other industries have progressed. So coming back to healthcare, why can't we do that? Why can't I as a patient go to any hospital in India and avail my healthcare services without having to worry about if I'm carrying my the medical record, will that doctor have understanding of where am I, what am I, etc. So having put that context, what we need is a nationwide electronic health record. If that is the objective we are trying to achieve, what are the challenges in doing it? So one of the major challenges is because it is private-driven healthcare system, are the private healthcare players ready to share data among themselves, right? Our government or the public healthcare system has such a unique IT infrastructure where they can, share the medical information of patients across organizations. That's the one major challenge.
If you compare it to the Western world, maybe take UK or US, for example, where primarily the insurance driven, obviously UK is an exception because it's a socialist country, but if you take US, for example, it is primarily an insurance driven industry. So for faster processing of insurance claims, everything is standardized, right? Your provider identifier, your patient identifier, everything is standardized, which just makes life easy for IT systems to transmit data across organizations. Right. Coming back to the Indian scenario, until there are standards, obviously there are huge standards. You can take under healthcare IT itself, you have SNOMED CT, which covers a broad range of standards. You have HL7, which is a measuring standard. You have an ICD for diagnosis standard, etc. Standards are there, but until unless there is an objective, which is from the government side in terms of this is what we need to do and work backwards from there, then standards would really play a major role in integrating the systems together, so that a patient from this facility to another facility, it doesn't matter if you're going to a public place or if you're going to a private hospital, you have one national electronic health record through which the data can be shared and patients could be treated well. That is one point. Second point is from a roadmap perspective. What are we doing right? What are we not doing right? You rightly said the NDHM, which is in place now. NDHM has written very good, suggestions or the plan in which we want to implement this. So, for example, you take a health ID. So every person, every patient, every citizen of India, if you want to have a health ID, right, that is the starting point. So me as a patient, Naresh as a patient, have my own health ID. So wherever I go, I just show my health ID and all my records are available. Is it possible? Technically very much possible, but it involves a lot of commitment, a lot of focus from both the government and the private players to achieve complete interoperability in that context. That's what I have to say.
Yeah, thanks, Naresh. And that's where I would like to bring in Dr. Nilesh. Dr. Nilesh, healthcare is one sector where human element is as important as technology, and I think there couldn't be a better example than the diagnostics field where you're a leader. So, as a laboratory professional, can you please share some of those experiences when you have deployed, contactless and other technologies, how they have transformed the sector, and what has been the patient experience like? How has it evolved, Dr. Nilesh?
So, in the last 3.5 decades, by being in the lab, day by day, my respect towards IT has gone up by leaps and bounds. And I firmly believe that future CEOs of labs would be IT guys, because so much of innovation IT is bringing in this field and making patient life easy. And I see all round comprehensive input, whether it is cost, whether you talk about efficiency, whether you talk about quality, all the side, I think IT is big way contributing. And I will support with few examples. And I will try to balance between COVID and non-COVID kind of example, where I think IT has brought value. So as you know, in COVID time, we always talked about contactless, and RT-PCR was the word which was most used. And now RT-PCR day by day, I believe, will become more of a confirmatory tool. It is gold standard, but will stay gold standard, but it will become more confirmatory tool. And what will be taken over by some screening tool, which are coming up with a lot of help from IT, which will take scale. Like suppose in a football match, you want to invite huge audience and you want to screen all, you can't do RT-PCR for it. So you require some quick tool. So now you have a test where you just give a voice sample and it tells you whether you're COVID positive or not negative. It screens you. You have a breath test just on a breath on a chip, loaded onto a small machine, gives you quickly an answer. Same way you have a smell test when there is a card, QR code connected card, you scan it on a mobile app and you smell the card and you are asked some questions and you can answer the question and tells you whether you're positive or negative. And more than that, what I feel most excited about is an AI-based antigen test which has come up. All of you must have heard that COVID antigen test, frankly, the quality was big suspect. A lot of false negative used to come. But IT has played now vital role, where all these tests, instead of reading with naked eye, you read it through your mobile camera using an app. If you can go online, look for LookSpot, which is a Canadian company which has gone through FDA approval and everything. So artificial camera will read that line and hence the accuracy improves by 50%. So, it used to detect a CT value of 20, now it detects a CT value of 30, which is very close to RT-PCR. So I feel big change is happening and will keep happening on COVID side through IT intervention. I want to give you some more examples which are will club COVID, non-COVID both together in this, where many of the many of the statistical information which IT has been giving, which makes life easy for patient and doctor to take a decision. For patient, it brings more visibility. For doctor, it makes a big decision-making tool. Whether it is some statistics would give predictive information, some would give interpretive information, and some would give prognostic infection also. And 2-3 example I want to immediately come up, and then one example I want to take a little longer. When patient was screened for PCOS, polycystic ovarian disease, or patient want to be screened whether he is going for menopause, or whether woman's ovarian result score is good or not, you have to do battery of tests. And after doing battery of tests and imaging tests, at times doctors are still confused. Now you have a tool which puts all the information together and gives you one short answer whether the patient has got PCOS or not. And you won't believe many of these statistics are going for now clinical trial. And one last example which I have to give on tapestry pooling, so which will actually be a revolution in the industry, where you can pool the sample logically through IT software, and it can be 5 sample or it can be 30 sample based on positivity, and your cost substantially comes down, quality improves, and your efficiency improves. Just imagine 30 sample pooled in one test, your cost comes down by 30 times, and it's a single step pooling technology using IT tool. And so on. There are many tools one can talk about where IT is adding value.
Sure. Thanks a lot, Dr. Nilesh, and that's where I'd like to bring in Dave again. Dave, let's pivot a little and talk about who's the consumer here, right? And what is today's consumer expecting from their medical care provider? If you could maybe draw some light on that.
Sure, great, thank you. I'd be an honor to. So in hospital care, in hospital management, most consumers don't want to go to the hospital, right? So we try to build 3, 4, 5-star hotels with all the clinical services wrapped around and off stage, as the Disney model would suggest. But most patients really don't want to do there. So simply meeting the patient's expectation really is pretty easy in most hospitals worldwide. The reason I say that is because the expectation from most consumers of their hospital is really pretty low, right? So one of the things we try to do at Aster DM is remind ourselves on a regular basis, what our focus is to meet the needs of the customer, meet the needs of the patient, but exceed their expectations. And we're not where we aspire to be, right? So we're a work in progress. We're in the first year, probably a 3-year journey at this point, but our focus is to create wow factor. Our focus is to try to mature to the place from a service perspective, where our patients are discharged or they walk away from an outpatient visit, a clinic visit, or a hospital stay and say something was different about that interaction. I genuinely felt empathy from my physicians, from my lab technologists, from my nursing staff, things of that nature. So, again, from a timeliness perspective, I mentioned the phrase in my previous remarks about today we live in an instaculture worldwide. And so the expectation of today's consumer is to have really everything in fairly near time. And again, not to be totally self-effacing, but one of the challenges, we can have all the nice digital technology we have, right? We can have the best EMRs that are out there, but if the physicians are not actually using voice to text, whether it's Dragon or some other model, if they're not using scribes, if they're not actually entering the data in a digital format, then it's for naught, right? Great technology. There's a country song, I think, in the U.S. entitled "The Road to Hell is Paved with Great Intentions." So it's great to have good intentions, but the devil, I think, is often in the details. And one of the things that we're challenged with from time to time is, so we get the patient's lab results back, we get their imaging results back, but how quickly do we get back to the patient in the channel to which they want to receive the results, whether it's WhatsApp, whether it's secure text, whether it's secure email, whether it's a phone call. And right now it's all over the map, right? We've got different consumers have different preferences about how they receive that. But the whole sense of urgency, I think, it needs to be increased, not just with our organization, but in others. And just final note, I would say, There was a book that came out about 19 years ago that I tend to use the title of it. It's not the big that eat the small, it's the fast that eat the slow. And we need to get faster, never losing sight of quality. Don't misunderstand me, or safety. That's not the intent. But assuming that that's the case, we need to condense the whole compression expansion theory of physics. We need to do some compression on a number of our different gaps. And I think that's an issue with a lot of providers worldwide. So it's great to have the digital platforms, but the devil's always in the details and how we actually implement it. So hope that helped.
Yeah, thanks, Dave. That's a great segue into what I'm going to ask Vilu next. Vilu, as Dave mentioned, the devil is in the details, and EHR is one such platform where I guess there have been a lot of challenges with physicians and nurses, filling up the data manually into the EMRs and EHRs, at least in the past. So from a CIO perspective, can you dwell some light on maybe the newer technologies that you're looking at, such as appointment scheduling softwares that you mentioned, or wearable technologies where you're automating this data entry into the EHRs? Vilu?
I think she had to drop off.
Yeah, if Vilu is not there, I would like Dr. Naresh to kindly take this question. Dr. Naresh?
I think, Kalan, one of the main reasons for me where the uptake of EMRs have not picked up in hospitals is the whole, the doctor and the nurses fraternity not liking to use them, right? So if you dwell into the reasons why it is so, one is primarily our education system from day one has been on paper, right? So doctors, nurses, right from their medical school days have been, trained to write, and obviously they think that it is more positive for them, the flow of thought is there, etc. Second, having said that, that's a negative part of it. From a positive part to it, the kind of value add which an EMR can provide to a nurse or a doctor is phenomenal, right? And if I'm sure there must be studies across the world which can compare the quality of care a patient can receive in a hospital with paper and with a hospital with a full-fledged electronic medical record would be quite significant, right? Obviously, see, it's a journey which an organization should take, right? It will not happen overnight. Until unless there is a physician or a nurse buy-in into the system, it will not happen. If you ask me personally, three major approaches or success factors which would influence the uptake of an electronic medical record. One, it has to be a top-down approach. The management has to be really focused and serious about implementing it, right? It cannot be a bottom-up approach, one. Second, the choice of the solution is what matters, right? Obviously, every nurse and a doctor has multiple things to do, right? If you give them a solution where it has, for a single activity, say for example, ordering a drug, if you ask them to click 10 times on a page and order it, nobody's going to use it, right? The selection of the system would make sense. Third is you have to, within the team who's implementing electronic medical record, on a personal experience, I can suggest you need to have physician champions as part of your team. Physician champions who understand the benefits which an EMR can give, right? The benefits which a clinical decision support system in EMR can give, right? Until unless you have all these three sorted, for me, I think EMR implementation will always remain a challenge in Indian healthcare system.
Yeah, thanks, Naresh. That's what I'd like to bring again Rajiv back into the discussion. Rajiv, we did speak about the role of NDHM and the opportunities that lies in probably connecting all the ecosystem together so that it enhances the patient experience, right? So can you just, and you have been a vocal, I think you have been a vocal author too in terms of, talking about some of those. Can you please shed some light on that, on what exactly, can you just give a little bit of detail, maybe 2 minutes on that, and then maybe we could take the question from there.
Sure. So, when we talk about NDHM, according to me, it is nothing but a collaboration between various service providers, be it public and private, and not just, but across the value chain, doctors, PSCs, diagnostic labs, farmers, hospitals, insurance firms. So why, it is important to share this information across this value chain, because what happens is the basic stuff happens. Unnecessary and repetitive tests will not be happening. And both of them have huge burden to patient as well as on the hospital side, it delays in the treatment plan. Now, just imagine that if we have this information across, value chain, and if we implement it very rightly, when I say implement rightly, it means that I'm going to correlate with geographies and hotspots with disease pattern. So what will happen is that it will become a very robust base for my treatment planning part, and more so for chronic disease management, and country is full of chronic diseases. So now with this planning in place, I could have more focus. At one side we have severe shortage of budget, and on the other side we are not putting our money where the need is. So with once we have this pattern with us, we will do very, very focused coverage in terms of budget provisioning for implementation and rollout. And that's where I think, according to me, NDHM will play an important role. And the whole concept is there. Dr. Naresh mentioned about health ID. There is a service provider ID. So what will happen is that once it's a basic tech, it's not a rocket science tech kind of a tech. It's a simple system of records, which is nothing but my EMR and getting, ported from one service provider to another service provider. And again, I'm, going to divulge on what Dr. Naresh said. See, when we were, a couple of years back, when mobility was at its peak, we have a major problem of services coming from 3-4 captive providers. And then country 4-5 years back moved to mobile number portability. And that's, I think this NDHM will ensure that there is a doctor portability, there is a service provider portability, and that's what we need. We can't be captive to one particular doctor, and we can't be captive to one particular region. Most of us are mobile workforce. Tomorrow I'm in Bombay, day after in Hyderabad, and so on and so forth. So according to me, this is what NDHM or connected hospital will bring to the table for us to move towards the next orbit of healthcare in India.
Great, Rajiv. Dr. Nilesh, you have been obviously very closely involved during the whole COVID times in terms of integrating with ICMR. Of course, the kind of caseloads that one saw, and even in terms of reporting, right? So I just want to take off from where Rajiv left, and would like you to address, right, what has been your experience and how has it changed the way you're thinking about your new investments in IT or technology when it comes to the laboratory management or in the diagnostic sector, Dr. Nilesh?
So you want me to say more on COVID respect or COVID respect?
No, ICMR reporting has been really the key, right? As Rajiv mentioned, that there is this whole idea to integrate all the systems together so that it enhances patient experience. I think that's something that has happened at scale, at least on the ICMR reporting part. So what has been your experience, and how has it changed some of the ways you're looking at new investments in IT or technology?
During COVID time, if you remember, all the labs actually became overwhelmed and nobody was able to give reports on time, nobody was able to manage loads on time and so on. Initially, I can understand it was more of a back-end issue where processing of the sample and all were a challenge. But very soon, most of the lab recovered and they practiced it well, how to get the results fast. What was biggest bottleneck was our data management. So collecting patients' data, putting in this RT-PCR app, posting it back in ICMR portal, and again being accurate for everything. And the equipments were such that all the full 100% interfaces cannot occur. So data management was completely a challenge. Now when we talk about digital health mission, national digital health mission, we are talking about managing data as a single source and accessibility, of course, controlled accessibility across. I think that can bring big revolution, not only in COVID situation, but also in non-COVID situation. It can bring big revolution. One of the biggest challenge which labs today face is ensuring that there are no clerical errors. And data accuracy and data management is the biggest challenge which we feel. And this kind of a drive with the IT health would be a big boon to the whole industry, I think.
Great. So Dave, would you like to respond to that, maybe with your experience on wearables and some of those other technologies that you have probably deployed? Has it helped improve, let's say, data accuracy or timeliness, Dave?
Great question. Yeah, I think that it has. I think we still have a long way to go. So I echo the comments of my colleagues on the call. I refer to, I think increasingly, if AI is not built into a lot of the data centers that we have, I think increasingly we're going to need health data analytics and analysis in big ways. And I mean, mathematicians and engineers and everything else. I refer to it as mining through piles of gold piles of coal for diamonds, right? So it's great to have wearables. Again, the devil's always in the from a pragmatic standpoint, how it's actually executed. So it's great that we have wearables that notify the patient and perhaps their primary care doctor that their hemoglobin A1C is high, but what's the action item, right? If the physician or the physician's office is so inundated with diabetics, then it's going to be very, very difficult to actually bend that curve, to actually make that an actionable piece of data, turn that data into information. So I think, I think we're a lot further than we were 10 years ago. I think we've got a long way to go to actually utilize, make the data that we have at our fingertips to really make it actionable. So I think if I know our organization, AstraDM, we saw close to 20 million patients last year alone. And so when you look at all that, think of the opportunities. Think about the care opportunities in 20 million patients, hundreds of millions, if not billions of data points with all, I don't even want to know. It's the number so big. But to actually go through that and build out algorithms and everything else to really build an efficient model for really helping our people with CAD, with CHF, coronary heart failure, with hyperlipidemia, with diabetes, with asthma, with some of the usual suspects, we would say, from a disease management perspective.
Sure. Before we go ahead, just a time check, Sujata, how much time do we have in the panel?
We have another 20 minutes.
Okay, great. Just want to be mindful of that. So Dr. Naresh, just taking off from where Dave left, the olden model was really about data centers, and now it's all about cloud, right? And even within cloud, we're talking really about how can we make it more AI enabled, right? What kind of information model should be used? Again, it falls into the standards, but I think from a CIO perspective, could you dwell some light on that and how you are probably re-engineering some of your own architectures, how you're thinking through that, and what's really the impact in the boardroom, right, when you have those conversations, Dr. Naresh?
Well, Glenn, for me, two things is which is the better one to manage, right? Do you want to own the data, keep it in your data centers and run it, or do you want to keep it in your own cloud somewhere outside, or do you want to put it on the public cloud, right? Three parameters. For me, from a legality perspective, until unless we have a rule, something like a GDPR or something like a HIPAA, which is available in India, and every hospital needs to comply with it. Obviously, people would go onto the cloud because lesser capex investment, less headache to manage. The provider himself would manage the data and the security, etc. But for me, I think it all boil down to the each individual hospital's decision, right? The management decision. But if you ask the management thing, which is more economical, obviously the cloud over a period of time, because initial expenditure would be less, the ROI would be less, etc. But I think from a security and from a usage perspective, the way it matters is how well you structure the data on your servers, right? So it's just not, the location matters, right? The way in which you structure the whole architecture, right, is what it matters for me beyond what we put it on the local server or we put it on the cloud.
Yeah, thanks, Naresh. And Rajiv, this is where I would like to bring in, when you were doing your AI-based, tuberculosis diagnosis projects in India. So how big a role did data play in that, right? As Naresh mentioned, Dr. Naresh mentioned, there's a lot to do with data structures, and even if it's in a server or in a cloud. So how has your experience been, and what has been some of the learnings there, Rajiv?
Sure. I think very relevant stuff. And it is like, very famous line that one size doesn't fit all. So cloud is a natural choice wherever we are with respect to common set of application used across in the enterprise, and we are slowly transitioning towards that. But let me take an example of this particular case, TB. Let's understand the context. What we do is that we run India's biggest CSR on the communicable disease, which is TB, and we call it the TB for Haryana. What we do is that we send vans equipped with X-rays to a district or a small village. And then, in a particular run, we have roughly between 160 to 220 odd subjects which comes for diagnosis or screening of TB. There is a radiologist, there is a chest X-ray technician. So what we do is that we have 220 odd or 200 odd X-rays which are coming out from the modality or X-ray machine. now for a radiologist to see each of these 200 x-rays and figure it out who has a TB and who doesn't have a TB is a mammoth task. And these are, please understand, these are like daily wages labor. They can't stand in a queue for full day because their wages are getting impacted. It is very difficult to hold them and bring them to the van to get this test done. So we were facing this problem that, by the time x-rays are done, by the time scan results comes, subject is not around. So we implemented, typical AI-based solutioning aspect where once the scan comes from the modality, it goes through that AI box and it gives me a report. So there are, 40 cases which comes as a potential, knowing that false positive and false negative situation. So in this particular case, radiologist doesn't have to see all the 200 odd x-ray. He has to see just 40, which is very fast. Now, but if I could have think about putting this whole AI solution in my cloud, it could have never worked because there was a severe issue with respect to internet connections in those areas. So, and what we were doing is that it was a wired box between my AI box and the modality machine. Now what happens is that how AI is going to improve and ML will be implemented. So we used to do a regular update once in a month on this AI box in the local environment. So in this particular case, cloud could have been clear cut, no. So what you have to look is, what is the solution you are trying to implement? Tech is never sexy. Use case or applicability is more attractive and more sexy. That's what you have to concentrate on.
Right, Rajiv. So would you like to respond on this, Dave? I did hear you earlier talking about the role of radiologists and maybe some of the, I would say, responsibilities taken over by AI. So would you like to take a quick stab at that, Dave?
Yeah, I'll preface my remarks by reminding the audience that I'm a layperson. I'm not a physician, and clearly what I'll say doesn't necessarily represent my employer's views. But I think if we look objectively at the data worldwide, we have, and we knew this long before COVID, we have a significant shortage of primary care physicians, general practitioners, and internal medicine physicians in so many countries around the world, right? And I think, again, we continue as a society at large to expect everything for everybody, right? So universal health coverage doesn't necessarily mean everybody gets a knee replacement within 24 hours from when they decide they need one or anything else. So, but given the, it's not a finite pool or a finite supply of physicians and advanced nurses, we certainly, we could reallocate stuff. And so I think one of the thoughts that I have is that over the last 15, 20, 30 years, the major companies like GE, like Philips, like Siemens, have collected truly hundreds of billions of images, and from regular digital x-rays to CT scans to ultrasounds to MRs to PET scans, on and on and on. And so given the fact that certainly I believe that the pandemic has illustrated to the world that, again, we need more intensivists, we need more internists, we need more family physicians. I'm wondering at what point when some country pulls the trigger and says, look, we don't need to have X thousand radiologists doing this. We're going to hang our hat on the hundreds of billions of images that have been analyzed, and we have artificial data that can predict within 99 plus, maybe even 6 sigma, the accuracy of especially something like a fibula break. Is it broken or is it not? So again, I think there's so much advancement that have been made. I don't think we've come close worldwide to taking advantage of all the knowledge that we have built up. So, we hear about and we talk about machine learning and everything else. Again, I think as we move forward, it would be intriguing to me. It's not a way, maybe it's a way of rationing. I'm not necessarily suggesting that, but if we could free up 50, 60, 70, 80% of radiologists and go through some retraining, I don't mean to put them on the front line necessarily dealing with patients day to day. I think that would be an opportunity long term to help in the relative near term, to expand the denominator of caregivers. Those are my views.
Great to hear, Dave. Dr. Nilesh, could you, if you really step back a little and look at some of these technologies that are coming in and how it's transforming the entire ecosystem, do you believe that this rise of remote care, will it lead to hospitals without walls? Dr. Naresh?
I would comment more on the lab side, and lab side, I'm not expecting it to be without walls for some time, because as a lab, we have to maintain humidity, temperature, so many things. However, automation will keep scaling up much bigger and better. We have just seen 1.5 years of pandemic time. COVID test itself has evolved so much that what throughput we used to give in the past and what confidence which we used to have in early days to now has immensely increased. So if I can tell you about one test, imagine if you multiply with all the tests, the automation involvement of IT is easing our life, not only for laboratory professionals, but also for clinicians and patients. So I am expecting the output and quality will substantially increase. And since I'm talking about quality, I just want to give one more example, a relevant example. Traditionally on quality, we have to run some controls and calibration and check whether every lot of results which are coming out are accurate or not. Now the days have come where through IT we have now moving averages. Now moving averages monitors my quality of result every moment, and I could be sitting anywhere and lab could be anywhere, but I can manage to check whether all the results are going in good quality or not, and as soon as there is a deviation, I can put a stop to it. Now these kind of tools, which when we keep getting it, I'm sure our life will become easy, results will become more reliable, and ultimately it will be a good patient care in your life.
Great. That again brings me to Naresh. Dr. Naresh, could you shed some light on the automation within, let's say, some of the shared services areas, dealing with RPA or such, such innovations, Dr. Naresh?
Well, I think robotic process automation, I think we've ventured out, not fully, but I have seen some successful installations of the robotic process automation. Will it help all processes in a hospital to automate? The answer is no, for me at least. There are certain mundane processes which could be, automated through an RPA solution, right? So, for example, the most common example I can cite is, fetching out information from, these organizations to which we submit our claims, right? So there are at least 2 or 3 people whose day job is to just pull information from their websites, put it on Excel sheet and give it to the people who need it, right? Such mundane jobs, I think, could be automated. But again, it depends on the need and what the demand is, right? But such solutions have really seen good implementation in some areas, what I've seen. But it has its own limitations, is what I see.
Great. Billu, would you like to come in, and I would want you to address here on some of the remote monitoring, I would say, technologies that you have used within your hospital and otherwise, and the ramifications therein, Billu?
So let me correct one thing. We have not gone live with many remote monitoring systems, but we have tested quite a huge bunch of them. And we have integrated 2 vendors with our telemedicine app. But again, it is not really put out on a live platform to absolutely use it. So very soon we are going to go live with, this, IP patients or inpatients for their monitoring while they are on the bed. But every time a nurse has to come into the room, if you have to measure the temperature every half an hour or take vitals every hour for certain ward patients I'm talking about, then we definitely are going to now automate that entire process where there is absolutely no intervention of the nurse. She can just sit at her station and we can monitor these patients directly for all their vitals integrated with our EMR, and while the patient is on his or her bed. Second, what we are doing is we've also created an EICU environment with a command center, but we have done that for one of our remote COVID facilities, that is at NSCI, and we're also going to extend that to other COVID facilities that we had created already. So we have got, then the third part is the smart ambulance, from where we are doing a lot of remote monitoring. We have created a small command center in our own ER, where senior consultants can sit and they can look at this. That is also already live, but we have to, put it on the road for the patients in real time, because all our testing and stability issues have been now ironed out. So we are blessed with one of the important factors is that we have got the geo network behind us. So as a corporate, we have got a lot of backing on the network front, which is a key requirement for any remote connectivity.
Right.
So yes, so while we are all moving into the 5G network, we are still currently live on the 4G, and we'll soon be moving into that. But yes, bandwidth is an extremely important factor for good remote connectivity, and that is why it will take a little more time, I feel, for the general public to come on board with remote connectivity, because however well we connect our own hospital with all the infrastructure for home care, for wearables, for wherever the patient is, to relay the data, clinical data to us in real time as fast as possible, they will need good connectivity at their end as well. So unless they don't adopt those kind of requirements, the wearables which are flooding the market may not be really impactful.
Vilu, those are great insights. Now that we are 4 minutes away from the close, I would want to put all the panelists on the spot here and just maybe take 30 seconds each and talk about, I'll start with you, Dave. What's your most counterintuitive, half-crazy prediction about the next 5 years in the industry? Dave.
What's the question again, Doctor?
What's your counterintuitive, half-crazy prediction for how technology will transform some of the things that healthcare industry is doing?
Oh, I'm very bullish. I think, I hate to say there may be a silver lining to this pandemic because it's been so traumatic to so many families worldwide. But I think it's really shed a significant amount of illumination on really where our deficiencies are. And earlier in the conversation, one of the other speakers was talking about, we need to have increased emergency reserves in so many areas, given the potential break to supply lines and things. From a technology perspective, I'm even in personal investments, I'm very bullish on the whole health data technology and health technologies and home devices and everything else. I just think, I think the next 5 years are we're gonna accelerate adoption worldwide. That's my opinion.
That's great, Dave. Rajiv, again, 30 seconds, quick one.
On a B2C side, I think mobility definitely. And on B2B, which is the enterprise, I'm of the opinion that virtual reality is something which is going to play a big role, because skill is still a major issue when you talk about service providers. And it's a Hindi phrase, so David, you will not be able to understand. We have only one Dronacharya for Kauravas and Pandavas, while we need many of them, for this 1.4 billion people. And VR is going to play an important role in the B2C space.
Dr. Naresh?
I think, Kalyan, I'm an optimist. I would obviously like technology to be used primarily in every phase of healthcare, especially in India. But I would see the role of AI and machine learning in healthcare will take up speed. Right? If you ask me personally, are there real-time successful use cases of role of AI and ML in healthcare? May be true, may not be true. But at least in the next 5 years, I see the role of AI will play a significant role in the way we treat patients in the time to come.
Thanks a lot, Dr. Naresh. Again, Dr. Nilesh, a quick 30 seconds remark.
I would tell for two sides, one lab technology side, how their life will change, and I would say pathology side. Lab technology side, middlewares, total lab automation, robotic labs, all that will take over the hard work, and the labs will become much more efficient, accurate, and people-less. Whereas pathologist, the two roles which he plays, one is a lot of microscopy related decisions, so visual interpretations, and secondly, signing of the reports. Now, signing of the reports, I feel in majority of areas, artificial intelligence will take over, and there will be reports signed by computer, no more by pathologists. That will happen, except one or two areas I'm doubtful, like histopathology and some such areas. As far as microscopy and visual interpretations are concerned, a lot of AI will be in place, a lot of image analysis will happen,
and same interpretation will come in much better accurate format in future.
Thanks a lot, Dr. Nilesh, for sticking to the time again, and thanks to all the panelists. Just to sum it up, I think we have had a great panel, great views. We have covered a lot of ground from enterprise IT to wearables to the role of AI ML, and I think one thing that has come out very clearly is each of these implementations are case specific. They are specific to the hospital and the kind of environment that you're looking at, and B, as you said, no size, it's not all size, one size fits all. And B, the human touch cannot be looked away, right? One has to factor that in, whether it's in terms of user experience or otherwise. And C, the most important part, I think one has to again look at metrics, maybe putting some hard metrics around patient care and looking at how one can improve the service excellence part. So I think that again, great panel. Thanks a lot for bearing me for the last 1 hour, and it's been a great illuminating discussion, not just professionally, but I think personally I've learned a lot. Over to you, Sujata.
And before we close, Kalyan, you have been a wonderful, very calm, poised host. Thank you.
Thank you. Thank you.
Thank you, that too. Thank you.
I second that. Thanks, Kalyan. Thanks for steering this conversation wonderfully. And thank you everyone for taking time out. Thanks especially to Willow, who came even during her busy schedule, and thanks Dr. Naresh for staying even when we had a different meeting. And thank you for the very insightful points that you guys have mentioned. Thank you, everyone.
Thank you. Thanks a lot. Have a great day.
Thank you. See you.
Bye.
Thank you, everyone. Our last and the third panel is on strengthening India's healthcare ecosystem. So till now, we learned from all our panels about the technological innovations and the technological disruptions that are happening. So what needs to be done to implement this implement the digital ecosystem that is the need of the hour. So today we have a very strong panel of leading CEOs from the leading hospitals from across India. And steering this panel is Vishal. He is a very adept founder and innovator and a venture capitalist. So he will be steering the panel. So today we have in the panel Dr. Deshmukh, Dr. Hemant Deshmukh. He is the Dean and Dean of the KEM Hospital, and he specializes in the treatment of complex vascular interventional procedures, including treatment of aortic aneurysms and limb salvage procedures. He is the author of multiple articles and the peer-reviewed medical journals. Dr. Sujit Chatterjee is the CEO of Dr. L.H. Hiranandani Hospital, and he has been the CEO since the inception of the hospital. And he is always focused in processes and quality. He leads the Hiranandani Group to arguably the first public-private partnership in healthcare with Navi Mumbai Municipal Corporation. We have Dr. Nandakumar Jairam. He's the ex-chairman and GMD of Columbia Asia Hospitals. He retired just 15 days back, and he is the chairman of he was the chairman of NABH under the auspices of Quality Council of India and the past chairman of Health Services Committee of FICCI. Dr. Taran Gyan Chandani is the CEO of Sir H.N. Reliance Foundation Hospital and Research Center. She has around 20 years of experience, both national and international, in acute and long-term care operation, as well as multi-site management in the public and the private sector. Mr. Jitendra Harin is the CEO of Jaslok Hospital and Research Center. He is an associated member of the Institute of Chartered Accountants of India, and he qualified in May 1998 in the first attempt. Harin has worked in various areas of healthcare, that is managing an integral role in quality initiatives and different areas of finance. And he is the only finance member in this panel. We have Mr. Himanshu Jain. He is the president of Diversity. He is currently leading Diversity India and subcontinent as his president. He is a member of executive committee of Diversity. He has been with Diversity since 2003 and with close to 3 decades of experience as a business professional. Now, steering this conversation is Vishal Gandhi. He is the CEO and founder of BioRx.
Vishal Gandhi is the founder. He has over 20 plus years of strong experience of strategic advisory deals in terms of investment, mergers and acquisition. Over to you, Vishal. We will have a quick round of self-introductions also, if anyone wants to say anything, and then we take it forward from there. Thank you.
Sure. Thank you, Sujata, for the kind introduction. I would like to thank ITP Media for yet again wonderful opportunity for me to be moderating this significant thought leadership session. And good afternoon to all the participants attending the panel discussion. And it's my deep honor and deep privilege to moderate a session on the most impactful theme in normal times titled Strengthening India's Healthcare Ecosystem. I must say we couldn't have asked for a better medical management practitioners along with the best solution providers as a panelist for this discussion today. I am deeply encouraged by each of the panelists' presence and their ever increasing commitment to enable more private sector participation in mitigation of the current challenges what we have witnessed. We have a diverse panel and we have equally diverse audience from length and breadth of India. I am convinced that the panel functional expertise will present a synergistic perspective, will be a great value to all the audience. And as Sujata introduced each one of them briefly, I would, since we have a kind of a constraint of time, I would like each one of them to also do a self-introduction. To start with, I'll request Dr. Hemant Deshmukh to self-introduce. Over to you, Dr. Deshmukh.
I'm Dr. Hemant Deshmukh. I head the Twin Institutes of St. G.S. Medical College and a tertiary care hospital that is famously known as King Edward Memorial Hospital. I have been the dean for the last 3 years and I have had enough of healthcare experience, right from innovation to patient care to research and funding patterns of medical devices in the institute that I am actually handling right now.
Thank you so much, sir, for a wonderful and brief discussion, introduction. May I turn to Dr. Sujit Chatterjee?
Hello, everyone. I'm Dr. Sujit Chatterjee. I'm ex-armed forces, and I'm a gynecologist by profession. I trained at the Tata Memorial Hospital in gynecology and oncology, and at the same time, I set up a number of institutes. I left the armed forces and have had brief stint with the infrastructure leasing and financial services. And I am, since 2002, been with the Hirandani Group and am the chief executive of the Dr. L.H. Hirandani Hospital, which is a 240-bedded tertiary care hospital in Mumbai. Thank you.
Wonderful to have you, sir. May I turn to Dr. Nand Kumar Jairam, please?
Thank you. I am a surgeon by qualification, and I had 14 years of academic surgical experience before my passion in medical administration and healthcare quality got me. I have been an administrator in various hospitals in Bangalore, and for the last 17 years associated with Columbia Asia Hospitals, which grew from 1 to 11 hospitals across the country as its chairman of the board and CEO. I have laid down my office 15 days back and currently an independent healthcare consultant and an advisor to the Manipal Group.
Wonderful.
Pleasure to be here.
Thank you so much, sir, for your presence. May I turn to Dr. Tarang, the lady in the panel? Dr. Tarang, you need to unmute. I know we are all used to this now, but still sometimes it happens.
A very good evening to everyone. I am an orthopedic surgeon by training, and I have been into administration for more than 20 years now, out of which almost 13 to 14 years have been in Singapore, where I've worked with the best of the institution, including the Ministry of Health, for managing the various healthcare systems. I lead and do the healthcare management as a desire, but quality, patient safety, and innovations and technology is something which remains as a passion, And luckily, I've been in an ecosystem where I've always found a very good balance between the desire and the passion. So that has been a very nice experience all throughout. At the moment, I am leading Sir H. and Reliance Foundation Hospital and all the healthcare initiatives of the hospital for the corporate as well as for the various COVID initiatives. So, and with that, we have been able to achieve lots in terms of satisfaction of our patients, whether it is at Seven Hills or at NSCI or at Sir H. and Reliance Foundation Hospital. So looking forward to a great session and learning from everybody here.
Thank you, Dr. Tarang, for the crisp introduction. May I now turn to Himanshu Jain. Himanshu, over to you.
Thanks, Vishal. I've unmuted. Thanks, Vishal, for this opportunity. I'm a chemical engineer by education, and I worked with a few business companies, including Unilever or HLL as it was known then, and ExxonMobil before finding Diversity, where I felt it was my calling. And somehow I identified very early on with the hygiene and propagation of hygiene in different industries and areas, and have been with this industry for the last 18, 19 years, purely for the love of the industry. And it's a great opportunity for me to be in this company of august doctors from the country and leading healthcare practitioners, administrators, and learn from them during our discussion. We'll share whatever I've learned so far, and we'll be happy to learn from all of you.
Great, Himanshu. I must say that you have a very unique role to play in this panel since you represent the solution provider space, and I think that's a very, very significant space in current times. Last not the least, which is Jitender. May I invite Jitender to do self-introduction? Thank you, Jitender.
Yeah, hi. Good afternoon, all. It's nice to be here among all of you. My name is Jitendra Haryan. I am a passionate qualified chartered accountant. I qualified in May 98. 23 years of post-qualification experience. Last 12 years I'm in healthcare. Specifically for last 7 years I'm in Jaslok. And since last 3 years I'm at the position as a CEO of Jaslok Hospital. So currently we are going through the infrastructure transformation and very critical stage at the moment I'm taking this hospital through. So looking forward to learn from all of you in this session.
Thank you, Jitender, for the crisp introduction. So we are all now set to segue to a wonderful panel discussion, and please allow me to present a few facts in front of you for setting the context. So I think today's session not only is very insightful, but it's also directional in terms of the policy reforms required to strengthen the Indian healthcare overall ecosystem, and not just from the delivery perspective, but starting from innovation to delivery, and what I call is bench side to the bedside. COVID-19 has actually brought a major disruption in the healthcare industry in India, an awakening call to reboot the way healthcare is delivered in India. Somewhere deep down, the recent pandemic has made us somewhat realize how important it is to continue strengthen the healthcare ecosystem, and more particularly post-pandemic for the economy, and it is indeed absolutely a necessity to make healthcare accessible, equitable, and affordable for the sustained growth of the economy. I would also like to stress upon the word healthcare is always related to the delivery aspects as in healthcare providers, and sometimes we completely miss the research and development related to drugs, medical device, pharmaceuticals, biotechnology, vaccines, and so on. It's important to see that how healthcare systems from the value chain of the bench side where the innovation takes place to the bedside where the final delivery happens. Make in India approach, higher spend on R&D, robust clinical research, quality in healthcare delivery are all equally important parts of the healthcare ecosystem. Hence, the integration of all this needs to be thought through to lead the nation by the way of healthcare-based Indian economy. It's worth mentioning that India is now net exporting some of the products that such as PPEs, diagnostic kits, COVID drugs, COVID oxygenators, when India was not even manufacturing all this pre-pandemic, and today, we are exporting. So I think this speaks about the Indians' manufacturing strength and how to see an opportunity within the greatest challenge that mankind has witnessed in last 100 years. There has been immense push to achieve this goal from all the key stakeholders, including the government, which is trying to push healthcare spending to a greater percentage of the GDP, which includes a higher commitment to public research in the area of healthcare, pharmaceutical, and biotechnology. So I will now turn to Dr. Hemant Deshmukh, the Dean of KEM Hospital, who's playing a very unique role because he's in a medical college and also in a medical hospital. So, Dr. Deshmukh, what policy reforms can we realistically expect, and what is government doing currently to support businesses in healthcare so that we can respond effectively in the near future, if at all COVID third wave happens? And I'm kind of confident now that we are getting there somewhere, but it is sad, but I think we need to be prepared for that. So over to you, Dr. Hemant.
Yeah, good evening, everybody. The basic, the push towards universal healthcare, that the denominator for all medical facilities and healthcare facilities is universal healthcare. Now, when we say universal healthcare, it simply means that all individuals and all communities should receive the health services they need without suffering any kind of financial hardship. This is the basis of all the healthcare system that anybody can deliver to the patient. And when we say this, what we understand is that non-CB said omnibus means that you treat others and not for self. It is for others and not for self. It is for the patient and not for the self. So it simply means that the patient is the center for all activities, whether it is a medical care, the doctor or a healthcare worker. The patient is always going to remain the center and the center point of attraction for the healthcare providers. Now, it includes the full spectrum of essential quality health services. It not only includes curative, but it starts from health promotion to prevention and treatment. It doesn't end at treatment of any health problem, but it also ends with rehabilitation as well as the final thing, what we call as palliative care across the entire life course of a patient. Now, good health will always mean that the most vulnerable need to be treated. Now, it also includes, it also allows children to learn, adults to earn, helps people escape from poverty. This is the underlining theme of universal healthcare, and which we want to attain whenever we want to go into the next decade after witnessing the entire COVID scenario in the last 15 to 18 months of these 2 years at all. Now, moving towards universal healthcare requires strengthening of the health system in all countries. Now, India being a slightly impoverished state, the whole idea about delivering universal healthcare will require robust financial structures in place. Now, when the financial structures
I'm sorry,
Dr.
Deshmukh, you are not visible. I'm so sorry. Can you come on your screen as well, please? Your video is missing.
Oh, I'm so sorry.
I'm so sorry. It's such a great conversation, but your video was not there.
Now?
Not really. I understand.
I'm there now?
Not really. So it's about technology, and we are embracing technology. There are a few hiccups here. Ladies and gentlemen, bear with me.
The host?
Yeah, so no worries. Can one of you people behind ITP team, can you get Mr. Deshmukh live here on video? He's live with us for sure. It's just that his video is not there.
Yeah, I'm live.
Yeah, so sir, आपका video आप check कर सकते हैं? Okay, so maybe
I'm
will
opening it, but it is closing down.
No worries, sir. You continue, and then I think we will see how we can.
for us a lot of finance which required as per the GDP. Now, most of the time in India, we have seen that when people have to pay most of the cost for health services out of their own pockets, the poor are often unable to obtain many of the services they need. So increasing the healthcare expenditure by even a 1 percentage point in the GDP is going to make a massive difference in the delivery of healthcare. Now, pooling funds from compulsory funding sources, such as government tax revenues, can also spread the financial risk of illness across the entire population or the entire population of a country, or in fact a certain region of a state. The last year, that's COVID-19 pandemically dramatically demonstrate the invaluable role of health and healthcare workers, the frontline workers, and the importance of expanding investment in this area. Now, to meet the healthcare force requirements, what the government should understand that the training for healthcare workers as well as the frontline workers is going to be a mammoth task in the years to come. The growing demand for healthcare workers is projected to add to an estimated almost 40 million health sector jobs in the global economy by the end of the next decade, that is 2030. Now, this COVID pandemic, which was initially affected the healthcare workers disproportionately, has in fact highlighted the need to protect health as well as healthcare workers and to prioritize the investment in their education and their employment, and to take leverage partnerships to provide them with decent working conditions. When I say universal healthcare, it actually means that most of the time, especially in this COVID-19 pandemic, the countries need to rapidly scale up their investment. Now, those core public health functions that require collective action can only be funded by governments, or in fact, the market can take the risk of funding this. Now, when we move towards universal healthcare, there are certain things which forms a prioritized area, that is reproductive, maternal, newborn, and child health. Now, these are the 4 structures that any universal healthcare needs to get themselves incorporated. The basic requirement that infectious diseases have to come down, which includes tuberculosis, HIV, and which simply means that you have to really use insecticide treated bed nets for malaria prevention. A very small effort from the government can in fact divert a lot of funds which are being diverted to infectious diseases prevention as well as treatment. Now, the major disease burden in the Indian context is the uncontrolled growth of non-communicable diseases. Now, when I say non-communicable diseases, there are only 4 aspects which need to be focused. One is prevention and treatment of blood pressure, that is hypertension. The other is prevention and treatment of diabetes, and India is supposed to become the diabetic world capital. And the 4th, but not the least, is tobacco or non-smoking. Tobacco in any form is going to create havoc in 2030. If these 4 pillars of cardiovascular health are not taken care of, I don't know, we will not be marching towards universal health coverage. Now we are at the doorstep of actually creating an outcome of how universal healthcare can reach the population. And the government has definitely helped in creating a financial option for treatment of those who are in need. The Aishman Bharat, what we normally call as PMJAY, was launched as a step towards universal health coverage. And now this entails ensuring all people have access to quality health services, including prevention, promotion, treatment, rehabilitation, and palliation. And these initiatives were a part in response to this India's out-of-pocket spending. Mind you, unless you tell the children how to learn, the adults need to learn how to earn. And these are the 2 aspects on which the entire healthcare system of India will rest on, and the government is making tremendous efforts towards this goal.
Thank you, Dr. Deshmukh, for those transformative thoughts. We'll come back to you. Now, may I turn to Dr. Sujit Chatterjee, who is the Chief Executive Officer at Hiranandani Hospital. Dr. Chatterjee, as a CEO of a leading hospital, where is India failing in healthcare quality and equity, what further can be done to address this risk?
Yeah, thank you very much, Vishal, for this question. Let me take the easy part first. Let me take the equity part first. India's average age today, that's as of 2020, is 28.4 years. Now, another 20 years down the line, we'll be 48.4 years. So therefore, the population is definitely going to age, right? And you're not going to be young at the same rate that you were earlier. Now, if this population is going to be healthy for the next 20 years, imagine the productivity delta that our country will get. So therefore, the equity that India must put into healthcare is at least 3 to 5% of a GDP for the next 3 years. That will be a stimulus. That will give the fillip to the healthcare in the country so that we may rise as a nation with being a healthy subset of 140 or 30 million people, billion people. But the point is that I would like to say is that the government has to take this bold decision. Today, it's the public sector has got a huge infrastructure, immense capability. But it seems that the private will only take over the job. And this has been well proven in the COVID pandemic. Dr. Tarang is there with us, Mr. Haryan is there with us, Dr. Nankumar is there with us. All of us have seen this responsibility coming directly to us. So therefore, if we are not going to be able to invest heavily into healthcare, I think we are going to lose a huge delta, and that is the equity that really we need to push forward. The point is that India cannot afford to be reactive as far as health issues are concerned. Now, for the first wave, as far as COVID or the pandemic is concerned, well, it caught us by surprise, so we did react. But for the second wave, there was no excuse. We were reactive again, so that's no excuse. So such a large country with a humongous population, one can never, ever be complacent and be reactive. We've got to be proactive, and to have that proactive activity, to have the proactive sort of edge, we must have the government with us. The government of India will be the absolute sheet anchor, and the private player can add to the sharp edge of the razor. But we cannot be the entire saber. So therefore, this entire responsibility cannot be put onto you. So I think that is the equity that I am really, talking about. And this is, to my mind, an extremely important thing, that the government must invest. The private player must sharpen the edge of the healthcare, but the healthcare must expand across the length and breadth of the country. Now, we talk in terms of quality. You mentioned quality as far as healthcare is also concerned. At the moment, there's the NABH, the ISO, the ISQA, and what have you. But I don't think this is what is the real, crux of the problem. The crux of the real problem is that if you want to compare or you want to equate India to the healthcare leaders of the world, there are two basic things, and that is maternal and infant mortality. Now today, the maternal mortality, though it has come down, but it is still 113 per 100,000, a large number. And the neonatal mortality, which we have been able to bring down, is 21.7 per live births, which have been there. But look at the disparity. Look at Kerala. Kerala has 10 per 1,000 live births infant mortality. Look at Maharashtra, 19 per 1,000 live births. But look at Bihar, 49 per 1,000 live births. Now you can't have such a huge disparity. This does not work, sir. And no matter how much of glitz and glamour you bring in, how many proton reactors you bring in so that we have proton beam therapy in this country, if you do not address the basics, you will get nothing. Sir, no sentence can be culled without learning the alphabet. And we are trying to create a huge an expression of healthcare and quality without understanding the alphabet. So I think this is where I'm at, and this is what my take is. And I think that, this is what India and the government of India should be looking at. There are two distinct players. There's the private player, there's the government. The government is really the bastion, and the private player can only add flavor to that bastion. The private player can never replace the government as far as the responsibility of healthcare is concerned, which also is enshrined in our constitution as a fundamental right. Thank you, sir.
Great, sir. Couldn't agree more with you. And I think those unique insights are very, very helpful. And I'll come back to you later. May I now turn to Dr. Jairam, who's currently an advisor to the Manipal Group of Hospitals, to express his supplemental views on the point related to the reason behind where India is lagging in healthcare quality, as very beautifully put together by Dr. Chatterjee, and how can social determinants of health be addressed ASAP?
Right, yes. I think Dr. Sujit has, with great clarity, pointed out the need for us to invest in healthcare much more at the government level. My take is that in addition to this, the private and the government health streams run parallel. They do not talk to each other, and there is little, if any, similarity of work between the two. The other point that I'd like to state is that there is a tremendous difference between the urban and rural healthcare delivery in this country. The urban healthcare is delivered by private players and is at a level that is at par with global standards, albeit there is not enough accountability. And that is a point that I think needs to be addressed. But if you take the rural population is by and large today served by the government because the ability of private healthcare players to meet the healthcare requirements of rural India is far from financially satisfactory. And so very few players venture into the private healthcare space, from the private healthcare space into rural India. If the government wants private healthcare to take a principal role in the control of many areas of primary care, such as infant mortality, maternal mortality, and NCDs, then greater emphasis on the private players is in order. While I entirely agree with Dr. Chatterjee that the responsibility rests with the government, we have realized that the government is better performing as a payer than as a provider, in which case there needs to be an overhaul. And this overhaul implies a greater participation of private healthcare in the rural space for us to get better. The second point is, as doctors today, are we accountable to anybody other than ourselves? The answer is no. NABH is not mandatory. It is absolutely at the discretion of the institution. And there is nothing that guides the efficiency of healthcare. For example, if you take a government primary healthcare center, is anybody monitoring the HbA1c of the population that primary healthcare center covers? The answer is no. Is it being done in a cohorted fashion across tertiary healthcare players in the country? The answer is no. There are certain players who are committed to healthcare quality and who invest in it. There's a large number that does not, and this needs to change. Self-regulation and enhanced information dispersal amongst healthcare workers and the medical fraternity about the value and importance of various quality parameters and the importance of monitoring it, and a central repository to assess the manner in which these NCDs are controlled, the way that tuberculosis is being treated and responding, has to be a measure that tells us how well we are doing, both at the rural and in the urban centers. We have a long journey. Quality cannot start overnight and get completed, but baby steps to start monitoring KPIs, which will enable us to improve the nation's health step by step, is a long but extremely important process. And I believe that as medical fraternity, both at the government and the private level, this is best done by self-monitoring. All of us know that regulation is an unfortunate evil in trying to get better, but self-regulation and a commitment of the healthcare space is vital. And those are my few words to add to what Sujit and Dr. Deshmukh said.
For the brilliant insights. Thank you, Dr. Jairam, for those brilliant insights. May I now turn to Dr. Tarang. Dr. Tarang, it's time actually for us to talk about a very important dimension of how we can strengthen these healthcare ecosystem, which has been highlighted by Dr. Sujit, Dr. Deshmukh, and Dr. Jairam, that there is a deficiency. But how could we adopt these digital technologies, which everybody thought, digital technologies, when they were introduced in the Indian ecosystem, they thought they could probably bring some value in addressing some of these challenges, And I think now we have been adopting these technologies. So how far you think that, we can achieve a goal of looking at India's transformation of an India's sick care health system, which has largely been the center focus, to a preventive care. So maybe your thoughts will be great.
Thank you very much. I think the time has come where we all have to definitely understand that healthcare providers, healthcare regulators, everybody has to work hand in hand with the technology and embrace the technology to put it to the best use to provide a continuum of care to the patients, whether it is preventive health, whether it is the treatment part of it, whether it is monitoring, whether it is rehab, including the palliative care that we provide to people. We all talk about smart hospitals. So smart hospitals are not just infrastructure which are digitized. Smart hospitals are hospitals which have, which provide better redesigning systems, which build, which optimize the clinical processes, the management systems, which are all enabled by the technologies together. And it doesn't mean that a smart hospital has to be a hospital which is one structure. A smart hospital is a concept which provides your services on a broader ecosystem. So I guess whatever the eminent panelists have said so far, if we all embrace that the technology and the use of technology in healthcare is the new way, and we have to I cannot say that we have to stop doing something which is our old way, but I think we can definitely use technology to enhance what we are doing it in our usual ways. As Dr. Chatterjee rightly pointed out, that you have to start with your building blocks. So where is the basic care to ensure that your maternal mortality rates, your infant mortality rates are improving? So I think technology can play a very important role combined with the power of 5G. I think it can reach out to the remotest areas of the country, in the hilly areas, in those areas which are not as accessible to the healthcare workers, because we all know that India as a country have a very challenging doctor to patient ratios, and it gets worse and worse as we go from the metropolitan cities right into the interiors. So I think at this point, that point of time, technology definitely helps in some way or the other. And always, humans are always known to find out their ways if they have the will to find their ways. And I think this time nature challenged all of us. So we had COVID, and we all realized that there is a power which technology has. I think we have provided the consultation and home health care to people in the remotest village beyond Manali also through our hospital, and I'm sure many of the hospitals did the same. So I think we can harness the power of technology to address everything at all levels. I firmly believe that using technology for coming out with a completely new vertical of healthcare, which is basically providing services at home, is something which everybody has to look at, because that's something which will help us to move any unsustainable healthcare system to a sustainable healthcare system, reducing the cost to the patient, reducing the burden on the healthcare system, the hospitals. Because the purpose of any healthcare system is not only to increase the volume of patients to the hospital, it is to provide service to the people so that the population in general becomes healthy and is well, and comes to tertiary care hospitals only when they are unwell. The burden on our healthcare system is high. Many people are not able to access the tertiary healthcare system because we are not focusing on wellness and preventive health. We at times, there is a very fine difference in our country between nursing home care, between the care at the tertiary care hospital. And that's where technology can help. That's where the concept of hospital at home or home healthcare can help. And I think there is not, apart from the high-end surgeries, of course, the proton therapy, as Dr. Chatterjee said, apart from such specialized therapies, I think there are lots which we can do at home. We have attempted it. We succeeded it also to quite a bit of extent. So you can do significant part of your health checkups at home. You can provide all your laboratory services to patients at home. You can provide the basic nursing services at home. Everything, including how to teach the new mothers on lactation, how to do basic dressings and all, for which you don't want the patients to come to the hospital. And you can always harness the technology for even mental support, which we all did during COVID. And I think that is something which has really come out very well for all of us. So using technology for enhancing our home care delivery system, we went a step ahead, and we have quite a bit succeeded in providing even rehab, occupational therapy, speech therapy, all these services in the comfort of home. And I think somewhere it plays a very important role in not only reducing the cost to the patients, it also supports the hospital to ensure that they come out with this new vertical of using the technology. We've almost done more than 75,000 consults on our Geo Health Hub platform across India only through RFH. So I think there is nothing with which we can't reach to the patients. We took care of 2,000 above patients of COVID. So now with the new medicines and the way this particular variant is responding to the medicines, including the monoclonal antibodies, I think we have all come to a point that I don't think that if this pattern continues, even if there is a third wave, the impact will be less. A lot of care can be done at home. You only have to call the person to take some acute therapy for a few hours, and then he can go and recuperate or recover at home. So why to burden your infrastructure with something which can be resolved at home? Why not give the patients and the healthcare providers this empowerment that yes, you can treat people at home, you can treat volumes of people at home rather than in our hospitals, which is a 350 bed, which is a 250 bed, which is 500 beds at max. Because the cost of running such hospitals is also huge. So I think all in all, the technology definitely is the way forwards. And I think in as far as innovations and technologies are concerned, that is what distinguishes between leaders and followers. So we all have to lead from front. And I really feel that this is something which even the insurance providers have to support, because that will bring the cost to the insurance companies also down. If they support the home healthcare system as it is supported in any other country, the cost to them also will come down, because many services can be provided at home and the patients don't need hospitalization, and the premiums will come down for the patient, and also the cost will come down on the insurance company. So I think there's lots which I can talk about this, but in the interest of time, I feel this is something which the new India should look at, and which is something which we all have to come together and harness to address the basic needs and the advanced needs as well. Thank
you. Yeah, thank you, Dr. Tarang. I think what I understood in gist is that smart hospital is not a hype, but it is actually the hope, and we're getting there. So we may see actually your hospital being branded as the smartest hospital. So wish you all the best for that. And thank you so much for those visionary words. I really appreciate. Moving on, one of the most important area, which I personally am also equally passionate as Himanshu, and which is basically requires an urgent control and urgent attention, is about infection control standards. And considering every fifth or sixth patient who's taken to the ICU, and I'm sure all of us can relate to this, acquires a secondary infection in the ICU setting, and that itself speak about the need for raising the bar for hygiene and infection control standards. And when we speak about infection control in hospitals and preventive care, the name that we cannot miss is diversity. And with that note, I'd like to invite Himanshu Jain, the President, Diversity. Himanshu, over to you.
Thanks for very kind words, Vishal. It's like, when I hear those things coming from an industry veteran like you, it makes me turn red in my face for a minute. I would say yes, in many ways what you said is right. Diversity is a pioneer when it comes to institutional hygiene in the country in all walks of life, whether it's food service, hospitality, large facility management, public transport systems, food and beverage industry. It's been like that all the while. And we have really pioneered the whole concept of managing and delivering a performance on hygiene by measuring, using a scientific approach, the whole thing. And the same thing we're trying to do with healthcare, although a bit, I would say, relatively slowly than we should have been. The way I see the role of industry is that industry has to partner the healthcare stakeholders. Primarily the healthcare service providers, the eminent men on this panel, the institutions with which they work, the people who are actually the users who are interfacing with the patients. And when I say they need to partner, I mean hygiene is a function of the right chemistry, right methods, tools, along with the right people and practices being used. So practices and the choice of chemistries and the products has to go hand in hand. It cannot be done one way. It has to be adopted before somebody can get an outcome out of it. I see the role of industry, people like us, is to lead the education of stakeholders, to make them aware what technologies are available, what products are available, how can they help. Like, for example, we have a solution called accelerated hydrogen peroxide, which kills a virus like this in 15 seconds, the COVID virus, and it kills before it dries. So in one wipe, it actually takes care of killing the virus before the film dries. Now, these are things, unless the stakeholders know when you develop, they can't adopt it. So to me, the first role is to bring it to their notice, to prove them work, to handhold, to help them incorporate their in systems, to go to the right people who understand technology, are progressive, are willing to lead the change, which I'm sure a lot of people in the, I would see one of the most open-minded and progressive healthcare systems we have. Otherwise, you won't find a proton scanner in a country like ours. May not be the most, it's definitely not the richest country in the world, but it's being adopted because there's a desire to go forward. And what India has in common and what drives India forward is its hunger to grow. In spite of all the chaos, in spite of all the mess or the traffic on the roads we see all of us want to make life better for ourselves and for our people. So I see this industry hasn't done enough. We need to do much more by bringing the education to the stakeholders, need to be in front of the right audience and help handhold the progression of the industry to a new way of doing things. And I guess you asked me something about the products, how can we ensure the judicious use, right?
Absolutely.
Yeah. The way I see is product stewardship is a function of outcome of our vision. And development of a vision is a function of our knowledge and what is possible. So we need to develop a vision with the industry together to say, we solve today's problems and prevent future problems, or we drift. Drift is we just meet today's needs and forget about it. In any society at any time you'll find people from all walks of life. Some are just happy doing what is the minimum statutory requirement, and some are willing to take a step forward and go further and try to lead the change. And I think we need to associate with those change agents in the industry to go to that next level. There is no point in having a technology if it cannot be spread and used by the stakeholders and the benefits experienced. The concept of a cost per unit versus cost of the total operation is a very simple concept. Everybody understands it, but we don't always realize it. And these are the kind of things we need to bring forth. To me, I think industry of service providers like ours is very nascent, yet developing. And I think the more of us do this, play this role, the better will this whole setup would be, which will include, some of the most expert doctors in the world come from India. And yet, the highest infection rate comes out of India. And because that is the way we live. You said 1 in 5, 6 patients. I'm not even having an estimate. We do not measure hospital-acquired infection enough. Do we have a system? Now, some of the best hospitals do measure it. They know it. But is it the high priority? Maybe, may not be, depending on the vision. Can the government mandate it? Yes, the government can mandate it. But do we want them to mandate it? Because the moment they mandate it, there'll be some harassment associated with it. So to me, that is something which the industry together has to come together and set its standards, differentiate and move forward. I am very confident we are not very far off from that day when insurance companies, because they fund in the money and they take care of the patient care, especially in the private space, will start determining which hospital gets how much paid depending on the kind of infection rates you have, the treatment success you have, etc., etc. And if it happens in US, it can happen in India, because we are, in many ways, we are a very similar society, both in terms of democracy and in terms of paying for your own needs. The government doesn't pay beyond a point. The US also, in spite of being social security, you pay for your own Medicare. In India is going that way. So I think industry can do a lot, but it has to partner with the stakeholders. It has to have an approach of education, be prepared for the long haul. And the only ask from the healthcare industry would be an open-minded engagement, period. That's all we need. Engage, develop, progress, try, take it forward. Thank you, Vishal.
Sure. So I think with your continued mission and vision that you have for this industry, I see hygiene specialists all across the, I would say, all across the healthcare institutions in India. And I think that's something that will be your contribution. So please keep up the good work, and I'm sure this is the work in the right direction. So now let me turn to which is our dear friend Jitendra, who's the CEO of Just Look and Research Center, who comes with a deep finance background and understanding. And I'll request him to share his insights on the affordability in private healthcare setting, especially tertiary care setup, because Just Look is one of the leading tertiary care setup in Mumbai. So Jitendra, over to you.
Yes, thank you. So to answer your question, see, the cost of running the tertiary care hospitals is very high. And that is typically because the input costs are high and the operating costs are high, especially in the metro cities like Mumbai, and can only go up if there are labor unions. So it is labor intensive and capital intensive sector. The proportion of drugs and consumables also would be high in the tertiary care treatment. There is a huge initial capital investment required, and there has to be a continuous investment further required to keep up the medical infrastructure. The working capital requirement is also high, and it can be higher if the credit cycle on the collection is high, and that can typically happen in the government schemes. So collectively this results into the higher treatment costs for patients. So importantly, how can we address? Is there any way we can improve the affordability? So my thoughts on that are to bring down the input costs. The government may consider full or partial refund of GST paid on the hospital goods and services, as we cannot claim that because our output service is not taxable. So therefore, whatever GST we pay on our medicines, consumables, assets that we purchase, it is actually the cost for us. So that can certainly be looked at for partial or full refund. Then more drugs can be brought under the DPC to reduce the costs for the patient. Make in India needs to be pushed in healthcare, which will significantly bring down the cost. We have seen this in the case of PPEs, where initially we were procuring the PPEs at the cost of around 1200 plus. And now we are paying about 200 to 50 rupees, even lesser than that in some cases. So government should also sponsor the research and development, and also attract investment by providing incentive to the investors for development of indigenous medical equipment, and private sector hospital can support it by using them. This will substantially reduce the cost and also the capital burden. Also, the duty waiver on the import machineries can be considered because this is a significant cost. In some cases, we pay duties as high as 25%. Then there can be low-cost financing options provided for the healthcare sector, so that the total overall cost of the hospitals come down. Payment cycles can be better under the government schemes, and there can be fast-track redressal of the tax disputes and refunds. There is also an interesting proposition of the REIT model, which is real estate investment trust. So, what government may do is to, attract the investments here. They can actually give the tax offs for the funds for creating the infrastructure for the healthcare sector. What it does basically, it will provide the infrastructure, which could be even the funding of the civil infra or the medical infra, and the hospitals don't have to really pay or invest into the infrastructure, and they can just merely pay the rentals, and by that a huge cost benefit that can be passed on to the patients. Also, under this PPP model, Ayushman scheme is there. Now, in the Ayushman scheme, there is a requirement of, I think, 25% of the bed commitments. Now, this is a major deterrent for the hospitals to subscribe for the scheme. So if that is flexible, then the hospitals, if they have spare capacity, they can subscribe to the scheme. So even it could be as low as 5%. And by that, they can use the spare capacity better and recover their fixed costs. So, all these things will collectively help the hospitals to optimize and, manage the cost structures in an efficient way, and that can be passed on, the benefit can be passed on to the patients.
Thanks, Jitendra. I think those are very clear inputs, but I can share that some of it is already being taken by the government, undertaken by the government, and some of it is very difficult to adopt, because you said BPCO, so I think pharma industry is betting that, drugs should not go to BPCO.
The fact is that whatever we bill, the hospitals bill, 30% is taken away by the pharma. So if we are looked at as if, we are making 100 on the bill, whereas what comes to the hospital is that only probably 70, 75, from which we have to pay our doctors, our staff, CMCs, maintain the medical infra, invest in the medical infra, all of that has to be done. So not easy.
Yeah, I know that opens a session for another debate, actually, pharma versus overall healthcare delivery. So I think considering we are restricted in time, so I would like to move on. Thank you, Jitendra, for those unique insights. I'd like to invite every member on the panel, to start with Dr. Deshmukh, to share brief comment on affordability in the private healthcare setting and role of technology and insurance that everybody spoke about in enabling accessible, equitable and affordable healthcare. So I think, sir, one-liner recommendation in that front would be very helpful before we sort of move on to the Q&A. Dr. Deshmukh, over to you. Dr. Deshmukh, I think your screen is frozen. We can't... Okay, so I think we'll wait for him to come back. Meanwhile, let me turn to Dr. Chatterjee. Dr. Chatterjee, would your views or recommendation?
Yeah, well, prepaid healthcare is going to be the way forward. We need to understand that our insurance policy is completely skewered. And it is skewered because the older you get, the higher premium you pay. But the diseases are going to occur when you're older. So when you are earning and you are capable of paying a high premium, why are you not being charged a higher premium? So I think that if you skewer it and give the no-claim bonuses when you are at senior ages, it will go a long way to ensure that the healthcare is affordable, as you want to put it. Thank you.
Wonderful point, sir. I was actually laughing because I truly relate to it. So, I have to pay for my mother. When I enrolled in her policy, I was paying only X amount. But today, after 10 years, I pay actually 3X of that. And it's such a wonderful insight. Thank you so much for sharing that. Dr. Jay Kumar?
Yeah, in my opinion, I think, what needs to be done is to look at managed healthcare, wherein insurance is paid not for a single patient as compensation to the hospital, but by the insurance companies for taking care of a community's health, pretty much like what the Kaiser Permanente model is. And I think this is something that will help achieve quick change in the manner in which insurance is accepted and supported. That has to come, because otherwise we would continue in this for decades.
Thank you for those unique insights, sir. I think it's quite an innovative structure that you're proposing, and I'm struggling to learn about it. So I'll certainly come back to you and learn more about this. Dr. Tarang?
So I think we need to trust to believe that the home healthcare or hospital at home concept, the way I like to call it, is one of a new vertical which the hospitals should look at to ensure that the quality of life for the patients also gets better, cheaper. It will help everybody. It will help the hospitals, patients, and it will also bring us to the forefront of technology, because as we are a progressive nation, I'm sure we will look at more and more innovations in this side, which will overall benefit all of us.
Dr. Tarang, we have seen evolution of home healthcare in this country. You know, there are about 5 to 7 players who are deeply funded, but you know, they couldn't really scale up the model. And I don't think the hospitals wanted to partner with them. So what do you think will actually be required to make sure that, you know, there is actually an adoption of home healthcare setting in a big way, and ultimately that is really going to help India moving forward in the right direction?
I think it will be the hospitals which have to drive it, because they will have to recognize it as one of their verticals. The way we provide tertiary care, the way we provide any quaternary care, we will have to, the way we do health checkups, we will have to recognize this as a concept of healthcare. And if that is done, obviously,
part of your portfolio.
Yeah, as if that is done, they can always partner with the companies for care delivery. But the pivot has to be with the hospital, because at the end of the day, you need your trained staff, you need your trained doctors, you need other staff to provide the care services, because the services cannot be compromised. I think somewhere there was a gap in the service provision, which people expect when they come to the hospital, a good tertiary care hospital, which was lacking, and that gap has to be sealed. There has to be a standardization of care, so a person should not feel if my blood is withdrawn is better in ABC hospital vis-a-vis at home. Rather, that experience should be much, much better than coming to the hospital.
Sure. Himanshu?
Yeah. So you're looking for a more affordable healthcare, right?
I know.
You know, my take is this, that I think we are in a many way a market-oriented society. And the way I see it is that we are in many ways trying to look for my interest versus rest of society interest. What we need is a different approach. I think we'll continue to be a market-oriented society. We will have to pay for our healthcare whether we like it or not. It's more about better financial planning and a structure outside. I like the suggestion Dr. Chatterjee made around, healthcare premiums being inverted, more incentivizing, encouraging people to take, healthcare, and the government providing the right structure. But it will have to be market-driven is the way I see forward. Because I don't think the government has the kind of resources to make a universal healthcare free of cost or low cost to everybody. And I don't even think they have the intention. Not only now, even in future, any political party, whether communist or capitalist or BJP or Congress, they are all in the same game. None of them have the will to do it. We can keep saying they won't do anything.
Yeah, we still are 3% of the people who are paying taxes, right? That this number hasn't gone up.
I'll come back to my original. And I think prevention is our number one takeaway. And I'm not talking only of the communicable diseases where hygiene plays a direct role, but I'm talking of all kinds of areas. If we as an industry, stakeholders together, take it upon us to educate our population about, can we stay with the habit we acquired during pandemic of washing hands every time we come back home? Every time we go out before eating food, can we do that? Can we start using a sanitizer? 15 years back, I went to Philippines, lived there for 4 years. Every single person coming to office had a bottle of sanitizer in their pocket. 15 years back, there was no pandemic that time. I'm just talking of the paradigm change we need in our lives when it comes to hygiene. Once you do that, this cost is very small. Today, nobody will complain about the cost of a sanitizer. They will be very bothered about the corona. Now, a pandemic has awoken us. Will we go back to bed? Depends on us. And a cost of healthcare is a function of cost of our habits, whether it's hygiene or lifestyle. So if we slouch in our chair, we'll have an orthopedic problem. if we are a couch potato, we will have an obesity problem. And it is a function of how do we want to live our lives. And to that extent, I would come back to one same premise, whether it's with hygiene, without hygiene, is prevent. Focus on prevention is the best way to keep a society healthy.
Thank you for that. Jitendra, over to you.
Yeah, so I think I have pretty much covered in my talk, but just to add to that, we are under 2% of GDP is what attributable or spent on healthcare. We have a lot of scope. I think if we compare with the other countries, even if we look at 3%, 4%, we have a huge funds that can be allocated towards healthcare. And if a large portion of that is diverted towards this Make in India drive in having the long-term strategies of reducing the cost of medical infrastructure and also producing the more and more drugs in India, I think that will bring down the cost significantly. That is one. And also, I think there can be a focus more on, like Mr. Himanshu said, has to be on the preventive health. So that will, I think, make the huge difference in the way we are currently looking at healthcare.
Absolutely. Dr. Hemant, can you also hear us? Can you see us? Are you back, sir?
I'm back now.
Wonderful, wonderful.
Lot of technical problems, I suppose.
No worries. Glad to have you back, sir.
Yeah. Probably, I think every speaker in this gathering has said that prevention is also the best strategy to counter any kind of disease. But give children a good health and give adults a means to earn, and that will definitely signify or turn into a most healthy population in the country. And the long-term benefits obviously are going to be astronomical. Prevention is the best cure, I suppose. And towards that end, I think everybody should try how to prevent a disease, and which is always in the curriculum of the undergraduate students. So it should now come down to people who are in their schooling ages, that prevention should be the best cure for any disease, not only a disease which causes pandemic.
Great, sir. Thank you so much. We have about 10 minutes left, and I already have received a couple of questions from organizers, which is shared in the chat box. So first question, which is for Dr. Deshmukh. Sir, how do we generate a capacity building of clinical research in medical schools to meet the overall requirements of biotechnology and pharmaceuticals, which are the need of the country today? Because there's an innovation happening. But what I understand that, the capacity building in clinical research is very limited in this country to match the drug development. So, sir, your views on that will be very helpful.
Yeah, as a chief of a medical college and the KM hospital, what we have realized over a period of time is that we need a society, or we need a committee which we call as institutional ethics committee. Now, this institutional ethics committee should be present in almost all the hospitals, not only on paper, but they should be actually deliberating every month. Now, this institutional ethics committee will actually vet almost all the research proposals that the faculty or the doctors or any healthcare workers comes with. The second most important thing is we should have a lot of boot camps, innovation boot camps, which is definitely lacking in the colleges as well as the tertiary care hospitals and the medical colleges. We at GS Medical Colleges have started innovation boot camps, and to tell you frankly that for the last 8 years, I was actually running behind a prototype, and I invented a medical device by which I can treat obesity in a very non-invasive way. And I thought the idea was so simple that why can't the medical students who are so enlightened after the 12th standard exams can come out with some idea. So that is the second thing, that the innovation bootcamp is going to go into the curriculum of the undergraduate medical student. The third most important thing is that we have something which is called as a funding pattern within the hospital, which funds with the help of ICMR itself, which funds a lot of projects within the hospital and outside the hospital. Now, these three things together is going to bulldoze into a strong society and a community in the hospital, and we hope to come out with a lot of drug discovery. As you are well aware that amphotericin B liposomal, which was very much in demand. In fact, KEM way back in about 18 years back invented this drug, and today it has come into picture. Today it has come into practical use, and you can imagine what you invent today is going to be of some use years together and probably a decade later also. But innovating is the key to a good healthcare setup.
Thank you for that visionary statement, and I like your idea of innovation boot camp in the medical school. I think that's going to go all the way. As you said, that what you do today will actually have an impact tomorrow. So wonderful, sir. Thank you so much. Coming back to Dr. Nandkumar Jairam, sir, you have been, I would say, a policy advocate when it comes to primary healthcare. So the question is that how can we further improve the primary healthcare? Because if we take care of primary healthcare, I think we can take care of the healthcare systems in India.
Absolutely, and I think the answer is from what Dr. Tarang already has told us. See, basically primary healthcare needs to be the primary point at which any patient, not patient, any person in this country seeks healthcare attention, rural or urban. Today what happens if a patient has a headache in Bangalore, he goes directly to a tertiary care hospital. Waste of resource, waste of money, manpower, everything. So there has to be a channel. And this is the first point that I'd like to state. The second point is that primary healthcare need not be delivered only by doctors and nurses. I think there is an opportunity for other healthcare workers suitably trained and available to deliver healthcare remotely. And this is enormously aided by telemedicine and various technologically advanced solutions that will enable this to be monitored and appropriately dealt with by clinical staff remote from the place of patient contact. So the third point that I'd like to state is that today, and I've said this earlier, there are two parallel streams of healthcare delivery, the government and the private. In the remote areas, they need to talk to each other. And there has to be a common goal. And the goal has to be to get the health of that community better. Suitable primary health care means screening the population for non-communicable diseases, establishing methods to ensure better control of non-communicable diseases, identifying infectious diseases and treating them early. These would be most important. To this I will add better maternal and prenatal and postnatal care.
Thank you for that. Yeah, sorry, go ahead.
No, so it's a large topic, but these are the principles on which I would base the future for primary care.
Great, sir. Thank you for those directions. Dr. Tarang, there's a question for you. It says that what's the future of health technology? It's a broad, but I think if you can share your insights, that'd be great.
It's a really broad question because according to me, healthcare technology will really supersede the growth of any other industry, not only in India, but across the world, because as always, healthcare is a field which always remains active. It will never go into recession as long as humans have a ticking heart and a brain to function. So likewise, the healthcare technology will just evolve and evolve and evolve. We are already trying to work on algorithms for stroke, integrated with the artificial intelligence system. Robots are getting also developing ways and means to develop the artificial intelligence within them. So very soon, I personally feel that any good infrastructure set up in a remote place with a robot and your surgeon sitting in any metropolitan city will one day be able to perform a surgery, and that will happen as a reality. It may look something which is very unusual, but 20 years back, I think we did not have smartphones. We had simple phones. We never expected that on our phone we can manage everything. We can even monitor our oxygen saturations, our heart rates and BPs.
True.
So, well, if that can become a reality, I think this will not take 20 years. The journey will be much faster because there are because in COVID, one of the things which I also realized that there are a lot of people who will come forwards to create the infrastructure. The problem is not infrastructure. The problem is of the healthcare workers. The problem is of the people. So once you have the technology to some extent replace the people or extend the reach of the people, I will not say replace, because at the end of the day, a robotic surgeon also needs a surgery, also needs a robotic surgeon. It needs a skill set of a doctor. So it's just that instead of the robotic surgeon performing that surgery in my hospital, can always perform that surgery in a remote village or where there is an infrastructure created by someone who cares for people, who wants the best of healthcare to reach the people.
Absolutely. I can share with you, that there is a advanced robotic system, Make in India, which will be available to each one of us, in next 12 months. And it's advanced stage of clinical trial, and I think it should be getting an approval. So having a robot in your, in your OT is certainly not a distant dream. It's actually going to be reality in a couple of months from now. Coming to Jitendra, you've been, looking at financing, and so what can we do better to attract investments in private healthcare sector? Because there is enough investment happening in private healthcare, but I think there can be much more. And what is stopping that flow coming in, in healthcare? And I'm privy to some of the challenges, but I would love to hear from you first.
Sure. So a very interesting question. So basically, when it comes to investments, it's about the fundamentals, and they are important. So there are certain fundamental issues which need to be looked at. So the first is the investments is largely linked to the profitability and the sustainability. So no investor would put in his money without looking at the projections, discounted cash flow, NPV, IRR, etc. So fundamentally, the business needs to look profitable. And unfortunately, healthcare businesses fundamentally are not so profitable. So this is one of the biggest issues. Second is the transparency, governance and practices. Very key to the investments and the the outlook of the investors. So the positioning of the healthcare needs to improve. The healthcare in India has got a lot of bad name, and often is referred to as money making business, which needs to improve. So more accountability has to be built into the sector, especially related to the pricing. So when you say a particular price, stick to that, and bring in some more accountability, transparency to the consumer. Then the consistency in government policy is important. So, any investor would look at the government outlook towards the sector. And when it comes to healthcare, it's not, the government policies are not really consistent. So we need to, do some work here. Then the scale. So, healthcare in India is fragmented. There are very few groups, who are large enough. So because we have 100-bed hospital somewhere, we have 200-bed hospital somewhere, 300-bed likewise. So there are many. It's a fragmented sector. So the investor would not put money in 25 crores here, 25 crores here, etc., etc. So there has to be a consolidation. The other point is there can be tax incentives offered, especially to the investors in the healthcare sector, if you want to improve the the investment scenario in the healthcare sector, and the exit can be made easy, and on exit there can be incentives on the taxation. So these are my few thoughts where there can be some work done to improve the outlook in the on the investment.
I agree with all of your points except the exit. I don't know why you're talking of exit. The moment you talk of exit, are you looking for commercial gains, or you really want to do healthcare?
It's always a secondary sale. Somebody has to take you over.
Then go the IPO way. Then go the IPO way, not the exit.
Not the IPO way. Somebody has to bail you out.
Sound better.
Yes.
Okay. So I think it's time for me to call upon Dr. Sujit. Dr. Sujit, there's a question for you, which is what health policy reforms are on the table? I know you're not working for the government, but I'm sure you may have some indication that what is on the table.
Yeah, well, I think the standard things are on the table. The government is quite keen to after what has happened, is quite keen to ensure that certain things which are pushed forward, health and family welfare, the Ayush, as well as the National Rural Health Mission, these sort of things are on the anvil and they are being rolled out. But the effectiveness of this rolling out is a humongous task. You see, you may have terrific plans and you may have a terrific scheme, but the geopolitical scenarios have to be taken into consideration, as well as the will. The polity has to have the will to move it forward. So if you don't have the will to move it forward, then in that case, these schemes just get left on the table or in the files. So therefore, I don't think we as a race or as people are intelligent people, and you can see what's there in the United States and the Fortune 500 companies. But the point is that within our own country, do we have the will to execute certain schemes which are good schemes promoted by the government, but there is no will in the polity to see it through. I think all these schemes which we speak about, like for example, Ayush is a good scheme. The National Rural Health Mission is a good scheme. I mean, it will benefit, as I spoke about maternal and neonatal mortalities. These things, these results will automatically improve, and the health of the health base of the country would go up tremendously. But as I said, the geopolitical scenarios have to be in consonance with the dynamics of what is happening within the nation, and then only these schemes are going to be able to see the light of day. So my take is that while we have everything good set, we don't have the will to push it forward.
I hope that National Health Authority is the way, and let's put a trust and see things happen, Thank you, Dr. Sujit, for those brilliant insights. May I now turn to Himanshu. Himanshu, there's a question for you. It says that how can infection control reduce the overall healthcare spend and be a driver to a sustainable economic growth? So over to you, Himanshu.
It's just feeding into exactly my thoughts, because to me, as we have talked, and Dr. Deshmukh led the conversation by talking of prevention and freeing up money from the communicable disease management expenses being released for non-communicable and the lifestyle diseases which are ailing us much more today. To me, a nation is only, as Sadhguru says, an idea, and a nation's economic output is a function of the health of its people. We have a demographic dividend, but that dividend can come to life only when people in the country are healthy enough to be able to contribute to the economy, and not being the net users of the economic wealth, but net givers to the economic wealth. The dependents have to be less than the independents who can feed them. Like, China is experiencing that the dependency is much more than us. To me, prevention is the way forward for any developing country. And while hygiene plays a role across the sectors, the most important role is with communicable diseases, with food safety related illnesses, with even allergen management, which we work with many industries in. So to me, bringing hygiene in its pristine space back to our lives at all levels of our livelihood, whether we are operating in a clean or unclean atmosphere, is a choice we have. Whether we are eating clean or unclean food is a choice we have. It's not necessarily a cost. By the way, the cost of hygiene is very, very low, but the impact it has on us is very high. And sustainable economic development is when you are able to do more with less. And if people are healthier with less expense, which is on prevention, naturally the economic development will go forward. and I allude very strongly, and I really agree with Dr. Chatterjee when he says, what we lack is a will. We talk the right things as a polity, as a society. We do not always do the right things. I think my submission to all the audience and everybody would be, let's consider, let's decide what are we going to do. Let's stick to the right habits. Let's make a contribution which takes the nation forward, not pull it backward. Thank you.
Wonderful, undisputable, and I think prevention really needs a very differentiated strategy to reset the healthcare setting that we today have. And I'm sure baby steps like this, significant thought leadership sessions like this will certainly be a catalyzer in transforming the situation where we are to then build a better one. So I wish we can continue to go on, because all of you are so brilliant, and I'm really, really happy, and I've learned so much from each one of you during the discussion today itself. But as I get a message from Sujata that we need to bring it to the closure, I know it's a tough one, but it's time for me to pause. And I want to really thank each one of you for sharing your wonderful insights, and all the audience for your patient hearing. And I think it's time for me to say bye and hand over the stage back to Sujata. So thank you, Sujata. Over to you.
Thanks, Vishal. That was a wonderful session, and thank you, everyone. Before I say goodbye to everyone, we have two questions which are very important, I think. One is to Mr. Jain. You have a program called Garima, which is a unique program that educates and uplifts the status of janitors by helping them become skilled hygiene technicians. So could you give us an insight into it in very short words?
Garima is our CSR initiative. The thought process behind it was that we lack hygiene practitioners in the country, and we have a large unemployed population. No one aspires to become a cleaner, janitor, hygiene technician. So how do we bring dignity to that? And that is why the name Garima. How do we bring dignity to this profession of bringing health and hygiene? I see a hygiene technician, a cleaner, a champion of hygiene as somebody who helps us prevent an illness. And in a certain way, the status is very high, or should be very high, although our caste system takes it to the bottom of the pyramid. And that is something which we have tried to restore through this Garima by training people in their local spaces to become much more aware of the right hygiene practices, the right way to do the cleaning and maintain hygiene in a place, and provide a skilled hygiene manpower to the industry, in the offices, in hospitality, in healthcare. In fact, in the last COVID wave, our CSR partner, Doctors for You, have been playing a stellar role in running COVID camps in Bangalore, Delhi, Patna, Guwahati, and many cities. And more than 200 of our Garima trained practitioners have been supporting that effort. We do it entirely on our own so far. We haven't got into any, we fund it completely on our own, and we are a relatively small company, but it is coming out of our passion to make India a little more hygienic in our lifetime than possibly, if it becomes a movement, much more hygienic. So Garima as a program, I would invite support, request, your inputs on what can we do better. We would like to make it a movement, not just leave it as a program within us.
Okay. Okay, next is a very generic question, but anyone can answer. How mHealth can revolutionize the Indian healthcare industry? Who would like to answer?
What health is that?
What health? Mobile health.
Okay. I'm not the person.
Who would like to answer?
I know the doctors will need to address that because...
Yeah. Dr. Chatterjee, would you like to...
Yeah, well, I mean, see, it is inescapable. Technology, the use of technology is inescapable as far as the future of healthcare is concerned. Now, as far as mobile health is concerned, it is important because the fact of the matter is that today, if you look at intensive care units, the intensive care units have got a very large number of patients who are critically ill, and they require to be under supervision, not only at the bedside, but off-site by the consultant who is, or the critical care or the intensivist who is looking after the patient. So therefore, you need to have this capability of having the patient being monitored on the mobile phone and in the intensive care unit. Let me just tell you one thing, is that from hour to hour, there may be change of drugs. There may be change of drugs which build up the blood pressure. There may be even change of antibiotics every 3 to 4 hours, depending upon the scenario of the patient. Today with COVID, you have the sequential organ failure syndrome. Now, the sequential organ failure syndrome is not going to announce itself and come. It is subtle and it is devastating when it is set in its full might. So therefore, you require these devices which are very, very capable of transporting the data of the patient, including lab investigations, the important investigations. Now, for example, I have invested in technology from Israel where you have a watch. And this watch is put on the patient's hand as far as the intensive care unit is concerned. And from this watch, the mobile phone of the consultant per bed, that means they will not be able to monitor everybody, but one individual can be monitored at a time. So it's only a matter of flipping the bed and you will be able to monitor 16, 18, 20 patients, depending on how many handsets you have. So I do not think that this is a rarity. This is already there. It is already available and it is working extremely well, but you require it. Especially in the tertiary and the quaternary care hospitals, you will definitely require it. And I've just given you one example of a critical care unit. You will require it in the cath lab. You will require it in the post-operative environment, especially when we are talking in terms of things like robotics and surgeries and things like that. Such technology is definitely mandated. Your patient may be wearing a device, and you are linked by global positioning. You know where the individual is, and you are able to say that, okay, this is his pulse, this is his blood pressure. I already know what he does, so therefore you're able to advise the medical caregiver at the other end as to what should be done forthwith. So I don't think there is any escape over here. This is the way forward, and the more sophisticated it gets, the easier it will be for the physician or the consultant to be able to monitor the patients in a very intensive manner. And I'm not talking just about one individual report coming from a system, but I'm talking about multiple leads of information being fed into one particular doctor's mobile so that the doctor is able to monitor this with great intensity.
Okay. Thank you, Dr. Chatterjee. I must say we had a very extremely useful day. We have learned a great deal, and we are very much indebted to the panel members who have discussed the future of healthcare from many aspects. Not just about the digital smart hospitals, which we covered in the earlier two panels, but regarding the policy reforms that are required to implement the digital smart hospitals, which this panel was all about. First, I would therefore like to congratulate all of you on such a successful event and such a fruitful discussion. I would also wish to thank all our very energetic and knowledgeable moderators for the capable way in which they have steered this conversation. We are indebted to you. Our esteemed panel members, thank you. Many of you have set aside time from their busy schedules to be able to participate in this, but they have all come and they have given us excellent thought-provoking insights. Thank you once again for that. So we do have a technological enablement, digitalization and automation which are affecting the industry today in profound ways. Healthcare delivery is no exception. So we look forward to have this conversation more, and I hope through this conference we could bring forth the need for digital hospitals for the future. In closing, I would like to take this opportunity to thank our partners. They have been a pillar of support to make this conference a reality. Bluestar, where Mr. Sangam, Mr. Rao and Mr. Jana, they gave their input on importance of HVAC, and Polycab India, Mr. Shashi Amin for his insights on fire safety, Diversity, Mr. Himanshu Jain, who gave us who gave insights into the importance of hygiene, and Sir H.N. Reliance of Foundation Hospital. Last but not the least, I would like to thank the Healthcare Radius team who tirelessly worked hard in the past few days to make this conference a successful. Before I say goodbye, I would like to make an announcement. We'll be organizing our next conference, Embracing Healthcare 4.0, on 27th of August. Apart from this, ITP Media in the next quarter will be hosting Manufacturing Today conference and awards on 17th of September, IGEN Design Forum on 29th of September. We look forward to see you all then. Thank you everyone once again for making this conference a great success. Thanks.
Thanks, Sujata.
Thank you very much.
Everyone. Thank you so much.
Thank you.
Good to see you. Yeah.